first presentation this morning is going to cover the state-mandated topic of domestic violence. There are actually individual topics that are required to be covered, and those will be covered by our two presenters. We have Suzanne Harrison. Dr. Harrison is currently retired from Florida State University College of Medicine. I'm sure she's very pleased about that. She's been very much involved in family medicine and rural health programs during her clinical career. And she's a frequent lecturer for the FMA on these topics. We also have Robin Thompson here, who is an attorney. Obviously, the interplay between attorneys and physicians is really important in this particular area. She's the executive director of the Survive and Thrive Advocacy Center, a nonprofit agency founded in 2015 to assist survivors of human trafficking. She's also an active member and co-chair of the Social Services Committee of the Big Bend Coalition Against Human Trafficking. So rather than take up any more of their time, I will leave the program to them, and I'll be back to help with the question and answer when we reach that point. Thank you.
Good morning, everyone. It's great to be with you again, and really wonderful to be presenting once more with my friend and colleague, Dr. Harrison. I'm Robin Thompson, and we are here today to talk about domestic violence. One of the things I do want to add to what Dr. Edwards said, and thank you very much, Doctor, for the introductions, is that I've also worked in this field of domestic violence for almost 30 years now in terms of public policy and advocacy. And that's who we are. That's more of who we are. You can see that we don't have any disclosures to report here, and that, as Dr. Edwards said, we do meet the requirements for the state of Florida licensure credits in this area. So, and Dr. Harrison, we're going to be doing what we call a tag team. We complete each other's sentences. We've done this a few times, so we'll be popping up and down. We look forward to your questions, by the way, at the end of the program.
Thank you, Robin. I'm so happy to be with you, all of you here today. I'm Suzanne Harrison, recently retired, and very happy about that. And I just want to talk a little bit about why this is such an important topic. I know that it's state mandated by the state of Florida, but I think that as healthcare professionals, we are really the first to perhaps identify a victim who's been impacted by abuse in their lifetime. And really, in the context of a clinical encounter, we have a unique opportunity to develop a trusting relationship where they might actually disclose the details of their life and what's going on. So we need to trust that and realize that it's the gift that it is if a patient decides that they want to trust us enough to disclose what's going on. We also know from looking at the research and really combing over what happens when people do choose to disclose that we can have improved health outcomes if we know more about what's going on in a patient's life, and really better adherence to treatment plans, because then they become shared decision-making plans. And so that's really part of the reason that we think this is so important. So you want to do this?
Our learning objectives today, as mentioned, is exactly what the law requires us to do. So you get the credits. We're going to talk about what domestic violence is, or intimate partner violence is what we're going to refer to it more today. We'll talk about prevalence. We'll talk about the screening, what's expected of you in the healthcare setting, indicators, of course, the numerous impacts on a victim or survivor's health. We'll also talk about the laws, your responsibilities under the laws in terms of reporting and the like, other laws that are available and programs to help survivors. And we'll also talk about the resources. So what is domestic violence? One of the most important things to remember about domestic violence is that it is a pattern of assaultive and coercive activity. And as a lawyer, as a good lawyer, right, standing up here talking to you, I will talk to you a lot about some of the the kind of drawbacks under the law. So the law looks at a lot of these actions, a lot of this violence in a snapshot format. And of course, the law is really specific about what it looks like. So that when you see this power and control wheel, which I'm sure many of you might have seen before, you'll understand more how the pattern of domestic violence, the pattern of assaultive, coercive control is really what you look at. And you have the ability to use that as you do your jobs, as opposed to the law, which only looks at snapshots of activity, perhaps over time, but usually just an incident by itself. All of the things that are up here on this coercive, if you will, the power and control wheel, talks about physical injury, psychological injury, emotional abuse, using the children, using tactics of control and coercion, things that over time clearly indicate what I said before, a pattern or a video of control. One of the things that we see even after, and I'd say especially after there's, somebody leaves a domestic violence or intimate partner relationship, you also see continuations of this. So we never think that when someone's left that it's ended. So you see numbers around stalking, deprivation, again, using litigation as a form of control. So know that this is one of the most important things for you all to see, and you'll get those snapshots and those pictures over time. The other thing that we're going to do today, which might be different from what you're used to if you've ever had this course before, is we're going to talk about other aspects and what we call the continuation, or the continuum, I should say, of abuse. And that's neglect, violence, and abuse over the lifetime. This is such an important concept because what I've seen over the decades that we've been presenting and working in this field is that one form of abuse or vulnerability or injury can really layer on, can intersect with, can continue, can reinforce abuse and its continuation over time. So we'll be talking about intimate partner violence. We'll also give you a little bit of information about child abuse, elder abuse. In fact, I will just as a footnote say, Suzanne, when I was presenting on this course in Palm Beach County, a physician came up and said, "Why aren't you talking about elder abuse? We're in Florida. We really need to talk more about this, the prevalence of this issue, because of the sort of misconception that it only applies to younger people. It definitely happens in terms of our elders and any kind of abuse in the household." We'll also include concepts of dating violence. So for people who aren't married, but also know that there is that kind of violence. The other thing to realize is that sometimes people are persuaded as well by the cost of this. And we know that intimate partner violence, domestic violence over the lifetime, when you look at the cost of that violence to workplaces, to the justice system, you're talking about an impact of over $3.6 trillion, and that a victim, just on the incidences of domestic violence, can have an impact of over $100,000 out of pocket over that person's lifetime. So we know talking about the lifetime impacts is really important. So Florida law does define domestic violence, and it talks about it in a really specific way. One of the things that we do, as I mentioned, is talk about domestic violence, dating violence, and other forms of abuse and neglect. And that is in turn what Florida law talks about. And the statute, really, if you think about it, the statute is specific. It talks about violence committed by someone in a household against another person in that household, those who are related by blood or marriage, or residing together as if a family. And when you think about that definition of domestic violence does exclude sometimes people who are, abusing psychologically, or might be also neglecting a person unless it's a vulnerable child or adult.
This is the tag team part of it. So what I want to do is provide for you a framework of the different types of abuse. Now, this is not new material to most of you, but I just want to make sure that we're all on the same page before we begin talking about patient care and statistics and things like that. So I hope that you could read this from where you're sitting. Abuse is really any willful or threatened act by another person, and it can take many forms, as Robin was describing earlier. Neglect is really that failure or omission on the part of a caregiver, most often impacts people who are being held against their will, children who have an inability to make decisions for themselves, vulnerable adults, and some of our older adults. So that's most often when we see that. That doesn't mean it can't happen to other people. Exploitation is really the deception, fraud, coercion for the financial gain of another person. So we see that happening with trafficking victims. We see it happening with elders more commonly than other types of people. It can happen with anyone, of course. And a vulnerable adult, for the purposes of defining it, is any adult between the ages of 18 and 60 whose cognitive or physical abilities are limited, making it difficult for them to understand and consent. And then sexual abuse and assault is really defined as any sexual activity, which can include pornography, sexting, videos, messaging, and just really anything, is really defined as any time where consent cannot or isn't given. And so that can apply to a lot of different things, certainly children, some elders, vulnerable adults, and then, you know, a lot of our trafficking victims really don't have an ability to consent. They have absolutely no control. I think I messed up. Sorry about that. Okay, so we're going to talk about prevalence next.
So one of the things that we talk about in terms of Florida is what is the prevalence, and here are your statistics. So we have over 100,000, 107,000 reported incidences of domestic violence. And I should say too that domestic violence in Florida is defined more broadly than intimate partner violence. So we are talking about that broader kind of violence, child on parent, parent on child, sibling on sibling, any of those kinds of familial kinds of violence that you think of as well. So, so domestic violence, 50% or more perpetrated by spouses or cohabitants. And Florida law, in terms of reporting and uniform crime reports, isn't great in defining this. So I would love much more information, but we know that at least half of that number is around partners. Almost 200 people were murdered, homicides in a domestic violence situation in 2020. And again, the statistics are good, but I will tell you that does not include suicide. So if you sometimes think about some of the horrific domestic violence homicides in your jurisdiction, often you might see murder suicides. If it was a murder suicide, if it was a familicide, that suicide portion would not be included in this definition, nor would what I used to see. I'll never forget in Volusia County, the medical examiner one time reported seeing a number of women in terms of the autopsies with a kind of typical, what she thought of as a typical chemical cocktail in their bodies where they committed suicide, and they saw signs of injuries in various forms of healing before the woman died by suicide, and really started to conclude that there are some cases where victims exit relationships by suicide. And we certainly see that in Florida, but that would not be included as a death in these cases. We also see a large overlap of sexual violence and rapes, but again, often goes unreported, as well as cases of stalking. Only 63,000 of those 107,000 reported incidences, 63,000 arrests occurred. And of course, in our justice system, again, I mean, I don't know why I'm talking about being a lawyer, but as a thing I'd have to say is that the justice system, especially the criminal justice system, it's good that it's there, but it's not the place you go to resolve these issues. And of course, that's why we're here today. But this is your backdrop. So in terms of intimate partner violence, what we always need to mention too is some of these lifetime prevalences. Very often I refer to victims as women, men as perpetrators, but that's not at all to say that's universal. We know that women are also perpetrators of abuse. We know that abuse also, and intimate partner violence, I should say, happens in same-sex relationships as well as in heterosexual relationships. We don't know as much about those, and that we know that this includes both all these things, the psychological violence, the stalking, and the sexual violence with, again, like in sexual violence, you can see the statistics here, 1 in 5 women and 1 in 12 men see this perpetration.
I'll try not to turn it off this time. So I want to talk, we talked earlier about how we were going to talk about abuse across the lifespan. So we're going to talk about what happens and how prevalent child abuse is. So it is estimated to be 1 in 7 children in that short span of their lifetime, which is just way too many, right? It's just way too many kids are being abused or neglected in some capacity. What's important to remember about this is that we identify risk factors and protective factors for those kids so that we can help to mitigate, excuse me, some of the adverse impact of that abuse and violence that they're either enduring or observing in the home. What we do know is that when children experience adverse traumatic experiences during their childhood, there is a lifelong health impact. And so we'll be coming back to this in a moment, but there are a whole host of diseases and conditions that happen in adulthood that are really the result of having had adverse childhood experiences related to a trauma of one sort or another. And with those comes an earlier death rate with these kids. I've listed some of the risk factors, but I'd also encourage you to think about the protective factors. You've got protective factors in the individual. So those kids that seem resilient are able to problem solve. Protective factors in the home, if you've got one parent or one caregiver who can provide nurturing and help the child to escape that situation. You've got community factors, and then we need to work on the overall stopping the cycle of violence to really have a huge impact on this. Is this yours or mine? Still me. Sorry about that. We're used to both standing up here. I don't have anything, I promise. It's just early morning and I haven't had enough coffee. Okay, so let's talk about teen dating violence for a moment. And I know Robin mentioned it earlier, but it is so important that we recognize the impact that this has. We have millions of teens that are impacted by dating violence or experience dating violence every year in this country. What we know is that those kids that experience dating violence, those young women who experience dating violence, are 6 times more likely to have an unplanned pregnancy than their non-abused peers. What do we do as clinicians? Sometimes we're a little judgmental about that teen that's coming into our office pregnant. And so I encourage you to really think about how that happened, why that happened, and really ask some probative questions that are going to assist you with caring for that young woman appropriately. So this is most often an unplanned pregnancy. I have seen adolescents who planned their pregnancies, so it does happen. But we need to understand more what's happening when we find an adolescent in our office who's pregnant, and think about, the backstory to that. Be really careful about asking why questions because they can be interpreted as judgmental, but really recognize that this is a huge impact. And when we survey adults who've been impacted by intimate partner violence, 11 million women reported that they had experienced dating violence before the age of 18. So these are kids who perhaps don't know what a healthy relationship looks like. Perhaps they're growing up in a home that has some abusive or controlling behavior. And so they don't have good role models for that healthy relationship. And so we can mitigate some of that by really thinking about anticipatory guidance and talking to these adolescents about what those healthy relationships look like, and really being open to talk about it.
Something newer in the field of understanding what domestic violence is something that I want to propose that we contrast to everything we've just been talking about. And that's something that's called adolescent domestic battery. Some of you may have seen cases of this where you see a child, say, abusing or murdering their parent. You see that kind of abuse, and we've seen it more and more in terms of kids getting arrested and then appearing in the juvenile justice system. And I wanted you to know about this, and this is some recent research and information that's been done about this thing called ADB, or adolescent domestic violence. As I mentioned, this is included in the definition of domestic violence in Florida, but here are some statistics to know about. One is that usually you see this activity happen child on parent. So you might see incidences of where a child has hit a parent, has threatened to hit a parent. We've certainly seen cases where children are arrested after striking a parent, throwing their phone. Even one case of throwing a cheeseburger against their mother, the parents called the police, right? Now, the problem with all of this, of course, is that as soon as you get arrested, even as a kid, you get involved in the system. So we're trying to promote among all of our juvenile justice and in our local runaway shelters and with local law enforcement and the judiciary is, please don't arrest these kids, but understand that there's dysfunction probably going on in the home. When we see these cases as well, let me go back and tell you a story. When I started working in the field of domestic violence, it was the early 90s. And what I used to think about were these little boys, essentially, that would, one of the shelter directors told me they'd run around the shelter and just, as 2 and 3 and 4-year-olds, just be screaming at their mothers and calling them, cussing at them. And it was like, wow, that child has learned abusive behavior from the father, right? And that's why the mother was clearly there as a victim. And that's what adolescent battery would look like. That's what abuse of the mother would look like. But that is not at all what's being borne out in the research. What's being borne out is that these kids are perpetrating and using violence, but not doing it for the means of control. There is a small cohort that is, but know that that is not at all the universal. Very often we're talking to these shelters and doing training around how to talk about taking away the phone so it's not used as a projectile, for example, and resulting in arrest. But know that ADB can be misinterpreted as that kind of activity in a home or that violence, which ends up in arrest. I also will tell you this, there are still the cases, and it's about 5% of all of the incidences of adolescent domestic battery that end up in serious or very serious injuries to the parent, which is, by the way, most often the mother. So that's something to know about too. In terms of violence against women globally, this is of course a phenomenon. When I was driving down here, I heard about how the women in Afghanistan now, not only is there higher suicide rates, but the violence against that's perpetrated now by the Taliban has just gone through the roof. That 1 in 3 women over 1 in 4 will experience IPV in their lifetime. 1 in 5 is the statistic that we use to help understand the prevalence of sexual assault in our college and university community. And we know that these overall are very high statistics. So, when we talk about the clinical setting, we know it's not a matter of if, but when you will see violence against women in your practice and any kind of intimate partner violence as well.
So just to follow up on that, I want to talk a little bit about homicides. So what we know is that 16% of all homicide victims in the United States are completed by an intimate partner of one variety or another. It could be, a spouse, a live-in significant other, somebody who was or is currently a partner but not living with them. But for women, more than 50% of homicide victims have been killed by a current or former partner. So that is just horrible to even think about that, a really common cause of mortality in women. Until recently, and we're going to talk a little bit about reproductive health in a second, but until recently, death by homicide was not counted as a form of maternal mortality if a woman was pregnant or in that postpartum period. Now that has changed a little bit within the last 18 months, but the reporting for it is just abysmal, and it differs from state to state, and it's difficult for people to know how the laws have changed and how they can change their reporting because we're really talking about trying to capture it on a death certificate at times. And it really has become a problem. So we're hoping to know more about this in the coming years. We're really just in the infancy of really understanding the impact of homicide during pregnancy.
One of the most, I think, extensive and important studies that was ever done was done by Dr. Jacqueline Campbell on femicide. And again, what we're trying to impart to you too, going back to that idea of you get to see a pattern of activity, maybe coming out in terms of a visit to your practice or to for a routine healthcare appointment, is that there are red flags to know that something might be afoot. Now, the presence of all of these is not a definite that a homicide or a femicide will occur, but what Dr. Campbell talked about these were many of the signs that you would see before. That includes access to a weapon, the use of a weapon, and also I want to flag as well that many of these can also be signs of a perpetrator's suicide. So threat with a weapon, the presence of a stepchild. There are a couple in here that we'll talk about more, but any act of separation during an intimate partner violent relationship is really one of the most dangerous times. So that act of separation can be any kind of, I'm leaving you, I'm getting a protection order. It could be, I'm getting a promotion, I'm going on a conference, I'm going to be away for 2 weeks. Anything that can represent a kind of separation from a perpetrator can also be a sign of increased or impending violence. In fact, I'll never forget this too. This was years ago when I went to see my physician. At the time I was working as the executive director of the governor's task force on domestic and sexual violence. This was when Dr. Lawton Childs was governor. So I went to see one of my for a regular appointment, and my doctor said, Ron, and I kept giving them materials to put up in the bathrooms and talking to them about this issue. And what he said was, I'm never going to just tell a woman to leave again, which is what I was doing, Robin. And he said, I see what happens. Unless I can provide her 24-hour security, I'm not going to say just leave. And it really impacted me when Dr. Steele said that, because something happened with a patient where he said that and the violence increased. So, and also I know Dr. Harrison just talked about the increase of abuse during pregnancy.
So back to elder abuse as we go through the lifespan and talk about abuse. I want you to think about elder abuse as a more comprehensive notion. So most of us think that we know what we're talking about when we talk about elder abuse, but some of these folks that we're caring for have also experienced other forms of abuse during their lifetime. And they may even be with the same controlling partner into their elderly years. And so we are also seeing domestic violence in those older adults. We are sometimes seeing them exploited for financial reasons. We're seeing a lot of neglect. We sometimes even see sexual assault, and I think there have been reports of trafficking now in older adults. So keep your your mind open to the possibility. When you identify abuse, you don't necessarily know the backstory. So really think about all of those questions, how to interview with a dyad, how to interview that older adult by themselves so that you can get more information. We do know that this is really common. The National Council on Aging estimates that 1 in 10 Americans over the age of 60 will be abused, and that almost 5 million older adults are abused annually. There are risk factors that we can identify. Of course, that doesn't mean they're being abused, but it does mean that we need to be paying more attention. So older adults who are socially isolated, maybe they're living in a retirement community, but they're, isolating themselves in their little apartment. Maybe their spouse has died. Maybe they require some care by people that are not well known to them. So that social isolation puts them at risk for being exploited, abused, neglected. We also know that any kind of cognitive decline or mental impairment puts a person at risk. Perhaps they don't understand what's going on, or they can't clearly articulate it to someone they trust. So to get that cycle of violence to stop. And then, of course, anyone who has disabilities, depending on what they are, can put them at risk and make them more vulnerable. But really think about abuse, any type of abuse, just sort of, it can happen at any point in your lifetime.
I've mentioned this before, but know that most forms of abuse do go underreported. And that is how we, keep track of this in something called the UCR, the Uniform Crime Reports. That's a national as well as state and local reporting system. We know that by far it is unreported. So some of the best estimates show that half of it is reported. Some of the worst of domestic and sexual violence show that only 20% or less is reported. We know the prevalence is higher. And as I mentioned before, that when it comes to the LGBTQIA+ populations, these numbers are even less. And I would say too, any kind of vulnerable populations, immigrants and others, there's going to be even lower rates of reporting because of other consequences related to reporting. For example, I'll never forget, there was another story I'll just tell you at a courthouse when an immigrant woman actually went to get a protection order. She was undocumented at the time. She went to get a protection order and they actually called ICE and she was detained and slated for deportation as she was seeking help in this country. Now, the reason why it's distressing on any number of levels, right? She was there to get safety for herself and her family, number one. Number two, as she was a victim of intimate partner violence, she was also eligible for immigration relief. So that's why this problem of underreporting is so great and why you all are so important, because it's not going to go reported into the justice system, and it should go, I hope, reported to you all so there can get care. When it comes to COVID, we know that some of you, by a show of hands, did you hear about the reports of domestic violence going up at the beginning of COVID? Yeah, it was just like people were saying, it's just exploding. And why did that happen, right? There was isolation, there was social isolation, there was not availability of shelters. The justice system went into some sort of lockdown as well, a slowdown. We had unavailability of services. We had the shelters that usually would house people be also closed down. To this day, I had lunch with our local shelter director here recently in Tallahassee, and what she said was they're still trying to bounce back. I will tell you that even with all of those impacts of COVID that had to do with the isolation factor, that is still reverberating. We know that in terms of nonprofits and help and assistance, that COVID had a very negative impact in terms of donations, access to funds, and being able to continue some services locally. You might have seen this in your area, shut down, have not reopened yet because there simply wasn't funding to keep them going. The other thing we see is the huge economic impacts of COVID. And still now with the rising rates of inflation, the other costs of living, the availability of affordable housing, all of that has impacted the ability of survivors of any kind of violence to be able to be in our communities and be safe. That includes access to other kinds of support like healthcare. We know too that in the justice system, and it's one of those things, like we did this program online last year, right? Or the year before. So there have been silver linings. We have discovered that technology can be helpful, but we also know that technology can be isolating in terms of victims. And that's what I mean by things like court systems have developed supervised visitation, remote supervised visitation. But what that can look like is it can look like something that is very intrusive. An abuser can look inside a victim's home when they're doing supervised visitation of a child and see where they are, can locate them by looking out a window behind, say, a child during a supervised visitation visit. So there's all kinds of pluses and minuses to the impact of COVID, and know that at number one, we always see too that whenever you go into a local shelter, and I'll ask you to do this, go back to your communities and go see the people in your homeless shelter, go visit with the unhoused, and you'll find an increasing number and all the time of victims of domestic violence who were there, and that domestic violence was the reason for them becoming homeless. And while they're in shelter, increased rates of sexual violence happening. That's part of that overlap we've been talking about of abuse.
Okay, so let's talk a little bit about screening for domestic violence. So we'll start with looking at the guidelines. So I'm not taking you back too far, just a few years to the last time the United States Preventative Services Task Force really looked at these items was in 2019, well, 2018, published in 2019. And what they recommend is that we screen for intimate partner violence in women in their reproductive years. And then we either offer them the social services, or we refer them to those social services that they need to escape the situation if that's what they're looking for. And that was a B recommendation, so a pretty high recommendation. You all know what those recommendations mean. What is disappointing is that there's not enough evidence to support screening for violence in the elder population. Now, that doesn't mean we're not doing it. So I want to make that really clear. It means that there is not enough evidence out there to say that there is more benefit than harm in identifying that violence, because perhaps there isn't something we can do about it. And I'm not in any way advocating that you don't do it. I just want to tell you what the recommendations say. So let's talk about what we know about screening. So what we know is, and when I talk about screening, I'm talking about all individuals, anybody who walks in your office, not people that you suspect are surviving or have been victimized in this manner. I'm talking about all comers, right? So we know that just asking increases disclosure by about 30%. We know that patients want to be asked, even if they decide that they're not going to disclose. They want to know that we care, and they'll tell us that, even if they decide not to share. So we also know that they prefer direct questions. They don't want us to beat around the bush. They want us to ask directly so that they can choose to answer. It's really important when you're asking these questions, and I'm going to show you a few screening tools in just a moment, that we accept the answers that are given, even when we have suspicions that that answer is not truthful. We accept the answers that our patients give us, and that we don't argue with them or try to change their answer in any way. Just accept it for what it is. Survivors tell us that they prefer computer-based questionnaires. So if your office or your clinical encounter has an ability to put it on a questionnaire that they fill out on an iPad or tablet or something like that, that would be great. They also like paper questionnaires, but keep in mind you need to ask these questions in confidence so that there isn't somebody else around. I'll come back to that in a moment as well. They are okay with us asking them directly in the clinical setting, in the exam room with the door closed and nobody else being there, but that they prefer the questionnaires, which is kind of interesting because we have sort of gone to this let's ask them directly mechanism in most of our offices. But that's what they tell us. So let's talk about some of the screens. And I'm sure you've seen most of what I'm about to show you, but just to reiterate, there's a few screens that are evidence-based that I want to share with you. I'm not advocating for one over another. You can look up the stats on these screens, but I think any of them are effective, and you can also tailor them to fit your own clinical practice. So the HIT screen was developed by Dr. Kevin Sharon and his team in the 90s. And it has been expanded to work for men and has been tested in that setting. It has been expanded to several different languages, and there's an app. But it is basically this. How often does your partner physically hurt you, insult or talk down to you, threaten you with harm, scream or curse at you? So getting at those different types of violence that we talked about earlier. This is the partner violence screen that was developed by Feldhaus in 1997. And it's just the 3 questions. And I'm sure you've all seen this before. Have you been hit, punched, or otherwise hurt by someone in the last year? Do you feel safe in your relationship? A really common question in the clinical setting these days. Is there a partner from a previous relationship who is making you feel unsafe now? Getting at that stalking issue. This is out of Minnesota. It's called the HARC-C. And all of these questions are meant to encompass the last year. Have you ever been, within the last year, have you been humiliated or emotionally abused in other ways by your partner or someone else important to you? So all of these, the first 4 questions include that, or someone that's important to you. I really like this screen. Have you been afraid of your partner or someone else important to you? Have you been raped or forced to have any kind of sexual activity by your partner or someone else important to you? Have you been kicked, hit, slapped, or otherwise physically hurt by your partner or someone else important to you? And then the last question, has your baby or child seen or heard of any of these events? Really gets at that when children witness violence and understanding what happens to them. And then this is the Elder Abuse Suspicion Index. And I know that you all have a copy of this. I don't want to read all of the questions. It's really getting at that exploitation, neglect, coercion, fraud of older adults. And then the last question is for the physician to answer, not for the patient to answer. Really says elder abuse may be associated with findings such as poor eye contact, withdrawn nature, malnourishment, hygiene issues, cuts, bruises, inappropriate clothing, or medication compliance issues. Did you notice any of these today or in the past 12 months? And the other questions are really about, ADLs, medication use, financial coercion, things like that. And I think this is a really good screening tool for our older adults or anyone who is really being cared for another and requires a caregiver. So why are we talking about this? There may be some of you in the audience who say, I've heard this talk before. I've heard this talk from the 2 of you before. But the reason that we're talking about it is we are still missing it, as Robin was describing. So even with this training, we continue to miss it. We did a study looking at callers to the National Domestic Violence Hotline. And what we found was that most patients who had presented to a healthcare setting within the last year, only 40% of women and 27% of men reported being screened for domestic violence in a healthcare setting. Even worse, when they presented to the emergency department due to an illness or injury directly related to the domestic violence, only 27% of them were asked if their current condition was related to the violence. And I think that's just shameful. It's easy to miss, but we need to keep domestic violence, other forms of abuse on our mind, keep it in our differential when we're caring for patients, not just deal with the medical problem for which they are presenting, but try to figure out how it happened, mechanism of injury, mechanism or etiology of the illness, and really think about abuse as being on our differential. I did it again, sorry about that. Okay. So I want to talk a little bit too about screening for ACEs. And this is really directed at most of you who are in a primary care setting. So our pediatricians, our family physicians, our general internists, our geriatricians. So I ask that you sort of like approach these topics, any sort of screening tool, with kindness and patience to allow the patients to answer in a way that feels comfortable to them, not correct or redirect. Assume that all of the patients that you care for have endured some form of trauma in their past. I know I have. I can list several different traumas in my past, even some during childhood. And I'm sure that most of you in the room can think of things that have happened to you too. Remember, these impact our adult health as well. We can also care better for our patients if we know about that trauma. Now, if the patient chooses not to share, that's perfectly okay. It is their health care, but knowing and expecting that they have been traumatized in some way will help us to care for them more kindly, more compassionately, and have more patience. Some of the traumas that we could ask about are listed here. This is just an abbreviated list of things that could have happened from the ACEs list. Physically abused before the age of 18, unwanted sexual contact, domestic violence in your family of origin. Were you ever in foster care? Were you left alone for long periods of time? I see a spelling error there, sorry about that. Parents incarcerated. Did they see somebody or know somebody who was killed violently? Were they belittled or made to feel unworthy, either at home or at school? Good questions to sort of uncover those adverse childhood experiences that may give us some clues about why a patient's not responding to treatment. So let's move on and talk a little bit about signs and symptoms that you will see in the clinical setting. And we'll start with the stuff that is a little bit more obvious, you can get your head wrapped around it, right? So suspicious injuries. We all kind of know what we're talking about here, right? Obviously, anytime that history is inconsistent with the injury that you're seeing, right? So anytime it doesn't match up, they give you a story and you think, well, you know, when I imagine mechanism of injury, that just isn't possible. I want you to be suspicious. You don't know what really happened, and you don't know that it's abuse, but you do know that you need to ask more questions. Anytime that a patient has seen a gunshot, has, you know, been shot, so gunshot wounds, stabbings, I mean, we've all got that. We know that somebody else caused those injuries, and we need to medically care for those injuries, but we also need to report, which Robin will talk about later. But we also need to uncover some of the abuse and what's going on in the situation that landed them in that situation. Evidence of strangulation. Strangulation is a red flag for impending death or death by an intimate partner in the coming months to coming years. So take it really seriously. And it is a reportable injury too. And Robin will again talk about that stuff. Anytime you see a patient who has a serious head injury, think about how that happened, especially if they've had repetitive head injuries. I once cared for a patient who had such significant cognitive impact from repetitive head injury that it was just incredibly difficult for her to remember our shared decision plan and to follow through on it, because she just couldn't remember what the pills were. She would pick them up, she would come back in, her blood pressure would still be elevated. It was really hard for her. She knew she wasn't remembering, and it was really, we had to devise this plan where she could come and sit in the office every day, have her blood pressure taken. My nurse would talk with her, find out what was going on, and we slowly weaned her off needing to be in the office setting. I didn't have to see her every day, but she needed that contact as a way to remember. So think about that. Think about anytime you see a patient who has ruptured teeth, a facial fracture, maybe they have a ruptured tympanic membrane. Just don't automatically assume broken teeth mean poor dental hygiene and this person isn't taking care of their mouth. Think about how that happened, right? Especially if they're a young person and their teeth should be young and healthy and not breaking. Look at bruising, burn patterns, bite marks. You may see fingertip bruising on the inner thighs as evidence of sexual coercion or assault. Doesn't mean that's what it is, but we owe it to our patients to ask those questions. You may see multiple injuries in various stages of healing, as Robin was describing. And this just, this is a situation where the patient either is very clumsy and is injured all the time, or somebody is injuring them or abusing them physically in some manner. And so ask those questions. Keep it on your differential. You may see in the chart, if you have an electronic health record, which we all should these days, that a patient's been in several times for various falls, fractures, sprains, that sort of thing. You have to start thinking about how that's happening when there's a repetitive pattern like that. I find that I am more easily able to identify a patient who is in a controlling sort of situation, which I think all by itself is bad and abusive, just full disclosure here, that I'm more able to identify those patients because of behaviors that I might see. So a partner who comes with the patient, who won't leave the patient alone with me in the exam room, or who interrupts them or corrects their answers, or if they do leave, is calling on their cell phone or interrupting them with text messages. And so I think those controlling behaviors that I see are very worrisome. And so those are patients that I am going to somehow get them away from their partner if I can, so that I can ask more questions. I don't know what the story is going to be, but I know that I don't like what I'm seeing. If you're examining a patient and they are fearful, particularly with a genital exam, that is a red flag that there has been some sort of trauma in the past. And it's time to stop what we're doing, make sure that the patient knows that they can stop you at any point, and get them dressed again, and then explore what just happened and make plans for whatever. If it wasn't urgent, if it was a screening exam or something like that, make plans to do that at another time after they've shared their story and they feel like they can trust you. You might also see patients who have a significant delay in seeking care. Perhaps their abuser won't allow them access to care. Perhaps we've had a natural disaster or a pandemic like we are hopefully on the tail end of. But we saw this with Hurricane Katrina too, where people couldn't get to care. But perhaps they've got an abuser who's not allowing them to seek care, or they're embarrassed, or they think that it'll heal on their own. Just try to figure out the why behind that without asking a judgmental question. Why are you, why didn't you come earlier? Which can come off as something that's very judgmental and shut a patient down. I'm used to a different remote that has the go button in that spot. I apologize. So let's talk a little bit about patients who have a poor response to treatment. So these patients, excuse me, can be very challenging sometimes. They're not responding to treatment. They have adherence challenges. Or they overuse services, right? And so they're there all the time, like the patient that I was just describing. Perhaps for a very good reason. Perhaps it's a cry for help and they're ready to disclose what's happened to them, which is what happened with the patient that I was describing. We finally got to the bottom of what was going on with her. But patients who are in abusive situations, particularly if it's prolonged or severe, they might not respond to medical treatment. They might not be able to pick up their medicines. Even if they get them, they might not be able to take them because their abuser may not allow it. They may not be able to keep appointments. They may not have transportation. So my message is to encourage you to think about what's happening that causes these things and to not be blaming the patient for what's going on. There are mechanisms that we can use to reach out to our patients, whether it's telehealth, a telephone call, to find out what's going on, to make sure that they get the medications, and to really not make the assumption that they're taking them when their blood pressure is still elevated or their diabetes is out of control. Perhaps they never got the medicines. Perhaps they weren't allowed to take them. Perhaps they have a significant number of ACEs, which makes it difficult to treat their medical conditions. These patients also have a higher incidence of mental health issues, also making them at times more challenging to care for and to provide them with those options. So they are more likely to present with depression, and postpartum depression is particularly high in this population. These patients may present with self-harm behaviors. They have an increased incidence of suicide, as Robin was talking about. They also have a much higher incidence of substance abuse, and I'm going to come back to that on the next slide. They may have anxiety disorders. Patients can develop disordered eating as a way to mitigate their stress and instill an ability to control something in their lives. So sometimes what they're doing, even if it's an adverse health effect, is really a coping mechanism for these patients. And it's important to understand that because we're going to approach them differently. Some patients who've endured prolonged or severe violence, particularly those who've been held in captivity, like in trafficking situations, or were sexually assaulted as children, can have PTSD, sometimes as bad. Their PTSD can be on the level of victims of torture because their violence has been so severe. And then cognitive injuries in the patient that I was describing with repetitive head injury. And her story, just to add on to that, was that she'd had repetitive head injuries, one so severe that she was in a coma for several weeks. And her ex-husband, who she was still married to at the time, was the perpetrator of this violence. And he was the one who put her in the hospital with the head injury that induced the coma. While she was in the coma, he was able to get custody of all of the children. So she was the victim and he got custody of the kids. Still makes me angry to this day, and that was in the 90s. So I said I'd come back to substance abuse. This is such a problem for many of these patients that are in these just intolerable situations. Like I said, they can use drugs and alcohol as a coping mechanism. Sometimes abusers will use substances as a way to control their victims and to make them more compliant with what they want to have happen. That happens a lot in victims of trafficking. It happens a lot with victims of child abuse. And it can happen with elders as well. So not uncommon. I took care of a lot of patients who were pregnant during my career. And so what I saw was patients who continued to use substances, who continued to smoke during pregnancy. I saw a much higher incidence of domestic abuse of many different sorts in that population of women. So most women who are pregnant want to be as healthy as possible, right? If they can't be, and they continue to use drugs, alcohol, tobacco, whatever it is, it means that there's something else in their life that is taking priority over trying to get off of those substances. And so, you know, it's our duty to ask them questions about it. So if somebody can't quit smoking, if they can't quit drinking, if they can't stop using drugs, I'm going to explore more what's going on in their life to see if I can have a better understanding about why that's happening and maybe get them the help that they need. You may see patients who are presenting with withdrawal symptoms. Perhaps you work in an emergency department or an urgent care center and you see patients who come in with withdrawal. Well, we know that stems from addiction and not being able to get the drugs that they are addicted to. But think about how it was that they became addicted and what's going on in their life, because I would say almost universally, those patients who have addiction problems have traumas in their lives, and we owe it to them to explore that more thoroughly. Okay, a moment about reproductive health. So what do we know? We know that people who don't have access to contraception, who can't use condoms, are more likely to get sexually transmitted diseases, right? That is kind of a no-brainer. So why don't they have access to contraception? Why don't they have access to condoms? What's going on in their life that puts them in that situation? For the kids that are in foster care, the kids who run away from violent homes, they may end up homeless and on the streets. And they may engage in survival sex as a way to get enough money for food, find shelter, anything that they might need. They may be at risk for being trafficked by another person. And so really think about the mechanism behind that. If you see a patient who comes in who has either a hesitation when you ask a question about how many sexual partners they've had in the last year, or they give you a number that is just almost unbelievable, take a moment in your mind, step back, think how that happened. Was this by choice, or were they forced or coerced into that activity? And your approach will be different depending on how you frame those questions, how you reframe them and reframe them again until the patient is comfortable. If you see patients who have genital injuries, these are more likely to happen with victims of child sexual assault and victims of sex trafficking, particularly young people. And these can be horrendous and often require extensive surgical repair. So when you see those things, make sure that that's what you're thinking in, that you've got those types of abuse in your brain as part of your differential so that you can offer them the appropriate services and get them the care that's needed without re-traumatizing them in the clinical setting. It is so easy for us to re-traumatize our patients without even realizing that it's happening. So just take a breath, take a moment, and let them talk, and then get them the resources that they think they need while you get them the medical care that you know they need. I mentioned unplanned pregnancies before when I was talking about teen dating violence. So I'll just remind you again that adolescents who are victims of dating violence are 6 times more likely to become pregnant during those teen years than their non-abused peers. So think about that before reacting to the fact that you've got an adolescent who's pregnant. They often don't have access to contraception. That is becoming more of a problem lately. And when there's an unplanned pregnancy, we have an increased rate of both live births from that unplanned pregnancy and abortions. Now, in our current situation where reproductive rights are being limited in some states, we're really going to have to be alert to this sort of thing and care for our patients appropriately, find all of the resources in our communities to refer these patients to, depending on what their needs are. And then you can have complications of pregnancy. If you are a person who's, caring for young women in those reproductive years, whether you're a family physician who does OB, a pediatrician who does adolescent medicine, or an obstetrician who's delivering babies, when patients come in with preterm labor, abuse needs to be in the top 3 of your differential. And the same thing with a placental abruption. Yes, you need to care for the medical needs, but you also need to understand the etiology of how they got there and make sure that abuse isn't part of the situation and you're not sending them inadvertently back into that abusive situation where they're going to become abused even more. Okay. Boy, I took all these slides, didn't I? So let's take a moment and talk about neglect. And again, this happens most frequently in children, elders, and people who are being held hostage, like victims of trafficking, who are reliant on others for their care, for all of their basic needs. But you may see patients who come in with malnutrition, or they are dehydrated when they come in. And so you should be thinking, how did this happen? Why are they malnourished? Is this, that they don't understand, they're not eating enough, their calorie intake's not high enough, or they're food insecure, or is somebody limiting their food intake? Is somebody not giving them breaks to get water while they're working in the fields all day, so like in a labor trafficking victim? You may see patients who have poor dental hygiene. Perhaps they don't have access to dental care. Perhaps they've got a lot of broken teeth from previous injuries that were never repaired. Medication misuse, really common in children and in elders. So when you see this, think about why that's happening. Is it the patient? Is it the caregiver? Is there some miscommunication? And then sometimes, medication misuse or compliance issues, adherence issues with medications can also be because we didn't communicate very well with the patient and they really weren't agreeing to take that medication. They were agreeing to tell you yes so they could leave as quickly as possible. And we need to keep that in our mind because, unless the patient's really agreeing to it, they're not going to do it. We need to understand that. So in that case, it's our fault, not the patient's fault. Pressure ulcers, obviously, in those with any diminished mobility, and that can happen at any age. And they might not be provided with medical care because their caregiver wasn't allowing them to come in, wasn't bringing them in. So let's talk about the impact of abuse on adult health. So I promised this earlier. So we're going to go back to our ACEs grid and just talk about how this happens for a moment. So there's an impact on neurodevelopment when a kid is experiencing some sort of adverse trauma in childhood. You know, a parent is incarcerated, they see their mother killed by an abuser, they see somebody shot outside of their home in their neighborhood. You know, I mean, this can be anything, really. You know, this isn't just abuse in the household and the child being the victim of abuse. It's really very much more widespread. But what happens is it changes their telomeres, and it really impacts the way they think and their ability to problem solve. And so they're more likely to have risk-taking behavior that might be, you know, sexual behavior, it might be, you know, assault on another person, but they're using it as a coping mechanism for the kind of traumas that they've experienced. We need to keep that in mind. So again, not blaming our patients, but understanding where they come from and how that happens. What we know that happens with this process, and I'm not going to go, we could do a whole session on this, but for the purposes of today, it has a huge impact on adult health, with lots and lots of diseases impacted and increased in their prevalence in this population, these kids who've experienced traumas during childhood, and they do have an early rate of death. This is just simply a list of the types of conditions that are increased with adverse childhood experiences. It is not meant to be exhaustive, but I will just tell you that, you know, the number of patients with heart disease and the number of patients with cancers in those patients who have experienced ACEs in their lifetime versus those who haven't, way higher in kids that have had childhood traumas. So we need to think about it. We don't necessarily need to ask about it in the moment that they're having an MI, but we need to think about it in their aftercare and how to care for them, because the more we can get them to disclose, the more that we can get them to the resources that they need, we might be able to mitigate some of the effect of those. We need to engage behaviors. All right, this is you.
Okay, that's a lot, isn't it? I mean, we are giving you so much information at high speeds. And I think one of the things that's so different is what you just also touched on, Suzanne, is the overlapping of victimizations and what we can do. So we'll be getting to what you can do. And I also want to tell you that we have a video to show that will help illustrate some of the points that we're making, and I hope that will be something that you'll enjoy. One of the things that we also talk about is the wider contextual social consequences of this. One of the things that I see now as I work in the field of human trafficking, assisting survivors, and working in our community is some of the social consequences of both this kind of violence as well as trafficking and their overlaps, which is the increased risks of incarceration and homelessness. They go through the roof, of course, because of the vulnerabilities that happen as a result of this violence. Economic dependence. So that's economic dependence that could keep somebody in a violent relationship because they have no other choice but to leave, especially again now with the cost of housing and the cost of living. And then we also see something called forced criminality. So what I saw at the beginning of the pandemic was the first set of calls that we got were from women who were being sex trafficked by their abusers. And so that is a form of forced criminality. It's not the only kind of forced criminality, though, that happens. So again, being careful of the judgment that we have to understand if someone is coming to you with a criminal record or describes having been arrested or, being, recently coming out of jail, know that that could be at the hands of a perpetrator who is forcing that kind of activity as a condition of staying in a relationship, having a roof over her head, being able to stay, or his head, in the same household with children. So that is clearly a way of forced dependence on the abuser, and then know that there's an impact on the performance of that individual at work or at school. One of the very first women that I met in this field was back 30 plus years ago. Her name was June. She was a nurse at TMH, Tallahassee Memorial Hospital. And what she described was eventually, she came to be one of the biggest spokespeople on this issue in our community. And what June would talk about was how at home she was abused physically, emotionally, but at work she shone. She was the high performer. She was the one who got respect, but she was also being socially isolated constantly by her husband, who said, no, we're not going to go to that social event. We're not going to go to the Christmas party. We're not going to do those things. And what June talked about was, as opposed to here, at that point, he was not making her miss work. He wasn't cutting up her uniform. He wasn't slashing her tires so she'd be late, but like some abusers do. He was wanting her to stay working, but he was kind of, king of the castle at home, and very, very, very abusive. So I can't remember if that's yours or mine. So when you talk about children witnessing violence, yes, thank you. This is a sticky topic, and I'll tell you why. Because over the years, there's been research to show the clear impact on witnessing of violence, the ACEs that Suzanne just talked about. It's a huge impact. Secondly, the law has sort of kept up and not kept up with the impacts. So a child can witness violence in a lot of different ways. A child can be with an eye shot, can be with an ear shot. A child can actually be being held by the parent while the other parent is physically attacking that parent, right? So there are all different kinds of ways that a child can witness a violence and be impacted by that violence in degrees and intensity. The problem that we've seen over time in the state of Florida, that I saw way back in the 90s and is still going on, is the system response to that violence. Does it proportionally respond to what the child has experienced? Does it get an accurate picture of what's going on? Or is there a huge hammer that comes down when there's been, say, violence within earshot, but not a severe kind of violence is actually being impacted when being held or being, kind of between two individuals when there's violence? But know this, regardless, there is an impact on that child, mentally, physically, obviously with the ACEs that Suzanne just described. We know that when there's spouse abuse, there's so often child abuse at the same time. And those numbers go up when there are stepchildren, non-biological parents in the household. And usually what I've seen that look like is stepfathers or boyfriends that are living with non-biological children. In Florida, when you call the hotline, this is for the abuse hotline, and you know that there has been violence perpetrated against, or a child has witnessed violence, that is what the state of Florida wants you to report. I can tell you, after we've done this lecture in the past, we've gotten calls from physicians that said, I will absolutely not do that because it has endangered both the parent and the child. I'm telling you what the law is, and I'm telling you what your peers have responded to us at, and all we can do is go back. And after that one, if you remember, Suzanne, I called the hotline and said, this is the situation, and they said they still have to report because it can have an impact on that abuse victim, and which is also maybe often the parent as well. Physicians had made a different ethical choice when it comes to making that report. So I think you're back.
Okay, so let's talk about how we talk to our patients and how we get at some of this when we do suspect abuse. So I'm going to start by just talking about the very real barriers that exist. I know this is really hard work to do. These are hard questions to ask, and not every patient is ready anytime you decide you're going to ask, and we're not always ready to ask the questions. So I think that's okay. We just need to recognize that there are barriers. We have very brief interaction times with our patients, and sometimes that's really not long enough to really develop trust, particularly if you're in a setting where you don't have continuity with your patients. But for those of us who do have continuity, perhaps we can be the ones that are asking the patients the questions. And so that really does make a difference. They're also very resource intensive, but I'm here to tell you that this is not your job alone. We are just a small piece. And so we connect with other people who can help provide resources to our patients. I've had really good luck with calling the local domestic violence shelter, and in Tallahassee, that's Refuge House. Just want to give them a little bit of a plug here. They have been great about coming to the office and talking with the patient in person. Back door to the clinic, let them in. Even if the abuser's in the waiting room or in the parking lot, they are willing to come and talk with the patient, create a plan with that patient, even if they're not choosing to leave the situation at that time. Again, we don't encourage people to leave. I'll come back to that later. The patients also have really complex needs. They are often from marginalized, oppressed groups of people. They don't know that help is really available. They don't trust that help is going to be provided to them. And so we can't expect them to disclose. It is, after all, their life and their choice about whether or not they tell us the backstory. We also live in a culture that isn't always conducive to acknowledging these sorts of things. We still live in a culture where there's gender privilege, and let's not pretend like it's not there, right? And so that can impact whether a patient is ready to leave their abusive partner. We also are in, yet again, another time of economic destabilization where we're going to see abuse going up, and we need to be very aware of that. So perhaps in patients that you've seen before and they seem to be in a healthy relationship, now all of a sudden they're not. So just because you asked the question before doesn't mean that you're not going to need to ask it again. So let's talk, this is you.
So one of the things that I have also observed over the years in doing these programs is how much you all are incredible helpers and how you want to do whatever's necessary to help someone in these situations. A caveat to that kind of help, though, is the sort of rescue mentality that I see a lot in the anti-trafficking movement, the sort of coming in, riding on the white horse, I can save you, I can fix you, there's a magic bullet, I know this is all you need to do. But know that, first of all, that's totally not favored by survivors. What they end up saying is, I saved myself and I had people helping me. So that is really a more kind of accurate mindset to what survivors are thinking and doing. Also know that they might not identify as a victim to any of these things. So if you're saying, oh, you're a victim of domestic violence, I think you should get a protection order, I think you should leave, or I think this is impacting your children as you're a victim of domestic, they might not say that. They might say, I'm being a good mother, I'm being a strong mother, I'm keeping my children under the roof, I'm feeding them, I'm getting them to school every day. So know that you might not get that identification, and it's important to realize that that's there. Also, excuse me, that someone disclosing even to you because you are perceived as part of the system. You might be part of a system that has resulted in that person in the past getting arrested. If there's been, say, mutual violence in a situation, that person might have been arrested and threatened by DCF to take the kids away. So even though it is not you know quite well that you are not a member of the law enforcement. That's not how you may be perceived. So know that it might take you several visits. It might take several people. It might take a different person in your practice to do something called really cultivating trust. And that's really one of the best phrases I could think of. What we encourage you to do is to try to cultivate trust and understand things like there may be a barrier of culture, of language, of experience that right now you can think about, how can I make a difference in my practice to better accommodate survivors.
I need this. Oh, yeah. Grab this. Okay. All right. All right. So this slide is really just a quick and dirty, easy approach to implementing trauma-informed care in your clinical practice. Now, again, this is another topic that could take a full hour, possibly even longer to talk about, but just a 3-step process. We have to create that environment where disclosure that is conducive to disclosure, where the patient trusts us. And as Robin said, it can be anybody in your office. Maybe it's not me, maybe it's not you, but maybe it is your nurse or the medical assistant or somebody else who really has a relationship with that patient, and the patient responds to them, and perhaps they can be the person who asks the question. But really emphasize confidentiality, ask permission to ask questions, to do physical exam maneuvers that are particularly sensitive, offer as much control as you can to the patient. It really doesn't take that much longer to do it this way. Yes, a little bit longer, and so you have to be prepared to do that, but really this is what it takes to create that environment. When we ask sensitive questions, we need to provide a rationale for why we're asking that question. It is really about their health. It's not a morbid curiosity about their life, right? So we're asking questions that are going to improve their health care. We're going to normalize our questions. We're going to explain that abuse and trauma are common, and we ask these questions of all of our patients so the patient doesn't feel alone, doesn't feel isolated, understands that there are other people out there who are also experiencing this. And then probably the most important thing is be prepared to respond effectively. Don't be shocked. Don't be surprised. Normalize and tell the patient, this isn't your fault. I'm sorry this happened to you. There are resources available. Be as kind, compassionate, empathetic if you can get there. And really make sure that you're providing the aftercare that they need, even if that's not with you. If you're in an emergency room or an urgent care center, or perhaps you're a subspecialist and you're not going to be providing follow-up, make sure they have an appointment before you let them go. And then identify any resources that the patient really needs to be able to deal with their situation. So this is a bit more detailed, but this is really the way I think about it. So I already mentioned normalizing our questions. I want you to really listen with an open mind and let the patient narrate their story in a way that's comfortable for them, rather than interrogating them by asking them a series of closed-ended questions. Be really open to letting them just tell their story and sit there in silence. There are studies out there that say that we interrupt our patients at about 23 seconds. Please don't do that in these situations. Let them talk. Avoid any biases. We all have them, right? And so what we need to do is avoid any cultural-based biases that we have. That means we need to identify them. We need to know what they are so that we can check them at the door to the best of our ability. If the patient needs an interpreter because you don't speak the same language, maybe you have a few skills in that language, but not enough to really effectively communicate, maybe it's a different dialect. So maybe you need an interpreter. If you do, make sure that that person is not connected to the abuse in any way. So if you've got a medical assistant or a nurse who speaks the same language as the patient, but they also know themselves outside the office, that is not the person that's going to interpret. You're going to call the language line. Don't let a family member interpret for them. Get somebody who's trained to do that, because we really want to effectively communicate with these patients, and we don't want to increase their risk of severe injury or even death leaving the office. And you can inadvertently do that. So just be really careful about that. And always, always, always don't ask these questions of your patients if you can't separate them from the person who came with them. So I didn't tell this at the beginning, but I'm just going to share this with you now. The way that I came into this work, I was still in residency, and I don't know if I can ever get through this story without tearing up. One of my very dear friends and co-residents was killed by her husband, who then shot himself. It's a Tuesday morning in January of 1991. I will never forget that. And, you know, Holly lost her life because she was in the process of leaving her abusive husband. And he came to the apartment one night and ostensibly to collect his belongings and shot her in the back of her head and then shot himself. And we found them the next morning when she didn't come to work. So sorry about that. This is how I came to this work. So this is a young physician, you know, with her life before her and was in that situation. So abuse can really happen to anyone. It can happen to us. And I want you to remember that. Anyway, all right, yeah, you want to say something? Oh, okay. All right, so let's talk a little bit more about confidentiality. I know that we've mentioned that many times. We'll continue to do that. Our patients don't necessarily know their rights. They don't know the limits of confidentiality. It is up to us to explain that to them. And sometimes to explain that before we ask the questions so that if they want to choose to not disclose, they have that option. I don't want my patients to lie to me, but if they're in danger and they feel like that's the right decision for them, I need to offer them that option. Say we've got a mom with kids who the kids are not physically being abused, but they're seeing the mom being abused. We want that patient to know that if she discloses to us, we may be a mandatory reporter. I want her to have that option before I ask the question. Yes, I want to get them help. I absolutely want to get them the resources that they need, but I also don't want to put them in danger, and I don't want any adverse events to happen because they got into the system at a time where, you know, say they wouldn't leave their abusive partner, and so the kids get taken from them. I don't want that to happen. And so that's a lot of what this is. And again, I know I said this before, but accept the patient's answers for what they are. Don't challenge them. We need to offer them every modicum of control that they can have.
And I'm going to do this one, the next slide from here, which is the one about who's at great at risk. We've talked about this already, but know too, just as Dr. Harrison said, someone could be at risk and be highly educated and be in a position of relative power in our society, and they could still be victims of this violence. Just in the interest of time for us to keep moving.
Yeah, absolutely. And I'll just mention that before I move past this slide, these are associations, not causal relationships. Okay, so we decided that we're suspicious. We're going to ask questions. How do we do this, right? How do we do this in a way that makes our patients trust us, that engenders that trust, that makes it feel safe, and they feel like they can disclose? So we're going to start with open-ended questions. None of these closed-ended questions with yes or no answers that makes it feel like an interrogation. You can follow up with direct questions. Patients appreciate that, but don't make that the entire interview. Assure the confidentiality repetitively. Just because you say it once or somebody said it at the front desk does not mean that the patient believes that, and they might need to be reassured regularly. And then again, don't pressure their disclosure. Remember that most abuse and neglect is missed because we didn't consider it on our differential. We weren't thinking about it, and that failure to recognize that and help them and get them the resources that they need can result in increased harm. And then obviously it cuts across everything. So I'm going to go through some of my favorite questions that I ask patients. Now, some of these are adapted from previous screens that have been published. Some of them are my own. Some of them come straight from some of those screens, but I've just bunched them together because I think they're useful. I encourage you to ask questions in a way that is comfortable for you. So feel free to take all of these questions and adapt them to your own style. So this is a really common way that I ask questions, particularly in someone that I'm just meeting or I don't know really well, or I'm worried, but I don't want it to be obviously a screening tool. So everyone argues. How do you settle disagreements in your relationship? Do your fights or disagreements ever become physical? And so that's an easier question, series of questions to answer. Has your partner ever pushed you? Have you ever done that to your partner? Would be a way to identify perpetrators. So if we're really going to stop this cycle of violence, we need to not just care for the victims, the survivors, we also need to identify the perpetrators. And some of these people were abused as children as well. So for those people, getting them help may actually stop the violence. And so if you can identify a perpetrator in your clinical setting, that is the type of person that will probably respond to resources. So I'd encourage you to ask. Do you feel safe in your relationship? Straight from the partner violence screen. Is there anyone from a previous relationship who's making you feel unsafe now? That's those last two questions. Is anyone forcing or coercing you to engage in any sexual activity that you don't want to do? Have you ever done that to someone else? Certainly lots of people not with intention, but we're really here to offer anticipatory guidance, provide our patients with resources. And so I find these questions useful. And I think this is you. No, it's not. Yes, it is.
No, you.
Okay. All right. It's me still. Sorry. We just decided who was going to do what earlier this week. So I already kind of talked about this, but I do think screening for perpetrators is important. You're less likely to identify a perpetrator if it's current abuse. So you're more likely to get somebody to admit to something if it's past tense, and then perhaps get them the resources that they need to kind of stop that kind of interaction in a future relationship or even a current relationship. Although I do have to admit, I have identified perpetrators in my clinical setting, sometimes friends of the family. And I ask a question and then I was obviously very surprised by the answer. Have to hold that in check, right? We're not going to respond. Got to put the poker face on while you say, let me see if I can get some resources to help you with that. And sometimes that actually works really well. So I think that's about it for that. These are a series of questions that you can use that link the symptoms that the patient is exhibiting or the signs to abuse. So in my experience, these types of symptoms are sometimes caused or made worse by another person or by stress. Are there any sources of stress in your personal life? Okay, all right. Excuse me. This type of injury is sometimes caused by other people's action. Is anyone hurting you? This type of behavior sometimes suggests problems with safety in the home. Is anyone frightening you? So you can link it directly to what you're seeing in the clinical setting. Makes more sense to the patient. They might respond favorably to that.
So the next slide is going to be that video, and as soon as I click on the video, it's going to start to play. So I grabbed this from you so I could
me out of the way.
So I could do the intro. So during COVID, one of the good things that happened was that funding came down from the federal government to the state and then to the local county, and we produced a series of 3 videos at our agency, which is the Survive and Thrive Advocacy Center, to really demonstrate ways to do telehealth visits for victims of abuse and trafficking. And this video will show Dr. Harrison with a woman who is depicting herself as a survivor of or in a current relationship where there's both intimate partner abuse and human trafficking. Again, to echo that, this is something that we saw and that around the nation was echoed, where domestic violence abusers were starting to force victims to do where they were being abused in the home to then start sex trafficking in order to economically support the family. We've shown this video a couple of times. I actually had these AHEC scholars one time say, did they give you permission to film this? It is so impactfully done. So we want to show this to you also to let you see everything that Suzanne was just talking about in terms of types of questions, creating a safe space, etc., and how she does an actual intervention with a patient. The second thing is to know that we use this to kind of show the pros and cons of telehealth, because when you start to do telehealth, you don't know if the abuser is just behind the person off camera, right? So how do you start to broach that and do it safely? And it is a huge concern. This does not necessarily go into. We don't have time today to go into all the pluses and minuses of telehealth visits when you have somebody who is a victim of abuse potentially doing that kind of visit. But we start to talk about it, and if only we had more time. But anyway, let's see the video.
Good morning. I'm Dr. Harrison, and I understand that you called for a telehealth visit today.
Yes, I did.
Can I get your full name and age?
My name is Shannon Lively, and I'm 20.
Thank you. And do I have your permission to continue with this telehealth visit? All right, thank you. Are you alone, or is there anyone there with you today?
I'm alone.
Okay, all right, thank you. What can I do for you today?
I think I'm having some problems down there, and I had that in the past, so I think it's happening again.
And when you say it happened in the past, what do you mean? What did you have?
I was diagnosed with an STD, but I don't remember the name of it. I just took some medicine and it got better.
Okay, I'm going to ask you a few questions about that, more detailed questions in a minute. But is there anything else you want to talk about today?
No.
Okay, all right. So some of my questions may seem a little odd. They may seem really personal, but it'll help me to put the picture together and get a better sense of how to best treat you, okay?
Okay.
All right, and if you feel uncomfortable with anything, just let me know, okay? So how long have you been feeling poorly?
Maybe like 4 days now, I think.
Okay.
4 or 5 days.
All right, thank you. And I'm just taking notes so that you know, so that I can keep track. This is my notebook. I'm not writing anything down except trying to keep track of what you say.
Okay.
So can you describe to me a little bit more about what you're feeling? You said it's been about 4 to 5 days.
Mm-hmm. I think I feel hot. I mean, I think I don't have a thermometer, so I may have a fever, I think. And I just like burning and itching down there. And there's like a little, I don't know what you call it. It's like a sore in the area.
Okay. And Shannon, do you have your cell phone handy?
Yeah, yes.
Can you make sure that it's turned off while we talk?
Okay. Okay. Okay.
Thank you. So you said you have a little sore down there. Is it on the outside or on the inside?
It's on like I don't know how to describe it. It's like on the, I guess it's outside.
Okay. Is it on your vulva, the area outside your vagina?
Yes.
The lips?
Yes, the lips.
Okay. And is it on the right or the left?
The right.
The right. And is it just one sore?
Mm-hmm.
Okay. And can you tell me what color it is?
It looks like my skin.
Okay. Is it red at all?
A little.
Okay. And does it have a little blister on it, or okay? Is it pussy? Is it clear?
I don't know. I can't tell. I think it was clear, but now maybe starting to have something.
All right. Have you had sores like that before?
The last time.
Okay. All right. And the medicine that you took the last time, do you remember how many days you took it?
No, like maybe a week or so. I can't remember.
Okay. And did you take it once or twice a day?
Twice a day.
Twice a day. Okay. Do you remember what color the pills were? Okay, that's all right. It's all right. And if I gave you some names of different types of STDs, do you think you would remember what they called it?
I just don't. Yes, you can try. You can
Okay.
try.
And these are just really common things. It's not that I'm suggesting that this might be any of them, but have you ever heard of a yeast infection? Do you think that's what it was?
Yeast infections growing up, and it wasn't that.
Okay. How about chlamydia?
That might be. I think I remember them saying there were two things.
Okay. How about gonorrhea?
I think that's the one.
And how about herpes? Have you heard of that?
I've heard of that. I don't know that I don't know if I've ever had that.
Okay. And then what about syphilis?
No.
Okay. All right. Well, so I think we're going to need to do some testing. Do you have transportation?
My boyfriend does.
Okay. And does he know that this is going on with you?
Yes.
Okay. All right. And are you comfortable talking with him about this?
Yes, he actually has the same stuff, so I
Okay.
do something for him too.
Okay. All right. Well, I can't prescribe medicine for him if he's not my patient. But we can certainly get some testing done, and he can certainly make a call, and I can see him in the same way on a different appointment if that's something he's interested in doing.
Okay.
But we do need to get some testing done, and there are ways that we can get both of you tested. Okay. So here's the part where I'm going to ask you some other questions. Okay. And I really appreciate the information that you've given me. It really helps me to try to figure out what's going on. And I think I'm going to be able to help you today. But one of the questions that I have is, whether you're able to use barrier protection when you have intercourse.
What's that?
Like a condom, either a male or female condom?
Not really. We don't really use them.
Okay. And I'm assuming, since your boyfriend also has symptoms, and because you describe him as your boyfriend, that you're sexually active with him.
Yes.
And are you sexually active with anyone else?
No.
Is he sexually active with anyone else?
Yes. Yes, but he loves me. I mean,
I'm not asking about love. I'm just trying to figure out the medical part of it.
okay.
Okay. But you don't have any other partners?
I didn't used to have any other partners.
Okay, what do you mean by that?
Just, I'm not cheating on him.
Okay, all right. Well, and again, I'm worried about the medical part of it, not the social part of it. Let me ask this in a different way. In the past month, how many different sexual partners have you had?
So maybe 4 or 5, but I didn't have to use to do this, but the COVID has changed a lot of things for us.
It really has changed things for everyone.
Yeah.
So how has it changed things for you?
We just have just had some problems with affording rent, and so we're trying to do what we can to do that, to pay for our bills.
Okay, and so is that what's happening, that you are having sex so that you can get enough money for rent?
Yes, and he said it won't last long. It's what we have to do right now.
And is he doing that as well?
No, he's not. It's just
Okay.
me.
Just you. Okay. I'm sorry that that's happening. Sorry that's happening to you, and that this pandemic has put you guys in such a bad financial position. Are either of you working outside of this arrangement that you have?
No.
Okay. What kind of work did you used to do?
I didn't work. He worked. He just, like regular stuff around the city that he finds, just different jobs. But with everybody being inside, it's just he hasn't found any jobs lately.
Okay, all right. I'm worried about you, Shannon.
Why?
Because when you talk about this, you sound sad. And when any person's in a position where they don't have control over what they do with their own body, I always worry. This is something that's happening to you that you would not choose to do otherwise. And that's why I'm worried.
I mean, I feel I have to do it to survive. And he says it won't last long. So I'm okay with it.
Okay, well, makes my heart hurt, and I want to help you if you'll let me.
What kind of help?
Well, there's lots of different things that we can offer you. Even though it seems like it's a temporary thing, the name for what's happening is actually called sex trafficking, where you trade money for sex and someone else is, taking the money to pay for rent or shelter or whatever. And there's a big national organization and some local organizations that can help young women like you when they're ready for help.
But I'm not like those women. I heard of this. This is my boyfriend and we love each other. And
okay.
I don't know. I don't think that's me.
Okay, all right. Well, there's all kinds of other help that we can give you. Food, clothing, shelter. If rent is a problem and food is a problem because of not working, there may be all kinds of other assistance packages that we can offer you. Would you be interested in speaking with a social worker here as part of this visit?
Okay.
To see what kind of help we can get for you?
Oh, my boyfriend, no.
Not unless you want him to.
Okay, because he doesn't like handouts.
Okay. Well, and this is all your choice. You're an adult. And even though I'm really uncomfortable with what's happening to you, I don't want to take away your right to make your own choices. So let's go ahead and get a social worker, and I can introduce you, and then I will give the two of you some privacy so that you can speak without me being on this call.
Let me ask us to, I
in
think
the
we've
meantime,
gotten the gist of this
I'm
now. If I
also
could
going
ask
to
our
make
tech people
arrangements for my
to go back to the PowerPoint, that'd be great. So thank you. That I think did a very good job of depicting, if I could just see by visual feedback, of the situation, right? There are several things in this video. Dr. Harrison put the patient's agenda first and then started with those open-ended questions. She checked to see if the cell phone was off or on and if the person was alone. I don't know if you saw the body language of Shannon when she started to talk about, the abuser. She was she just totally changed her body language. What do you mean by that was an open-ended question that I just, again, picked up every time I watch this. There's something new. So, there was that, all these indicators in that interaction. And what you would see next if we had, a little bit more time was her saying there's a social worker connected to a local organization that could be of help to you. Would you like that information? What you got from this, I hope, is our indications, red flags of being controlled by, doing things that she wouldn't have chosen to do, really defending the abuser, the perpetrator. She was still perhaps in that phase of really knowing, I'm doing this out of my own free will. I'm not being forced to do it. You're not going to see the depictions of abuse or trafficking be perfectly out there. So know that this is a kind of realistic depiction of what it might look like in a healthcare setting. And I wish we could have a chance to talk and get some responses to it. So with that, I think I'll turn it back over to you to talk about their responses to the disclosure.
think we need to go over this slide again. Okay, so responding to disclosure. Again, we've talked about some of this already, but it's really important that you acknowledge and validate that disclosure if the patient is willing to disclose. Remember, that's a gift that they're giving you. So my first reaction is to thank my patient for trusting me enough to share, and to acknowledge that this isn't your fault. This is happening to you, and that there is help available. And then to identify what those patient identified needs are. They're most important. After all, that patient is an expert in their own needs. We are the experts in the medical care that we might offer them, but we are not the experts in determining what they need. So it's really important to separate those two. And then offer them an ability to make a connection. Ask them if they have someone that they can call, if that's something they want to do. If they say yes, don't have them use their own phone. Remember, that phone can be tracked by their abuser, their trafficker, whoever is the other person who's controlling them. And so maybe they can make that phone call on an office phone, on your cell phone, if you feel safe offering that service. I sometimes do, I sometimes don't. So, that judgment is up to you. Or maybe even have, victim advocate or a social worker connect with them in the moment. This was a telehealth encounter, and we've had filmed that part of it as well. But, having somebody from a local agency come to your office or talk to them on the phone can also be very helpful. Here is my version of a 2-question safety assessment. So now, doing a full safety assessment is not our job. It is the job of the social worker or the victim advocate. But sometimes we need to know, is this an immediate need? And that's when we're going to employ this. So if we've identified abuse, we think our patient's in danger, that's when you're going to employ this 2-question, just 2 questions. You can drill down and ask additional questions if you feel so inclined, but really just 2 questions. Are you afraid to go home? And have you been threatened with violence? That's really all we need to know, because we need to know, are they safe? If they are afraid to go home, do you have a safe place to go? Is your abuser in the waiting room or in the parking lot? I've had that happen to me. And that requires a different level of intervention to make sure that that patient stays safe. And then, do you have your identification documents with you? Because sometimes abusers will hold things as simple as, a driver's license, a medical card, anything like that. So do they have those identification documents with them? If they've interacted with a social worker or victim advocate in the past, they may have a to-go bag somewhere that is not at their home that they can retrieve, or somebody can retrieve for them if they're in a position where they want to leave that situation. Remember, they're the expert in when it's safest to leave, not us. If they've been threatened, think about, was the patient threatened? Were their loved ones threatened? Were their pets threatened? Because any of those things can hold a tremendous amount of control over the patients. Has there been an increase in the severity or frequency of violence? Are there drugs and alcohol involved? Are there weapons or firearms in the household that might make them more likely to be killed or severely injured? This is just a brief shot of documentation. It is not any different than anything else you do, but do make sure that you capture the patient's disclosure in quotations if you can, that your physical exam is detailed enough that it can be useful for documentation later on. Okay. And then document that brief safety assessment, and then any resources you offered or gave to the patient. Sometimes they'll decline them, but offer that as well. Okay. Do you want me to stop?
So we've got some next steps for you, of course, making follow-up appointments. Their resources, we're going to talk about all these things next. Need I say it? I mean, you're not the service provider. You're the link to service providers. You're the link to those resources in the community. And that's what's so, so important for you to take from this. Here are some, and let me, before I show you the resources, I'm going to give you the 411 on what the Florida law is for you as mandatory reporters. First, to understand, there is no mandatory reporting for domestic violence in Florida. Okay, there is mandatory reporting for anybody who has a gunshot wound or life-threatening injury. That's when you have to call the sheriff, right? So we're not a mandatory DV reporting state. We are a mandatory report to the sheriff for life-threatening and gunshot wounds. The second kind of layer of reporting for you, of course, is that call to the DCF hotline whenever you suspect abuse or neglect of a child or a vulnerable adult. Suzanne described who that vulnerable adult was earlier. And that's a call to the hotline, which I'll show you next. So there are consequences for failure to report. And know that on this too, this is something that you should have right now in your protocols and in your procedures in your healthcare setting. Who makes that call? So there's not 10 calls to the, DCF hotline, et cetera, but that's organized so that you make sure that that report is there. Know that Florida law provides for a range of victim support, different laws, relocation expenses, address confidentiality. There are protection orders. There's protections around firearms. There's time off work, 3 days if you're a victim of domestic violence that you have to comply with if you have a work setting of over 50 employees. There's all things that are available that your local service providers can help you with. Again, this is the DCF reporting information that child victims are vulnerable adults. This is a report that you can report anonymously. They may still try to follow up with you later to do an investigation. And know, again, it's if you suspect. Sometimes you're not going to know 100%, for example, if someone is trafficked or if they are a victim of violence. But if you strongly suspect it, then you have to make that report. 896 abuse. Resources, as mentioned already, every single county in the state has a local domestic violence center. Excuse me, you should keep the name and number of that handy for you, and know that in terms of other resources, there's the National Domestic Violence Hotline, 800-799-SAFE. This is another good one to have, again, posted every place in your workplace. There's a National Human Trafficking Hotline. We have the Florida Abuse Hotline as well for adult protective services and for children, which I just outlined. As mentioned, Futures Against Violence is a great resource for healthcare providers. There's a national coalition against domestic violence. And to get certified information about, just put local domestic violence shelters in Florida and you will get this website. So you'll be able to have your local program identified. And then this is what we've talked about this already, and we should probably go to questions. Making a difference. We've got a wealth of materials. We'll stay here afterwards, and we're always available through the FMA if you have any questions about how you want to make a difference. This is another mnemonic, if you will, for Suzanne usually takes the slide, but remembering to asking direct questions, documenting your findings, assessing and responding. Radar, this is another great kind of summary. I don't know, you want to say anything about taking care of yourself? We'll talk about that later. And we are ready for questions.
We have really no time left. There is one question from one of the live stream people that I would like to bring up, though, and that is a question for either of you or both of you. Are there resources available for undocumented immigrants who may appear at an emergency facility or clinic? And if so, how do we find them?
So it should be clear to every undocumented individual or documented or anybody cannot be denied services at any local emergency room, hospital, or domestic violence center in the state of Florida. So they are able to access direct care there.
I think we'll just start our break now. The next section that we're going to cover today is Florida laws and rules, as well as ethics. While this is not required for allopathic physicians, it is required for osteopathic. And I always learn something from these sessions. So we're glad to have Chris Nuland with us today. Chris Nuland was formerly the general counsel of the Florida Medical Association, an assistant counsel to Blue Cross and Blue Shield of Florida. Is now his practice consists mainly of representing doctors and physician groups. So he's also general counsel of a number of specialty societies here in Florida. So I'll introduce to you Chris Nuland.
Good morning, and welcome to what is perhaps the most boring lecture that you're going to have during this day of CME, but we're going to try and make it a little bit entertaining for you if we possibly can. My name is Chris Nuland. I'm coming to you from the Board of Medicine, where I was yesterday. Many of you are wondering, why is that relevant right now? One, there's a virtual riot going on at the Board of Medicine as we speak, so I am very glad to be right here, as protesters have taken over the boardroom, evidently at the Board of Medicine. Secondly, and probably more important for our immediate purposes, is the nature of this talk. Yes, we're going to talk about rules. I could talk to you all day about the various rules because you have what is probably the most overregulated profession in America. That being said, what I'm going to concentrate on are those laws and rules which get you in trouble with the Board of Medicine or the Board of Osteopathic Medicine most often. These are the things, in many cases, that Prosecution Services has told me, please tell your people to obey these rules because we want to go after people who take off the wrong limbs, people who overprescribe narcotics, the drug dealers, those types of people. We don't want to go after people for the stuff that we're going to be talking about today. So with that, let's talk about some of the continuing education laws. Why you're here, for instance. One of the things that you have to do every 2 years is take a course on the prevention of medical errors. And you'll note on the agenda that there's one of those later on today. If you take that, you qualify. Why is this so important to me? One, because this is the one conflict of interest that I do have. You have to give or take a prevention of medical errors course every 2 years. I was the lobbyist for the FMA and some other groups when that law went into effect, and now I make my living giving that course. So we didn't want it. We actually said, no, it's superfluous. Everyone in this room takes CME. Why? To avoid medical errors anyway. To have this specific course is absolutely ludicrous. But perhaps more importantly, look at the thing I have in gold. I know those of you back may have trouble seeing it. The course has to include information regarding the 5 most misdiagnosed conditions during the previous biennium. How do they figure out what the 5 most misdiagnosed conditions are? What the Board of Medicine does is they actually look at their disciplinary files and they see, what have we disciplined physicians? It may or may not have any relevance to what the 5 most misdiagnosed conditions are. Moreover, for those of you who may be psychiatrists, you really don't care that one of the things that gets misdiagnosed are MIs. It doesn't pertain, but you have to take a course on it. One funny, slightly off-color event from about 15 years ago is that there was one penile enlargement company or practice that was notoriously bad. Why is this important? Because most of their physicians ended up getting disciplined by the Board of Medicine. And so many of their physicians got disciplined that we were within a hair's breadth of having to teach about penile enlargements at this course or your prevention of medical errors. Fortunately, it came in 6th that year. We got to move on and not do that. The course also has to include, and yes, the course this afternoon will have that, information regarding a study of root cause analysis, error reduction, prevention, and safety, and it's got to be approved by the Board of Medicine. Now, what you're going to get this afternoon is, in fact, already approved, so you're good. As 1 hour of the 2 hour can actually be given by your hospital. That's important for those of you who may be on hospital staff. They give courses, and actually some very good ones that are very appropriate for your medical practice. All of that being said, here are the list. The 2021 list was cancer-related conditions, and I'm not going to go into each of any and all of these. Why? Because we're going to go over that this afternoon. But cancer-related conditions, and you can understand that underlying cancer gets misdiagnosed or not diagnosed very often. And there's some reasons for that. One is a simple delay in diagnosis, misdiagnosis, but a lot of it also is, it wasn't my job. I represent plastic surgeons, and very often they get sued for failure to recognize breast cancer. Well, that's really not their job, even if they're doing they've done. And it's actually fairly entertaining to watch them squirm as they try and explain why they took off the wrong leg, or why they gave sex enhancement drugs to a female patient who wasn't their wife and then had relations with her. These things happen. So be careful. You don't want to be a popcorn case. Other CME, you can take up to 5 hours of continuing education by performing pro bono services, but you've got to do it to low income, and you've got to do it with regard to a nonprofit organization. You can't just say, hey, I gave 5 hours of pro bono. You've got to do it through a 501c3 that will document it. Again, the new list of 5 most misdiagnosed conditions that your prevention of medical errors has to address. We've gone over that. But the DOs have their own list. Why? Because they have their own board, and just the statistical differentiations are important. I think that the DO list is actually more educational for our purposes today than the medical board. And the reason for that is these are things that apply to each and every physician, and they're the things that will get you into the most trouble most quickly. For instance, inappropriate prescribing of controlled substances. This has been a problem now for 20 years in the state of Florida. And I will tell you that the Board of Osteopathic Medicine and the Board of Medicine are sick of it. And the reason I emphasize that is they have no tolerance for it, and they are coming down hard on people. Whereas 10 years ago, it was a $2,000 fine, a letter of reprimand. They are now suspending licenses very quickly for this because they think this should have stopped a long time ago. They've passed laws to make sure it stops, and it hasn't. Failure to monitor the safety of prescribed medications goes right along with the first, because what usually happens both at the Board of Medicine and at what we call the BOOM, osteopathic medicine, is if you prescribe inappropriately, it's almost a natural follow-up that then you're not following up on the patient to make sure that they're taking their opiates as they should be, that they're not becoming addicted, that things are going well. If you're giving people any type of Schedule 2, 3 drug, you need to be on them. And you need to have them coming in now for checkups and things of that nature, especially because you now can do it by telemedicine for everything but a Schedule 2. That is really, really important and should help everybody in this room. Wrong site, wrong patient surgery. Again, in the 1990s, there was a problem with office surgery. And they passed the office surgery rule. It took them some time. But the number of office surgery deaths went down from an estimate of 48 to 50 per year to around 4 to 5 a year. And the Board of Medicine, very correctly, was justifiably proud of having done that by passing legislation, by passing new rules. They passed rules on wrong site, wrong patient surgery, the timeout rule. We'll talk about that in a couple of minutes. But the number of wrong site surgeries has not gone down. And they don't understand why. So they keep passing more and more rules because people aren't following the rules that exist. I know there's a logical flaw to that, but that is what they're thinking. So what they are doing now is they've enhanced the penalties. A wrong site surgery is almost always going to be a $5,000 fine, probation of your license, and if the wrong site is because you did not do an adequate timeout, which happens in most of these cases, they can cite you for a second offense of failing to do the timeout with another $5,000 fine, enhanced probation, and already then you've got 2 strikes, where Florida has the notorious 3 strikes and you're out rule, which, by the way, don't worry too much about it. In the 17 years on which it's been on the books, not a single physician has been eliminated by the Board of Medicine because of 3 malpractice actions. It has not happened. Now, let's be honest. If you're on your 3rd transgression for which you're going to the Board of Medicine or a 3rd malpractice, you probably have more deep problems to worry about than the 3 strikes you're out. But it really has been a red herring. Failure to diagnose neurological and brain-related conditions. That's similar, of course, to the Board of Medicine. And again, failure to timely diagnose cancer-related conditions. Why do I put up your current CME stuff? Because again, this is where you get into trouble without knowing it. Outside, you've got CE Broker, which tracks all these things. And believe it or not, they do a great job. Make sure that you're checking your CE Broker. Make sure that all the credits that you're getting today, give them a few days, but make sure that they get posted. 40 hours, as you know, every 2 years. 2 hours of domestic violence every 6 years. I have asterisks next to that. I'll tell you why. It is a bad, poorly written statute for which I have to take some responsibility because I was on the staff when it happened. And of course, the 2 hours of prevention of medical errors. Here's why I starred the domestic violence requirement. You have to take the 2 hours of domestic violence as part of every third biennial relicensure or recertification. What does that mean? It means if you take it today and your license is up in 2023, if you take the course again in 2024, it doesn't count. You must wait at least 5 years to retake it so that you're in the third biennium, or else it'll count for 1 hour of CME or 2 hours of CME, but it does not count as your every third biennium. Again, it's ridiculous. I'm sorry that it got worded like this, but we have tried for years to change it. And it's one of those things that the legislature goes, I've never heard of this being a problem, so we're not going to bother fixing it. And the reason that it isn't really a problem is, again, the Board of Medicine, Board of Osteopathic Medicine, and their staff and you've just broken the sterile field. So you have to go back, scrub in again, come back, but then you have to do the timeout all over again. And theoretically, you would be in an endless cycle of doing this, and there never would be an operation. This got addressed at the Surgical Care Committee, where the chairman of the Surgical Care Committee at the time was a former FMA president who was known for occasionally lacking tact. And he said, "This is stupid. It's asinine. I have never done this. I will never do this." At which point the Board of Medicine Counsel had to remind him that he was on an open mic and he had just confessed on the public record to having never obeyed a rule that he in fact drafted. The rule got changed. What do you have to do on it? You have to document it in the chart that you've done it. It is ultimately the physician responsibility. Remember I said just a couple moments ago that the nurse can actually write it down? That's fine. But it's ultimately the physician's responsibility. Although a couple of times lately, I've seen nurses get dinged too if there have been things like a wrong sponge count where the doctor asked for a confirmation and the nurse said, "Yes, I took out 20 sponges." Case about this that was kind of interesting. You're trying to do everything that you can to avoid these situations, right? I had a plastic surgeon several years ago who completed a surgery, 20 sponges. He asked the nurse, "What's your sponge count?" She said 20. But then she left the room. He says, "What's going on?" Because at the hospital at that time, there was a rule that nurses had to rotate specifically at specific times. So even though they were just about finished, his whole surgical team had to leave and a new team came in. And the surgeon very wisely said, "Okay, new team, I'd like you to do a sponge count because I think she may have been hurried." The new team came in, was trying to get set up. They counted 20. You all know what happened. There were 19. And the doctor got brought up on essentially a retained foreign object, which falls under this. And he went to the Board of Medicine and said, "I counted twice. I had two separate people count." I then was so angry that this happened that every nurse at my hospital has to take a 2-hour course on how to count sponges. And if you think this 1 hour with Chris Nuland is boring, can imagine a 2-hour course on how to count sponges. And we've done everything that we can. In fact, we've changed the rule at the hospital so they don't change mid-procedure anymore. Honestly, Board of Medicine, what else could I have done? And the Board of Medicine said, "There's nothing else you could have done. Go home, go in peace, sin no more." We had a question. Go ahead. Great question. Joint injections. Do you still have to do the pause? Yes, you do. And again, you have to document that the patient, and then again, you may not have the x-ray or whatever with you, but you have the x-ray. Missed joint injections are actually one of the things that comes up most often. You go into the wrong level and the Board of Medicine hates it. I hate it because in most of the cases, no harm is done. And you say, "Oops, I did the wrong one. Let me go into the right one." No harm, no foul, but officially it is a wrong site procedure. And you have to report it to the Board of Medicine. Again, you have to notify the patient of any adverse incident. And this is, to me, incredibly important. And the reason is, as somebody who defends you at the Board of Medicine, and rarely in trial courts, if you don't notify the patient, if you try and hide it, what the Board of Medicine or what a jury sees is that you are inherently a dishonest doctor. And that puts you in a very different field. The Board of Medicine understands that as an orthopedic surgeon, you might go to the wrong joint. They understand that cataract surgeons occasionally give the wrong lens. These are mistakes that happen. You admit it, You fix the mistake, you go on, and you get fined, and there's a little ding on your license. But if they catch you falsifying records or not admitting to the mistake, you are dishonest. And here's the difference. When you make a clinical mistake, they feel they can correct that. They're trying to protect the next patient. They can correct that by giving you CME, making you do certain things. If you're inherently dishonest, that is a character flaw. And that's a character flaw that no amount of CME is ever going to fix, and they know that. And those are the people who lose their license. The people who perform services that they're not qualified to do and know that they're not qualified to do. We'll talk about that in a few minutes. But those who actively hide what they did or change records are the ones who lose their licenses most quickly. Yes, there's an exception for minor dermatology procedures. I work for the FSD, now the FAD. And the reason we got that in was because with minor dermatology, actinic keratoses are the best example. You could have 6, 7 of them, and to have to do a timeout for each and every one was just ludicrous. And because most dermatologists work alone, you can't report it to the nurse. So for minor dermatology things, there is an exception. Although I will tell you, as the dermatology lawyer, I still recommend that you do a timeout even for the minor dermatological stuff, because you still can get hit for a wrong site surgery. You just can't get hit for the timeout. Surgeon responsibility. The surgeon, not the PA, not the APRN, the surgeon is responsible for post-operative care. Now, you can delegate it to the PA, you can delegate it to the APRN, and that's fine. But ultimately, it is you as the surgeon who are responsible. Let me give you my horror story. This is from long ago. A surgeon did a procedure on a Friday. The surgeon did a great job by all accounts. Surgery went well. He went off for a golfing weekend. His PA, who was rounding, found that the patient seemed to be going into sepsis. He paged, this was in the days of pagers, he paged the surgeon all weekend. And the surgeon would not answer his pager because he was having too good of a time playing golf. When the surgeon did come back on Monday, as you might guess, the bed was empty, the patient had expired, and he lost his license. And he lost his license not because he was a bad surgeon. By all accounts, he had done a perfect surgery. But the Board of Medicine in this case said, you were irresponsible, you didn't follow up, you didn't care. If you had done something wrong, we could give you CME, we could teach you how to do the surgery better. We can't teach you how to care. And therefore, we consider you to be a threat to the patients of the state of Florida. You will never operate here again. There's a lesson in that. It's why 20 years later, I still use that surgeon as a response, as a example. Why do I say update your profile? I'm giving you rules. You say, well, this is so minor. It is important. Understand that within 15 days, you have to report on your profile any changes to your address, staff privileges, your medical malpractice history, and that includes settlements. Financial responsibility. This is kind of a funny one because what unscrupulous physicians, no one in this room, would do prior to 2004 is they would get insurance in January so they could report, yes, I'm fully insured. Then they would cancel the insurance in February, but it would be up on their profile that they had insurance. That would never change. The patients never knew that they were self-insuring. Gail Harrell, who has been a great friend in the Florida House and Florida Senate, said that's ridiculous. So she made sure that this change occurred in the law. If you change your financial responsibility, you got to let people know. Board certification. I know many of you do not like MOC, maintenance of certification. I understand that there are those in this room who may not maintain their certification. But if you don't, you can no longer claim on your physician profile that you're board certified, and you need to change that. Changes in your education, disciplinary, and criminal history, and that unfortunately includes DUIs. The change of address, and there's actually another rule on this, means you may not get renewal information, but to me, even more importantly, if, God forbid, you get that complaint letter from the Department of Health and it goes to the wrong address, it does not get forwarded because it comes by certified mail. They don't forward certified mail. So let's take this through what happens. You don't get the complaint letter. You don't get to respond to the complaint. So what happens? The Board of Medicine and their legal team has to assume that everything that is in that complaint is gospel. They cannot question its authenticity. And because you don't even know that there was a complaint, you can't defend yourself. So at the actual Board of Medicine, they have what's called a waiver process, which means we tried to get in touch with the physician who decided not to defend themselves against these accusations, which we have to assume are true. Therefore, Board of Medicine, you must impose discipline based upon whatever the complainant said. And usually the complainant uses a fair amount of hyperbole when they're drafting a complaint against you. Most of the time, 80% of complaints get dismissed before they even get to you. You never hear about them because the board counsel say, that's ridiculous. But if you don't respond to it, you can't defend yourself. Moral of the story, make sure that you change your address. Pre-signing prescriptions. I thought we were over this with electronic prescribing, but I just had a case last week where a physician assistant stole their physician's prescription pad, started prescribing under the physician's name. In this case, I won't mention, don't want to get too much into specifics. And we have to defend ourselves now before the Board of Medicine because the PA stole the prescription pad. Lock these things up, be careful, and whatever you do, do not pre-sign them. I know you're going on vacation. Mrs. Smith is going to call, as she does every 6 weeks, for a refill of whatever, and it's just easier this way. Don't do it. There's a mandatory reprimand and a $5,000 fine and 2,000 years of probation, and you get labeled a drug dealer even if you did it for the best of reasons. I had one potential client years ago. I talked to you about the circus that can be at the Board of Medicine, who 2 days before her final hearing offered me $10,000 to defend her at the Board of Medicine. And that's a lot of money for 20 minutes of work. So yes, I thought about it. But what she had done, and this is a horrible, horrible case because she had had a neurological problem and she was in the hospital, but her boss said, oh my God, you're awake, great, patients are waiting for stuff, can you just sign these? And she had absolutely no idea what she was signing, but she signed 100 prescriptions while completely out of it. And yes, they were all for opiates, as it turned out. And her defense was, I didn't know what I was signing. Well, I declined the case because I said, I really don't think I can help you. You're going to lose your license and no amount of money is going to help you. So her case comes up, and then I mentioned the attorneys are in the back of the room. And I mentioned, yeah, this lady came to me. And I thought, no, I was hot stuff because obviously I'd come highly recommended. 5 other attorneys in the back said, yeah, she came to me last week. Yeah, she came to me a week before. I was the last of the 6 that were mentioned of it. None of us took the case. Do not pre-sign prescriptions. When it comes to renewals, handle it personally. You all have great staffs. Wonderful. But if you miss the deadline for getting your renewal in, you have another awful chain of events. February 1st, you are officially practicing without a license. Practicing medicine without a license in the state of Florida is a felony related, obviously, to the practice of medicine. And the law says if you're convicted of a felony pertaining to the practice of medicine, you may never have a license again. So getting in it late, you can lose your license. Now again, CE broker usually lets you know that things are not going well on this. The Board of Medicine will tell you on February 2nd, hey, something went wrong. What I tell people to do is you got to cancel patients that day, but get it in. And usually you're good to go the next day. But it's serious. Your CME and financial responsibility statements are audited every third biennium on average. I'm just checking my time. Make sure also your prevention of medical errors course is compliant with Florida law, that it includes information on the 5 most misdiagnosed conditions and all of the things that we mentioned, the study of root cause analysis, which I have found to be very effective in these courses, error reduction, and patient safety. Friends and family. I love this one because let's go down to the third bullet. Spouses and friends are not always guaranteed to be spouses and friends. And the popcorn cases that are the best at the Board of Medicine and most horrendous for the actual physician are when an ex-spouse, ex-lover makes a complaint that you fed him or her inappropriate drugs without taking medical records. So what do you do when your next door neighbor says, I think I've got strep throat, or I think I've got sinusitis? You got to create a record. And I'm not saying you have to go in and create a whole SOAP analysis, everything else. Just get a sheet of paper that you keep in a binder, said, yeah, Jill Smith came to me, symptoms of sinusitis, took a look at her nose and prescribed X. That's all. Let them know that you in fact did it. Of course, if they're asking for controlled substances, you do a little bit more digging for it. But remember, families and friends, even they need medical records because you don't want them coming back at you. Each and every prescription actually creates a patient-physician relationship. So when you're at the cocktail party and somebody asks you, and I'm guilty of this too, hey, I got this thing on my cheek. What do you think? When that dermatologist gives an answer, it's created a patient-physician relationship. Now, I've actually done that to a couple of dermatologists, and they've given actually great advice to me. So, but I've got my own dermatology appointment because my wife said, you haven't been for your checkup in 3 years. You're relying on going to the dermatology meeting and having people look at you in the exhibit hall. That doesn't count. So yes, I'm going. Yeah, yes, I'm okay. And of course, no self-prescribing of controlled substances. It's a one-way ticket to the PRN, and it should be a one-way ticket. Telemedicine. This is new. It's exciting. We worked for years. Yes, we had a question. Yes. Medical records by law have to be kept for 5 years. That 64B8-10. That's a absolute. I always recommend those 7. Why? When the Board of Medicine rule says 5, why do you have to keep them for 7? That is the statute of repose for medical malpractice actions in the state of Florida. So you want to keep them for that long. Here's the other thing though. If you have a system where you keep for 7 years, abide by that system. Why is that? Let's just say you kept records for 6 years. Legal, but you didn't keep them for the 7, and that's your standard. You get in trial, and I guarantee you, because I've had it happen, the plaintiff's counsel say, why did you get rid of this record after only 6 years? Because you knew it was damning, and you destroyed it intentionally so that I couldn't bring it up in court. Well, maybe, but you get nailed on that. Likewise, the case is 8 years old, and you still have the record. That same attorney will come up to you. You kept this longer than you should have. You knew that you were going to be sued for this, and you knew that there was a problem, which is why you kept the record extra time. Have a written record retention policy and follow it. That way you can say, we always get rid of records on December 31st of the year after which it's been 7 years from the date of last patient contact. Telemedicine. We have been working on this for years. And the reason we got it this year is during COVID, there was an expansion of telemedicine rights. The governor passed an emergency rule that allowed us during the time period to prescribe, even Schedule IIs. And you know what? It kind of worked. When we went to the legislature this year, we said, okay, the emergency may be over. And we can debate whether the emergency actually should have been declared over, but Governor DeSantis did. Telemedicine worked. At the legislature, though, said, we don't want to create another pill mill crisis and make it too easy for people to get opiates and other Schedule II drugs. So what we did is we allowed telemedicine to be used to prescribe Schedules 3 through 5. And this could be a game changer for a lot of people. It really helps get telemedicine or controlled substances to the people out in the hinterlands who don't necessarily have access to a physician. Beware, though, and I always counsel people on this, the standard of care does not change with telemedicine. So if you think that I can't give really good advice by telemedicine, you got to tell people you need to come in. Don't be afraid to do it. Don't be intimidated because it might be inconvenient for the patient. If you're not comfortable with your diagnosis, you got to bring them in. Records retention. Again, you have to maintain the records for at least 5 years. I recommend 7 because of the statute of repose. If you are leaving a practice or leaving an area, you have to notify the people. This rule has never, well, you have to notify the patient by sign or letter where they can obtain the records. Makes sense, right? You also have to put it in the paper where they can obtain the records. In the legal notices section, I have a poll. How many people in this room have ever looked at the legal notices section to find a position moving practice? 1. That's 1 more than I got in the last course that I taught on this. You have to put it in the legal notices once a week for 4 consecutive weeks, 30 days before you move. What happens if you get fired? Again, the Board of Medicine is made up of thoughtful, helpful people. They say, you got to do it as soon as possible. No one has ever been disciplined for failing to put the notice in the paper because they got fired and it was logistically impossible. Make sure that you complete your hospital charts before you move. Those of you who may be hospital-based, because hospitals love to file, I don't want to say meaningless, failure to maintain records, complaints at the Board of Medicine as a way of hitting you when you've left not on the best of terms. I've had to defend those cases. We talked about don't prescribe controlled substances to yourself. One of the great things that you can do is use the PRN program in the state of Florida, which is actually very, very good. And there generally is no discipline if you self-report to the PRN prior to somebody else reporting the substance abuse, the depression, whatever it may be, to the PRN. You still can be disciplined for having taken off the wrong leg while you were drunk, but they can't go after you just for being drunk. It's got an excellent track record. And the PRN will help you at the Board of Medicine if you comply with their contract. And the contracts are fairly severe. They're usually 3 or 5 years. They involve drug testing and counseling and everything else. But here's the statistics. Nationally, about 3/4 of all substance abuse inpatients or people who get treated have a relapse. The PRN is almost inverse. They're about 75% never have a relapse. That's an extraordinary statistic, but they are thorough. When I say that's going to help you at the Board of Medicine, I told you how it works, where you've got prosecution, you've got defense. The PRN actually helps you. Well, maybe not. They will sit next to you during your disciplinary hearing. Give you an example from a couple of years ago. Miss Smith or Dr. Smith was at the table, and the executive director of the PRN, who's always at the Board of Medicine, marched up the aisle, sat next to her, and said, Dr. Smith is an addict. She understands that. She has come to counseling every week without fail for 5 years. She has passed weekly drug tests for 5 years, has never failed or missed a drug test. I would trust my family with Dr. Smith. Dr. Smith, her probation is lifted. She goes on her merry way. Not 10 minutes later, Dr. Jones comes up. PRN director comes up the aisle. Dr. Jones is an addict. Everyone's like, fine. He's also a liar and a cheat. When he deigns to come to counseling, he's disengaged. When he deigns to get his blood tested, it's a 50-50 shot as to whether it'll come in. I would not trust my goldfish to Dr. Jones. Dr. Jones lost his license and to this day is not practicing. Moral of the story, PRN is very good at what they do. They can help you, but if you're not willing to go with the contract and do everything you have to do, they can be bad. And no, you cannot be Charlie Sheen for Halloween. Office procedures. We'll talk about this. For all but the most minor procedures, you have to have stuff in your office. You have to have intravenous access, supplies, oxygen, oral airways, atropine is something you should always have. No. Diphenhydramine, epinephrine, and hydrocortisone. These are things that every physician, with a possible exception of pathology or maybe psychiatry, should have in their offices. If a benzodiazepine is administered, you have to have flumazenil in your office as well. That kind of makes sense. If you're going to give that drug, you have to have the antidote to it as well. Same thing, that if you're giving an opiate in the office for whatever reason, you want somebody to calm down before a procedure, you also have to have naloxone in the office as well. You have to have the antagonist there. When you're performing just little stuff, you're exempt from having all the things that we just mentioned. But we still recommend that every physician who works in an office have at least BLS training. You don't have to have ACLS if you're doing only minor procedures, but we do recommend that you do it. Adverse incidents. This is really important to me because an adverse incident is an event over which the osteopathic physician in this version of the rule could exercise control and is associated in part or whole with the medical intervention and not the underlying disease. If somebody, you're a cardiologist, and somebody has an MI in your waiting room, that's not an adverse incident. That's an underlying condition. And why is this so important? Because every adverse incident report now gets looked at by the Department of Health, and they come in and they inspect your office. And much like the IRS, if you get a DOH investigator in your office, they want to find something. That's their job to do. If you can avoid having them come in, let's avoid having them come in. What do you have to report? Anything that involves the death of a patient, brain or spinal damage, or the performance of a wrong site procedure. And we won't go into all that because we're running out of time. Similarly, a procedure to remove an unplanned foreign object, the retention of the sponge in the case I gave earlier, or any condition that required the transfer of a patient to the hospital. And you say, well, I was doing a simple procedure. I was taking out a cyst or something, and their blood pressure spiked, so I sent them to the hospital. Is that an adverse incident? Yes, it is. And what you do not want to have happen is the hospital to report it, but you haven't. So go ahead and say, out of an abundance of caution. When I do these, I always say, out of an abundance of caution, we sent the patient to the hospital where she is doing well and no further action need be taken. The Board of Medicine, the Department of Health, they see that and they say, that's fine. You're such a good boy or such a good girl because you filed the adverse incident report. You did everything by the book and the patient is fine. You're going to be okay. What else can get you into trouble? And we're in the home stretch, folks. Misleading advertising, aiding unlicensed practice. Don't let your medical assistant perform your liposuction. Coming from the Board of Medicine and the Florida Society of Plastic Surgeons, it happens. Not completing your course before you order the THC, self-referral, stuff of that makes misleading advertising. Unrealistic expectations. Do not advertise scarless surgery. I don't care how good you are, there is going to be a scar when you give surgery. Unrecognized board certification. You would not believe what some people claim out there. The board certification, you have to put in your advertisement who is actually certifying you, and they have to have been approved by the Board of Medicine, or claims to unique skills. I have all sorts of physicians. I do what no other physician can do, what no other plastic surgeon can do. That's how you get yourself into trouble. Aiding unlicensed practice. Here's what a medical assistant can do. Under direct supervision, which means you must be there. They can perform aseptic procedures. They can take vital signs. They can perform venipunctures and non-intravenous injections. Yes, they can go ahead and numb an area. They can give the lidocaine. They can observe and they can administer first aid. What they should not be doing is practicing medicine and performing surgery. And again, there are all sorts of cases today at the Board of Medicine on just that. A couple new rules and we'll finish up. On electronic prescribing, if you have an EMR, you have to electronically prescribe all prescriptions, but there is a loophole. The loophole is if you can tell people and document that they should be able to shop their prescriptions, because EMR obviously goes through a specific pharmacy, then you can go ahead and give them a written prescription. This especially works for those of you who may prescribe Viagra, because people, different pharmacies, because it's not always covered, have widely different prices, and certain drugs like that should be shopped. The non-opioid directive, providers have to discuss the risks and benefits, and you have to give a DOH-approved pamphlet, but you can do that electronically now. We passed that last year. Human trafficking, you should all have taken the human trafficking course by now. A couple of laws in 2022, we extended COVID liability protection for you, because if you had a delay in treatment or you made a treatment decision based upon COVID, you're covered until June of 2023. Emergency care for minors, they passed a law last year in the parental rights that you couldn't even provide emergency care to minors unless it was in a hospital. Now, if Johnny sprains their ankle on the soccer field, yes, you can go out and treat it. We had to work 2 years to get that. Step therapy appeals, this is good for those of you who may be engaged in step therapy and need to go outside of the usual step therapy. And again, we talked about the telehealth prescribing. With that, we have finished the presentation for this hour. Are there any questions? Yes, another question right here. The question is, older physicians who may be grandfathered under their specialty's maintenance of certification, you can still claim certification because you're grandfathered into that. You have to check with your specialty because different specialties have different rules on that. Dermatology exempted everybody, internal medicine did not. IV, again, non-intravenous injections. So the IV push, they don't allow under that. Virtually everything else they can do because they're allowed to use office medical equipment which is a very broad category. But the physician has to have seen the patient beforehand, has to remain on site, and remains responsible. Yeah. With that, again, thank you for your time, effort. I'll get your question in the hallway because I know we have to get to the next speaker. Thank you for your time and enjoy the rest of the meeting.
Eileen Handberg. Dr. Handberg is a research director and professor of medicine at the University of Florida in the cardiovascular clinical trial area, and has extensive experience reviewing risk assessment, risk management sorts of things, and also the prevention of medical errors. So we were just discussing something relative to competency assessment, and I hope she's going to touch on that as well. So I'll let her go on from here. Thank you.
Thank you so much for having me. Excuse me. So just by way of introduction, again, I'm Eileen Handberg. I am a research professor at the University of Florida and have been, I'm a nurse practitioner by licensure, and I have been practicing in the area of cardiovascular medicine for the last, since the earth cooled. And I also have the pleasure of being the program director for Florida Cares, which is a competency assessment program. We're one of 6 programs across the U.S. And our job is to assist boards of medicine, hospitals to try and identify competency in providers who've come to the attention of the Board of Medicine or medical staff or a hospital, to try and determine whether or not your knowledge and skill is at the level that would be expected of a provider in your scope of practice. So we've been doing that. Actually, the program came into fruition around 1995 at the request of the Florida Board of Medicine, because they had providers who had issues and the board wasn't clear whether or not the physician had maintained their knowledge and skill. And so the board came to the University of Florida CME program and said, could you create a program so that we would have an independent assessment of this provider, that we're not biased as the board, which I think was a nice step from the Board of Medicine. And so that program has been in place. It closed down for a year or two because the director moved to a different institution. And in 2004, we reopened the doors based on the confluence of all the safety, patient safety issues that were going on at the time. There was Florida legislation that actually provided some funding for us to reopen our doors, and I've been responsible for the program since then. So I'm going to give you, the previous speaker was an attorney perspective. I'm going to hopefully give you a provider perspective. There are some areas that overlap with what he talked about, because a lot of those issues in the rules session that he brought up are things that I'm also going to bring up again, because as he alluded to in his talk, these are the things that tend to get you in trouble. And we don't want you to be in trouble. We want you to be informed and be able to practice your careers without fail. So these are my disclosures. I am program director at Florida Cares. I have been to 2 of these institutions. My daughters have been to 2. So I can wear a gator hat with upside down alligator with an arrow through it some days. I can charge on and be a knight. So that's my disclosure for Florida. And I've been to UM games, but I've not been there. So these are the objectives that the Florida statutes require that we cover. I realize you have to take this every 2 years. Hopefully we're going to make this interesting enough that you are not going to fall asleep, that you might have some interesting questions, and that what you take away from this is something that you can take back to your practice, to your healthcare institution, and maybe think about changing process, or just changing how you think about your practice so it keeps you out of the eye of those you don't want to be in front of. So a lot of this really started with the year 2000 Institute of Medicine report, To Err is Human. And so big news, 98,000 people die of medical errors, and it was an uproar. And because of that, the patient safety culture sort of emerged. It's not that we were trying to take bad care of patients, but it just became a national focus. There's now an entire industry around patient safety, as you well know, and you're subjected to it every day in your practice environment. And for the good, we don't want bad things to happen to patients. We don't want practitioners to not be able to practice. But there are a lot of things that happen. So it's been almost 22 years. And has anything changed? That's a good question to ask. These are the 2022 JCAHO National Patient Safety Goals. And if I showed you the patient safety goals from around 2005, many of them would be the same, which is unfortunate. And as was alluded to by the previous speaker. And I've been trying to think about, why is that? You'd think we go to courses every 2 years. It's in our institutions about process and improvement and sentinel alerts, all the things that we're going to talk about. Many of you probably have been involved in a root cause analysis. It's not rocket science, but the same things. Mistakes in surgery still happen. Making sure it's the right patient, communication, medication errors happen every single day. Why don't we get any better at it? And then it dawned on me, the people that took the courses back in 2005, a lot of those people have retired, and many of us are probably on our way to retirement. And so we have a whole new group of providers. We have trainees coming out every day. And the errors that we make when we're young, when we're middle-aged, and we're older, they're all a little different. And we learn from our mistakes, but we're always going to need a patient safety culture, because it's not the same 100 group of providers taking care of patients. It's 100 this week. It's a new 100 next week. When medical graduation happens next, it'll be a new crop of residents and interns. And what do they say about coming to the hospital in July? Don't. Right? They say that for a reason, because when you got out of medical school and you got ready and they put you on the floors, were you any smarter on Monday than you were on Friday when you graduated? No. Were you practicing pretty independently on Monday? Yes. So let's not go in the hospital in July, right? And that's not going to be any different. So I don't think that this is ever going to go away. Maybe the emphasis of what we are talking about might change over time. So what has changed? We are living through a pandemic that is hopefully on the downside. Who would have thought, if I would have asked you 5 years ago, do you think it's possible for the world to basically stop because of, some health issue? You probably would have said no, except if it was biological warfare. And basically the world sort of stopped. We didn't go anywhere. There was nobody on the streets. It's phenomenal what we have lived through. Medicine, how it's presented to the world, is totally different than it was 20 years ago. It's like the Wizard of Oz and him opening the screen, looking behind the screen and seeing him sitting there, this is the Wizard of Oz. The screen's open. People understand what happens behind the closed doors in the hospital. It's much more of a public-facing kind of experience. Social media is absolutely pervasive, and some of it's positive. Most of it's negative, at least in my view of the world. But so you can't make a foible that somebody hasn't had their camera out and taken a picture of you. Or you can't have said something that was ridiculous that somebody didn't record you. I mean, I thank gosh that I grew up in a time where people didn't photograph me during my stupid period, right? I don't want people to know what I did when I was in my teens and my early 20s, thank goodness. But that's not the case these days. How many of you have been to a meeting and somebody's putting up their camera, taking a picture or recording what you're saying or what you're doing? It's just pervasive. So there's not really any secrets anymore. Patients have also changed. They're much more engaged. They're on the internet. They're looking at all sorts of information. How many of you in the last month have had a clinic where a patient came in with something they've pulled off over the internet to ask you about? A drug, a treatment that's not approved, going to a different country to have some kind of therapy. And patients don't always realize where that information comes from, what the source is. Every time you click on the internet, it creates your persona. And the people who are savvy in the internet drive the things that you're interested to you. So trying to get an objective opinion about something is hard. You have to do some work. You have to figure out what's the data behind this. Who did the study? Is there a bias here? And most of us aren't really willing to spend that kind of time and effort. But the patients take that as gospel and bring it into the office and say, Doc, should I be taking turmeric? Should I be taking CoQ10? Should I be taking this kind of therapy or not? It's a lot of work. The media images of medicine have changed. I hazard a guess that there's not that many of us in the room who remember who Marcus Welby was. That's really old, a long time ago. I mean, I do, but that's kind of the edge of my spectrum in terms of watching TV. This generation gets their understanding of medicine from ER or Grey's Anatomy. And some of it's relatively accurate, but if you watch those programs and you're a medical provider, there's always something and you go, that's not what happens in the hospital, but that's what people see in the general public. We now have reality TV. And so they get a whole different view of medicine. If most of you, if you have any time to watch television, these are the plastic surgeons who are on Botched, who do a pretty good job actually, but it's TV drama. They're trying to create a fan base. And so the patients that are selected to go on that show are selected for a reason. They want to tell a story. They want to create a fan base. So even though it's what they do, you know, it's a selected sample. And healthcare is big, big, big business. Marketing is aggressive. You can't drive down I-4 without seeing about 50 billboards, and depending on whether you're on the Advent Health side of the street or whether you're on the Orlando Health side of the street, they're trying to get everybody to come to their practice. So there is a lot of advertising. The marketing people for healthcare institutions are aggressive. They need to get the client base. They need to bring in the revenue. And sometimes that sets up unrealistic expectations. So in this example, you know, grandpa's cured. Dr. Mark cured him. Now he had a bypass surgery likely. He still has his plaque. He still has his comorbidities. And he's still likely to die of heart disease. But the implication to the family is that he's cured. And so if that's what the family thinks, then it sets you as providers up for miscommunication, expectations that there's no way you can make. And so it's a lot of pressure. Medicine is always in the news. It's mostly in the news for bad news because that's what gets the headlines. Every time there's a big meeting, the press is there. They're publishing results. They're telling us about the clinical trials, which is fine, but they sensationalize the headings. Every time there has been a report about what to do about aspirin, I swear our practice must have get 100 phone calls because the headlines don't reflect what the data showed. So, you know, you get something put out, you don't need to be on aspirin. Well, if you read and dig down, maybe it's about prevention. And all your 800 patients who have secondary, need it for secondary prevention also call the office because they think it applies to them as well. So there's a lot of press. The most recent press about Redonda Voigt, who is the nurse from Vanderbilt who got prosecuted because she had a medical error and the patient died, got a lot of press recently. And so now there's this fear about criminalization of medical error. And we're going to talk a little bit about that. And you know, we're near Disney. When there's blood in the water, you know, there are people who want to pounce. And there's always somebody to call. Hopefully your patients don't call these successful, greedy attorneys who won't let you settle cheap. Perhaps they might call the WTF Popo attorney. Now this one I like. You get one divorce, you get the next one half off. That's planning. We're near Tampa, right? You want to call the Gasparilla attorney. You know, and then there's all the soliciting of patients to go after things like, you know, genital gangrene. How many times do we see that? Yeah, it's a side effect, but, and there are others. Trusted by over 12,000 victims. They're smart, these attorneys. They know how to advertise for sure and try and get you in their bullseye. The other thing that has changed, patient autonomy, we talked about. It's now more of a patient-centered environment that we're working in with shared decision-making. The day of me going in as a provider or you and saying, Mrs. Smith, this is what you need to do, and this is how we're going to proceed are gone. The days of Ms. Smith, these are the options for your care. This is your risk. This is the benefit. What do you and your family want to do? What can you afford to do? What is your culture? What do your beliefs tell you? What's going to allow us to be successful together? That's a much different environment. Informed consent is a process. If you take away nothing from what we talk about today, this is probably the thing that has the most ability to help you long term. If your informed consent is a process where you have talked to the patient and the family, because it's often the family that encourages people to sue, about what you're doing, what the risks and the benefits are, and being realistic, the likelihood that they're going to come back and say, you didn't tell me any of that and grandpa died, is not as high. Making sure they understand you have 10 comorbidities. We need to do this procedure, but there's a lot of risk, and the likelihood you're going to make it through is very small. Sets up a totally different set of expectations and could save you from a lawsuit, because sometimes patients don't make it through. When I was a nurse in the SICU, fresh out of nursing school, we had a patient go in for bypass surgery. And at the time, I didn't appreciate what this physician said. I was aghast that he said it. The patient said, Doc, I'd like to die with my boots on. And he said, sir, wear them to the OR. He gave that person a risk assessment. Now, it was a little crass at the time, and but he did, telling the patient he was very high risk, and they would be lucky if they could get him out of the procedure. Advanced directives, we are now mandated to report adverse events to patients and families and to document. It's a statutory requirement. The days of trying to cover something up are gone. People still try and do it. They're the people that get sued. Those are the people that lose their license, as was brought up in the previous course. So medical error, we know what that is. You've been to this course many, many times. What we're trying to do is to figure out how to not have so many medical errors. I know you guys are not going to go to work going, gee, it's Monday. I think I want to do 3 medical errors, 2 of them really big and 1 really small. Medical errors are not by people who plan them. Most of medical errors that happen are by very conscientious people who go in compassionate, trying to do the best job as providers that we can. All man-made systems have the opportunity for error. There's no perfect system. Some days you go in and everything is slick as a whistle and it works. You're rested, you go in to do a procedure, your best team is there to help you, all the equipment is right, the patient's stable, you do the procedure, everything goes swimmingly. The next time it's Friday, you're off call, you're tired. None of your surgical team is on with you. It's all travelers who've been at the hospital for less than a week. Your favorite piece of equipment is broken. You're having to make do with something else. And what you really want is on a boat coming from China because of issues with the chain. And something happens. And that's the kind of life we live in, and we try and we want you to have the best experience possible. Healthcare is still on the high risk spectrum if you compare it to pilots. But think about how they work. No pilot gets into an airliner these days or ever and does not pull out his checklist and go item by item by item by item. Does this work? Does this work? Does this work? This doesn't work. Sorry, people, we're going to be at the gate. How many times have you heard that in an airplane, right? But that's how vigilant they are. They don't say, ooh, I think we can slide by. It's a yes or no answer. It's black and white. And that's why they have such a high safety record. In medicine, we have this whole concept of the art and science of medicine. And I would acknowledge that there is an art to medicine. There's an art. There's some people who are so fantastically good at assessment and doing a great differential. They've got great knowledge behind them, but they have an intuitive nature about it. But we can take that sort of concept too far because there are some things in medicine that are not rocket science. In my area of cardiology, taking care of blood pressure is not rocket science. It's prescribing the right meds based on the patient's comorbidities, up titrating until you get blood pressure control, and you get better outcomes, right? The data is absolutely clear. But if we ask the cardiologists around the state of Florida, how well do you manage hypertension? Most of us would say, I do a fantastic job. If we audited their charts and we look at the national data, we have blood pressure control rates of less than 50%, probably more around 30 to 40%. It's just prescribing meds and seeing patients in follow-up. We did a randomized clinical trial at the University of Florida, and we enrolled 22,000 patients, and we used an algorithm. And we said, there are 4 drugs. This is how you prescribe them. It's stepped up therapy based on the blood pressure, and it did it automatically. We were able to get blood pressure control rates of 80%, unheard of in a clinical trial. It wasn't hard. The providers didn't have to think about it, and they didn't have to say, ooh, I like that drug, I don't like. They just did the algorithm. So there are things in medicine that we could make a little bit more checkbox-like and get better outcomes. But a lot of providers, when you say, let's do that, they say, well, that's cookbook. That's not the way I practice medicine. We have to practice medicine evidence-based, based on science that shows us that something works, not anecdotally, not just what you learned in medical school. The guidelines change. We see people in Florida Cares because you haven't kept up with the guidelines, and you're still prescribing the meds that you learned in medical school. There's a lot more meds out there these days, and some of them have data that says they're better than what you did before. And so that's the kind of medicine we need to practice. Are errors inescapable? All human beings make bad decisions. So I'd say we're never going to be error-free. All systems have the potential to bring in error to the environment. And you don't provide medical care in a vacuum. You work with more than one person, even if you're a solo provider. You have your medical assistant, whoever's in your office. You go to the hospital, you round. There's a lot of pieces in this. Why are they inescapable? Because every once in a while, everything lines up in this Swiss cheese model of medical error that Dr. Reason came out with, and everything lines up in a bad way, and an error happens. A lot of times, the processes are in place that will stop something from happening along the way. Medical errors in 2022. When they looked in 2008, Medicare was very upset that people were having hospital-acquired conditions like bed sores or pneumonia or other conditions. And so they created a list that they will not pay for those. In 2013, the overall error rate in Medicare participants was about 1.1 million episodes that year. And again, they were errors, they continue to be errors that Medicare does not pay for. In 2022, 400,000 hospitalized patients experienced some preventable error. So that's way above the 98,000 that was reported in the Institute of Medicine report. They cost about $20 billion a year. These are those never events. It started out with 10, it's now 14. If you actually go to the CMS website, there's a zip file behind this because each of these diagnoses has about 30 or 40 diagnostic codes because they're specific for any place that you can leave a foreign retained body. But the concept is if you leave something in a patient after a surgical procedure, CMS is not going to pay for that. So you can see why hospitals care about this kind of thing. They also got on the bandwagon of if you've had an MI, you've been in for heart failure or pneumonia, and you come in within 30 days, we're not going to pay for that either. And so there are now a lot of heart failure readmission programs around the state to try and reduce the likelihood that somebody's going to come back. Now, not all of this is because is the fact that we've done bad care. I mean, some people have a lot of comorbidities. Patients don't pick up their meds. They don't take their meds. They're non-compliant. It's not all us, but it feels like it's all us because the buck tends to stop with us and we're the ones that get blamed. You're on the boots on the ground. You're the one that the hospital comes to and says, fix this. You're taking care of the patients. So it's a little daunting as a provider. We're always the person that everyone comes to fix everything. Make the medical record work better. Make clinic go faster. Can't you see 20 more patients? We don't care that you're home at night at 10 o'clock in your Epic records trying to finish up your clinic notes. They need to be done in 2 days. What's the matter with you people? You know, and the MBAs are running the world and they're 30. How many of you have been told by a 30-year-old MBA something that you just want to go, oh my gosh, where'd you come from? Yeah, everybody's shaking their head. So the spin-off fact is there's really little tolerance for medical error and these kinds of things. There are a lot of factors in medical error. These are the big ones. These are the ones that always end up in the literature. These are the ones that are in this course for a reason. Diagnostic errors are a problem, and we'll talk about that. Treatment. Obviously, if you give the wrong treatment, do it wrong. Performance errors, those are important issues. Communication is a big issue, and we're going to talk about that. In this age of hospitalists and no more primary care provider rounding in the hospital with the people that they've known for 20 years, the handoff rate is unbelievable. It's amazing we don't have more errors than we do. The system. Think about a hospital bed, 30 years ago. It was a bed and a patient. A hospital room was a bed and a patient. Today, it's a bed, a patient, and at least 10 monitors and a 60-foot screen TV. Lots of stimuli. It's not quiet. It's not conducive to thinking. Alarms going off, and heaven forbid you go to a PCU or an ICU, then you're talking 2 banks of elevators, 10 IV pumps going off. It's a wonder that we can even think about what's going on without all the distraction. Medication errors continue to be a problem. So let's talk about diagnostic errors. 1 patient in every 6 is affected. 1 patient in every 1,000 primary care visits causes preventable harm. Inaccurate diagnosis can be done by anybody along the way. Can be any of the providers. It's not just the primary care. It's not the specialist. It can be the pathologist. It can be the radiologist. The most common diagnostic errors that occur in primary care include failure to order the appropriate test, faulty interpretation, failure to follow up, and failure to refer. One of the issues that we see in Florida Cares when we're evaluating people is this cognitive effort to prematurely close the diagnosis. And you end up with a common diagnosis when it really was a complicated issue and a complicated diagnosis. And a typical example, we see this all the time. Somebody comes in with a cough and it's turned into, I think they have bronchitis, when actually it could have been heart failure, could have been some valve dysfunction, could have been lung cancer. And rather than doing the complete differential, you sort of hone in on the simplest thing, treat the bronchitis, you send the patient away, and then some, they drop dead because their EF was 20 and it was undiagnosed. Delaying treatment after diagnosis is an issue, so you have to make sure your practice is set up to protect you and the patient, making sure that every test you order, every lab you order gets followed up quickly, efficiently, and referred back to you as the provider to review and sign off and provided to the patient. Patients can now access their medical records. A lot of times they'll call before you even get a chance to call them because they're in my chart and they say, "Doc, my whatever is whatever. What does that mean?" Or they read a report and they're like panicked because there's, the kind of little bit of vagueness that you see in radiology reports. Correlation with the patient is highly encouraged. And so, patients are calling you up. Diagnostic errors result in death or injury to about 40 to 80,000 patients a year. They're most common in primary care, solo practice. One of the reasons, the nice thing about working in an academic institution or a multi-specialty practice or a big group is you have people to talk to. It's kind of like medical school where you can run by the scenarios and say, "Hey, I saw this patient. What do you think about this?" Giving you the opportunity to sort of run through that. Maybe you did miss something. In solo practice, you're the king or queen of the ship. You pay everybody's salary and you're by yourself. And it's a hard environment to work in. And I applaud those people that do it. But it's not likely that the people you pay are going to question your judgment, second guess you, or stand up and say, "Doc, something's the matter." So think about that. Create an environment for yourself where you are successful. This is statutorily required for this course. If you were in the laws and rules course, you already saw this. These are the five most misdiagnosed conditions in 2022. This is a list that juggles by one or two every year. This year, cancer is the top of the list. Usually it's cardiology, but this year it's cancer. Second is gastroenterology. Cardiology comes in. Neurological, and then missed spinal cord compression. I think that's new to the list. I don't think I've seen that one before. For the osteopathic board, as was alluded, theirs are a little different, but these are actually, as was discussed earlier, kind of a little more broad ranging, getting at the bigger scope of the issue rather than just saying cardiology is a problem. It's this prescribing controlled substance. If you have been living under a rock, you do not realize in the last 15 to 20 years, we had a lot of pill mills in the state of Florida, and the Board of Medicine and the Department of Health went after them. And a lot of people got in trouble. A lot of people had their licenses examined because of this. That's gotten a lot better. But there is a Board of Medicine meeting today. I'm not sure if it's in Fort Lauderdale or not. There are cases on there about prescribing. So it's still an issue. Failure to monitor the drugs that you provide, wrong site patient surgery. You'd think this is not rocket science. It still happens. Some of this is actually surgery specific, and we'll talk about that in a little while. Failure to diagnose neurological and brain-related incidents. This is a lot of stuff that often happens in the emergency room, where somebody comes in with some vague symptoms that could be a differential a mile long, and you miss the one that really matters. And again, failure to diagnose cancer-related conditions. I think the indemnity payments in the cancer realm are the highest is around diagnosis of breast cancer. There are a lot of factors in surgical errors. There are around 200 million surgical procedures each year globally. That's a lot of surgery. 4,000 surgical errors in the US annually. It has been reported, and if any of you all went to medical school, so you all did a rotation in surgery, whether you're a surgeon now or not, and maybe this isn't the case as much as it used to be. Sometimes surgeons don't like to be questioned. And there are a number of cases where the staff in the OR tried to raise a concern during a case and the surgeon ignored the comments, and those have ended up in cases. So, we have to put our egos aside and listen to those around us. They could save us. There are now some cases reported around practitioners being distracted. How many times have you been somewhere in a medical environment and everybody's on their phone? Frightening to think that your anesthesiologist is playing Sudoku or Wordle, isn't it Wordle, in the OR while they're giving you your gas, but that kind of stuff happens. Incomplete or missing pertinent imaging prior to doing a case, so you end up doing a spinal procedure in the wrong place. That happens fairly often. Not making patients go through the whole pre-op assessment. How many of you have had a procedure and you had to go to see the anesthesiologist and they had to do the whole kit and caboodle, and you have some comorbidities and they should have done something preoperatively about that and they missed it? If it's a complicated surgery and there's more than one surgeon in the body, that sets up an opportunity for surgical errors. Time pressure. That can be self-inflicted. I want to do 5 cases today because I'm going to make more money if I do 5 cases. They're short cases. I'm going to do 5 cases. Or I have limited OR time. I'm only assigned OR time for 3 hours, 1 day a week. I got to get all my cases in. Or I got to be rounding. I got a sick patient in the floor. I'm doing a case now. I have to get to the office as well. All of those pressures set up an environment that would lead to the likelihood of surgical error. Wrong site surgery. You are required to do the pause. You're required. How could we still have wrong site surgery? It seems inconceivable when you're supposed to talk to the patient, identify who they are. Now, the patients don't always understand what surgical procedure they're having, but the staff should understand what you're doing. So how can we have wrong site surgery? And we do. We have cases all the time. Again, the Board of Medicine requires that you do a timeout. It has to be recorded. And I would make this your standard practice for everything that you do. That's any kind of procedure. Make your practice safe. Communication errors. This is where we were talking about the handoff. So let's take an example. How many have most of your facilities are the inpatient care is provided by hospitalists? Not as many as I thought. So if you are in an institution that is run by hospitalists, so let's make an example. I'll do cardiology because I can do that pretty well. I come in with a STEMI on a Saturday. I get the emergency room physician, who I don't know, and you wouldn't expect to know the emergency room physician. They call a STEMI alert. I get the cardiologist, the interventional cardiologist on call. I go to the cath lab. I get a stent put in. They send me to the floor. It's a hospitalist kind of run service. I get put on the hospitalist service, and it's a 12-hour group. So I get out of the cath lab at 2, and I get Dr. A at 2, who admits me, writes my orders. He goes off at 7 p.m. and the night hospitalist is on, and I have an issue. And so then I'm seen by hospitalist B, and then I'm going to be in the hospital till Wednesday. That's, you wouldn't normally with a stent, you'd be out quickly. But Monday morning, hospitalists C and D are now on. And so I'm going to get rounded on by a new hospitalist on Monday morning. The interventional cardiologist who was on call is now off, and somebody else on the cardiology team is going to see me. And I have a flare up of my diabetes, and I'm going to see somebody from endocrinology as a specialty. The likelihood that there's not going to be any miscommunication across all of those people is almost slim, remote, and none. Something, simple. And so we need to think about the processes. There are a lot of mnemonics that have been developed about how to hand off. I mean, I worked for a while with a cardiology group, and I went in and I helped one particular cardiologist, and we would go in and round on the weekends when everybody else was off. And the handoff process was a printed out list of all the patients in the hospital. And there would be a few notes about kind of really urgent issues, but the rest, it was the name, and we went around and we rounded, and we had to go look and see, there's just setting us up the opportunity to not act on something important in a timely fashion. And some of the frustration that patients have, it's not that you do something wrong. Friday rolls around, Friday at 5 p.m. If you're in the hospital, basically nothing happens until Monday, right? Because everybody's covering. Nobody wants to make a decision. The patient's in there for 2 days. They barely see the people that are rounding. And so patients and families get frustrated. Why am I sitting in here? Nobody's done anything. Don't they do testing on the weekend in this hospital? All of that kind of stuff leads to frustration on the part of patients. So there's a lot of opportunity. This was one example of a novel kind of ICU handover tool. This was in an academic environment. They looked at what the change in duty hours that happened many years ago. They looked at the number of handoffs that a house staff person would have, and they averaged about 15 handoffs in a 5-day period. 15. Each intern over a month had about 30 handoffs. So you can think of, and these are trainees, right? They're not, at the top of their game yet. They're still learning. So they decided to change the culture in this burn unit, and they talked to families and patients, and they did this novel thing. They used the glass doors outside of the patient's bedroom to help them keep track of issues, problems, patient issues, family issues, so nobody missed anything. This didn't take away from documenting in the medical record, but it was sort of a stop. This is where we're at with this particular patient and family. And it changed the error rate and the handoff issues dramatically. So there are different ways to get at these issues. They're not unsolvable. There are a lot of errors with medications, both in the prescribing, the administration, patients filling them. The error can be you prescribe the wrong thing. You write down the wrong dose. The eligibility issue is not so much of an issue. When I used to work in the ICU at night as a nurse in a community hospital, I was like the handwriting guru. People would bring me the chart and say, "What does this say?" I'm lucky I got it right, but that's gone because we have the electronic medical record. So that's fabulous. But we can still write the wrong medication and the wrong dose. And if the staff isn't as knowledgeable about the medical condition, they might not know to question what you've written. You hope that it's all a team and that everybody can help make sure the best care is delivered. And it's not that they don't want to help you, but if they're not knowledgeable enough, they might not catch it. In the pharmacist arena, they might It's, again, the eligibility issue isn't quite as prominent anymore, but they might not fill it accurately. Might be the wrong drug. Might be they're tired. There's lots of people, you know, maybe they're not doing the thing. This was a study done by, it's in 2010, but there was estimated 450,000 preventable medication errors at a cost of $3.5 billion. I can't imagine, I couldn't find more recent data. So 195,000 Medicare patients were felt to die annually due to preventable medication errors. This was a AHA position statement. So there's a lot of opportunity here. We had one of our hospital pharmacists do this study where they went to 50 community pharmacists, and they looked at 4,481 prescriptions, and only 13 of the 50 had them all right. So if you translate that, you're talking about 51 million medication errors annually. And that's not at your end, that's at the pharmacy end. So there's a lot of opportunity here. If we talk about the complexity of medical care, hypertension's, I said 1 to 2. It's actually, the data would tell you it's a 3 or 4 drug disease now. Cholesterol's now 1 to 2 drugs. Diabetes is 2, maybe 3. The days of metformin and insulin alone and diabetes are long gone. Heart failure's 3 to 5 drugs. And then you add all the other comorbidities. How many times have you had clinic in the last month where your patient's medication list was 10 drugs or more? I'd hazard almost every clinic you've had. And how many of them had drugs outside of your specialty that you did not have a clue what that drug was? Be honest. Happens to me every time I go to clinic. I have to like Google. I'm like, what are you on? What is this for? This is the new drugs from the FDA. I swear drug manufacturers are Scrabble aficionados because they want something that has lots of consonants and very little vowels. What happened to the days of prils, sartans, and statins? And you knew exactly at least what class of drug you were dealing with, right? I have my cheat sheet because I couldn't do this. So I looked up some of these drugs. So, and these may be your specialty. So Cytolux, what is Cytolux? Has anybody used Cytolux? It's an optical imaging agent that you infuse for patients with ovarian cancer during their procedure. So it shows up the malignancy. I think it's got cyanide green in it. You use near infrared imaging for fluorescence. Who knew? Qelbree, it's a kappa opioid receptor antagonist. And it's given to patients for CKD-associated pruritus in hemodialysis patients. I wouldn't have had a clue. I mean, I would have known my patient was on hemodialysis. But look at, I mean, this is just the new drugs. This isn't the drugs that we're seeing every day. I mean, how many of you know all the new diabetes drugs? And God bless them, they're now in cardiology, so I have to know those too. I mean, it's hard to keep up. I mean, medicine is hard work. It's not stagnant. This is another example where the folks at Wake Forest actually went to hospital discharge and did sort of a pause. And before they would let the patient go home, they'd get the team together and they'd look at all the medications that a patient might go home on. They reduced discharge prescribing errors by 50%, from 34 to 14% by doing this process and making sure the patient was on the right drug. And it's even more complicated than that, right? Because patients have to be able to afford what you prescribe. So you can prescribe whatever you want to prescribe, but if the patient doesn't have prescription insurance, they're not likely to fill it. And patients who are below the poverty level, even though you've written everything that's on the Walmart formulary, if it's 10 or 15 drugs times 4, that might make the difference between paying a bill, eating, or filling their meds. And taking your meds isn't as obvious as being hungry. So you have to sort of, now we also have to work as sort of insurance and wallet biopsy specialists. Not because we want to do another test, but because we want to know that the care that we're providing is going to get the patient where they need to be. Because how many times have you brought a patient back for a visit because something's not going the way you thought? The first question should be, are they taking what I prescribed the first time? I work with a senior cardiologist at the University of Florida, internationally known, and he said, my patients take what I tell them to take. He didn't say it that way. He said, "What they take what we prescribe, right, Eileen? Because I work with him in clinic." I said, "Sure." We did a test. We drew a blood sample, and we looked at drug levels. And our honest patients, about half of them were not taking what we thought they were taking. And we have good rapport with our patients. I mean, we do. And I ask patients all the time, "Are you sure? Can you afford this? We're not going to put you on Brilinta. If you can't afford it, we'll put you on generic clopidogrel because it's $4 versus whatever Brilinta is." Half of our patients didn't have anything in their bloodstream in a couple of the categories that we prescribed, and they weren't expensive meds. So we have to ask patients. They're involved in all of this. So medications are really complicated. For your office, so takeaway, making sure that the patient, when they leave the office and you give them a new prescription, make sure that they can afford it, or relatively that they can afford it. If not, if there's patient assistance, make sure they understand what you're prescribing, what it's for, what it's meant to do in plain English, and that they know what the common side effects. That's a mixed bag, right? Some people, you tell them the side effect and they have it. So sometimes you just don't want to tell them, but they're going to look it up anyway. And then what kind of drug interactions might happen, so that at least they're as informed as they can be. And this doesn't have to be your job. It's a team-based sport medicine. Making sure your MA or your office staff can do this for you. They can also do a lot of things on the front end to help you be successful. So a lot of times, the MAs are just checking people in, but they have generally a good rapport with your patients because they sometimes spend more time with them than you do because it takes a while to get everything done to get you to be able to get into the room. They can look and tell you whether or not their blood pressure is controlled. They can look and tell you whether, the patient says they're taking a prescription and why they're not. And it might not be as intimidating for a patient to get that query from the MA as it would be from you, exalted on high, saying, "Are you taking what I prescribed?" It just might be a different ear. So make sure you use the people in your office. You should also tell your patients when they leave that they should have sort of the same expectation of the pharmacy, making sure that they guarantee that, or that the pharmacist explains what the drug is, even having them pop the bottle and make sure that the right pills are in there. It could be the wrong pills. So one of the things that we're required to talk about is in this session is event reporting. And you all have heard this repeatedly. Hopefully give you a little bit of extra spin on it. Sentinel events, those are reported to JCAHO. The reporting is voluntary, and it's estimated that only about 2% of events. So when you see JCAHO data, understand that it's the very tip of the iceberg. It is not the entire thing. So a sentinel event defined by JCAHO is an unexpected occurrence involving death, serious physical or psychological injury, or the risk thereof. So a near miss counts. And you can see these are the types of events that should be reported. Each institution has their own naming of some of these events, and they will report more events or different events. These were the top sentinel events in 2021. Again, the things that we're trying to get us all to not do so frequently are still happening. Falls, obviously, and every institution has a lot of effort put into reducing fall risk. There are signs everywhere. You can see them on the front of the patient's room, in the room, everywhere. Delay in treatment, still an issue. Retention of a foreign object, 97 of those. Wrong site surgery, 85 of those. I thought we had this cured. Apparently we do not. A fair amount of suicide and self-harm, clinical alarm response. So there are a lot of things that have happened. The Agency for Healthcare Administration requires Code 15s, if you've never heard this. These have to be reported within 15 days. The list is there of what is death, brain or spinal damage, wrong site surgery, on the wrong patient, on the wrong site, retention of a foreign body, surgical repair for something you did that was not part of the planned procedure, that has to be reported. Going back to surgery to get something you forgot to take out the first time is one of those things. Allegations of sexual misconduct have to be reported. If you know of them, have actual knowledge of the act, then you are required to report those. And as was alluded in the previous session, if you were here, you have to do this from your office as well. The rules apply to the office setting as well. These reports include your medical license and the people involved. So if a code 15 goes in, you probably want to take a look at it if your license is listed there as one of the people that was involved. You want to know what's being reported for you. So a medical error happens, what do we do? Other than, you know, having an accident in our drawers, that gut feeling of, oh, oof, this is terrible. Our first responsibility is to make sure the patient's safe and they're being cared for. You have to document what happened factually, just the facts. Then it needs to be reported to the hospital staff, whatever the reporting authority is in your institution. Generally, most facilities have risk managers. They're usually great resources. They can help you navigate this with the patient and family as well. You want to notify your malpractice carrier and give them a heads up. It might not turn out to be anything, but you want to let them be aware. Disclosure to the patient and the family is required by Florida statute. Do not try and hide this. This happens. The Board of Medicine gets really pissed off about this. And if it's a medical error and you bill them for it, ooh, 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 I do not want to be at your hearing. They do not like that. I was at a Board of Medicine meeting and the Board of Medicine person said, "Excuse me, Dr. Smith, you mean you left a foreign body in and you had to go back and get it and you charged the patient for the surgical procedure to go back and get it? Is that what you just said?" And everybody in the back was going, exactly. The institution is going to report it as required. You want to read the report if your name's on it. And then hopefully we'll pull together a root cause analysis panel. And we'll talk about that. They usually do it sooner than later. You want to remember the event. So this is a group, it's a multidisciplinary group. It's the people involved in the event and any kind of people that are involved within the system that might play a role. So if it involves nursing or it involves engineering, maybe there was a physical plant kind of thing, they will pull everybody together, lay out the chronology of what happened, and then try and identify what contributed to this happening. Is it because we're staffed 90% with travelers and our staffing is so inconsistent that that played a role? Is it because you've been on call for 3 days and you're exhausted? Is it because the equipment we use is so outdated, it didn't give you the information you needed to be successful? And so then developing a plan to try and mitigate those issues, get rid of them, improve the process, and then hopefully go back and try and fix that so it doesn't happen again, and keep an eye on that to make sure that's the case. The root causes of sentinel events. This was a slide I pulled a long time ago from 95, but you can see all the way out to 2012, the issues seem to be the same. Doesn't matter sort of which period of time. Communication is a lot of the issue. Orientation training back in 95, and we're talking about leadership, communication, and human factors. So it really hasn't changed a lot. That doesn't mean we still don't need to do them, because every situation is an individual situation, and we hope we always learn from our mistakes and try and make things better. So I do this case. It was a very public case. It's old now, but just this was a root cause analysis that happened at the University of Florida. This was Sebastian Ferrero. He was 3 years old. He was small of stature, and he was going to get arginine in the pediatric clinic, and he was supposed to get 5.75 grams. He ended up getting 60 grams, and he died. And during the process of getting the infusion, his mother asked if the dose was correct before this test was done. Took 30 minutes to infuse the arginine, and about 3/4 of the way, he got a headache, which is a side effect of that infusion. His dad asked them to stop the infusion. They did. They went and got the physician. The physician looked at Sebastian, didn't see anything, but he never looked at the bottle hanging. They finished up the infusion. They sent him home. That night, they went to the emergency room, and they brought him to, transferred him back to the Shands Pediatric Hospital, and he died. And what they found out was that the pharmacy in the medical plaza got the order. They didn't routinely stock the medication. They ordered 2 bottles from the supplier. The dose was correct, but the pharmacist sent the 2 bottles to the clinic, 1 of 1 and 2 of 2. So the staff thought that they had to give both bottles. They didn't look at the dose correctly enough. The nurse didn't show the bottle to the physician to verify the drug that they were getting ready to deliver. And they didn't sort of listen to what the family said. But what happened with the disclosure is the lesson here. Dr. Novak, who was in charge at that time, said, "Our investigation to date has identified a series of errors that collectively caused this tragic outcome, and the family has been made aware of the findings." Who knows Farah and Farah? If an apology would be forthcoming when a hospital does wrong, I'd have less business. And that would be okay, because it's the right thing for a hospital to do. Instead of running for cover, getting their ducks in a row, hiring lawyers, and planning for protracted litigation, as usually happens, Shands at UF Medical Center did something very different. It admitted guilt and apologized. Nothing will ever take away from that family the loss of that child. But what did happen was a relationship between that family and the institution. And they created the Sebastian Ferrero Foundation, whose mission was to improve patient care for pediatric patients and raise money for a full-fledged children's hospital. And they have been successful. And since the time that he died, Shands Pediatric Hospital just got cited as being one of the top 50 in the state. So the legacy of that young man certainly lives on, and it could have been terrible. It's terrible all the way around, but disclosure is required. One of the lessons that we learned from that, our whole policy changed overnight. You couldn't infuse anything in a clinic situation. It stopped immediately. They went through the evaluation. You have to have everything approved. They put all sorts of safety parameters in place for this never to happen again. But it did point out that we should never be too busy to make sure patients are safe, making sure it's the right patient, the right dose. The Redonda Voigt case, which is the young nurse at Vanderbilt who gave she gave Recronium to the patient who was supposed to get Versed. She overrode the dispensing. She typed in VE and she popped it open for Recronium, and it should have been Versed. You have to actually dilute Recronium. You don't Versed, and she went and did that too. It's a red bottle. It's totally different bottle. She overrode like 5 or 6 things. So medical errors can happen. You can never check something enough time. The pause rule is important. Never be too confident in what you do or who you are to not listen to the people around you. Sometimes the most observant people in the hospital environment are the people who clean the rooms. They talk to the patients more than we do sometimes. And when the environmental services person comes to the nursing station and says something doesn't look right, that opinion is as valuable as whoever went to medical school and went to 3 subspecialty trainings. Never disregard anybody's opinion. The nurse who's standing behind you who says that doesn't look right, it's worth a second look. It doesn't take but a moment. We've got to get our egos out so that we do the best care for everybody. Joint Commission also publishes this Sentinel Alert. They put them out periodically, and just pointing out to you, there's some very valuable information. So if you have things going on at your facility, there's a couple here around direct oral anticoagulants. One that I pulled out was number 59, which is this whole issue, which is becoming huge about violence against healthcare workers. I mean, how many times as a healthcare worker have you been screamed at, scratched, attacked? I mean, we've had healthcare workers killed by, violent patients, family members seeking retribution. So there are useful tools and educational materials in those Sentinel alerts. They're not just about saying, oh, we've been doing stuff bad. This is a infographic around violence, and it's amazing. 30% of nurses, only 30% of nurses report violence against them. The rest of them sort of feel like it's part of the job. And only about 26% of emergency room physicians have reported it. How are we going to fix this kind of stuff if we don't report it? I think people feel like there's no solution, but there's got to be. We can't work in these kind of environments and expect us to stay healthy and sane. Medical errors do happen. We're always going to make some mistakes. Medical malpractice does occurs every day. Crimes by physicians and providers are prosecuted. So the Redonda Voigt case, a lot because of social media, and it just sort of went viral. There's been a lot of chatter and a lot of fear about the criminalization of medical error, because who wants to report something that you're going to be sent to prison for when you're trying to do the best job you possibly can? So there's a lot of angst about that. But she is not a unique case. There are cases every day where a provider not every day, but there are a lot of cases over the last 10 years where a provider gets charged with something. I actually looked on the DOJ, last night. They were asking me for my slides. I said, I'm not done. Dr. Armando Valdez was sentenced Wednesday to 5 years in federal prison for Medicare fraud. He had a $38 million Medicare fraud thing going on, and he's going to federal prison for 5 years. the Board of Medicine meeting, which again, I'm not sure which day, where it is this today, there's a case that's being reviewed, and this is all in the public record. You can go to the Board of Medicine website and look at the agenda and look at all of the case material. It's in the public record. There's a female pediatrician from the west coast of Florida who's in federal prison for clinical trial fraud. And that's not unique. I just pulled up today's agenda. Larry Nasser's a physician. I didn't realize this. He's in Florida. He's in the Coleman Federal Penitentiary for life plus, 256 counts. So she's not unique in that it never happens. It does. And that's what, gets the public spooled up. It's unfortunate because then people don't look at all of you and all the good things you do every day. And it gets a little overwhelming as a provider. There's lots of medical malpractice information. Again, the attorneys are looking for a payout. They're looking for clients. They're looking through all of these reports that go to the board. If you don't think they're looking, you're pretty naive. This was on one of the lawyer websites talking about this is a list of Florida doctors with the most reported claims, and it tells where they practice and if their license is still active. Now, if I was a patient, I would want to know that because I don't want to go to that provider. And I was shocked. I knew a couple of those. The good thing, at least, I'm not sure if this is post-COVID or not, but Florida Medicare malpractice payouts are sort of on the decline. I don't know if that's because we all stayed home for 2 years from the patient perspective and there's less and it's getting ready to come out. I don't know. But the payouts and the amount paid has been on the decline for the last couple of years. We talked in the previous session, there is a Florida statute about 3 strikes you're out. This was supposed to protect the public from people who go from state to state, who have issues, who say, oh, they've got malpractice in Georgia, and they quit practicing there and they come to Florida. And the intent was that you couldn't go state to state and then subject your bad medical practice on someone else, that the state board would catch you. But the legislation, because of a lot of lobbying, modified this. And the problem is that the way they modified it, it only counts if it's a case that goes to court, arbitration, or a mediation. And so cases that go to the Florida board and you do a settlement agreement don't count. So you could have a practitioner who has like 6 issues before the Florida board and they wouldn't meet this threshold for not being able to practice. This is an example I found in the Palm Beach Journal Times. I'm not sure what the paper's called. Dr. Berto Lopez, who practices in Palm Beach, 30 years as an OB-GYN, 14 very serious injuries of babies and mothers, 6 deaths, multiple cases before the board. I mean, I read this stuff and it made me it curled my hair. It was that bad. And I've been in medicine a long time. They finally revoked his license in February of 21. This was the legislation, which it doesn't really matter. The issue here is how the strike was defined. This sort of took the whole tooth out of everything. And so the regulatory boards are supposed to look. They do report this, but they haven't really knocked anybody out from getting a license because of this. This is the Florida Board of Medicine. These are your colleagues around the state. It's a governor-appointed position, so if you're interested, you can apply. So you may know any of these people. There are a lot of different specialties. There's consumers on the board. This is your board. I didn't put up the osteopathic board. I apologize. I just did the one. But they're the people. You can go to board meetings, and this was mentioned before. This is a huge learning experience. You can get 5 risk management CEUs if you go. I would encourage you, if you can, to go once in your career. It is amazing. It's interesting. You won't believe the stuff that people do. There's some honest errors and things that come up, but there's, as the previous speakers said, there's some crazy stuff that happens. You wouldn't believe some of the stuff that happens. The Board of Medicine gets access to all these Code 15 reports. They get complaints by consumers. So obviously you have an unhappy patient with the care you provided. There's an open website. They can put in a complaint against you. Your competitors across town might put you in. That has happened. Plaintiffs' attorneys, they troll those reports, those insurance reports, and look for cases. So the complaint process you should be aware of. So this is their diagram. Everything that has a red around it is confidential. So if somebody complains about you, it goes to the department, it goes through this whole process, gets investigated, goes to prosecutorial services, goes to a probable cause panel that has to determine that there really is a reason that should go, and it gets deposed. At this point is where you would get a letter from the board. And then you have an election of rights. You can have a formal hearing, informal hearing, a hearing waived. There's no dispute about what happened. And then a settlement gets decided on. If you ever get a letter from the Board of Medicine, the first thing you need to do is to get an attorney. And I don't mean your cousin Vinny. I don't mean anybody that advertises. You need to go to a medical malpractice attorney who works on behalf of providers, who works and goes before the board at every meeting. Because that relationship that they have, their understanding of the board, can make the difference between what happens with you at the Board of Medicine. The worst thing that you can do is think that you can defend yourself. I don't care if you went to law school. The worst thing you can do is try and defend yourself. First of all, you've been accused of something. Nobody likes to be accused. You are going to try and stand up for yourself. You are not going to want to be criticized. You do not want to sit at that table as your own attorney and represent yourself. You will be chewed alive. It's worth the money. Get a good attorney. So what happens when this all goes through the process is your attorney and the prosecutorial services attorney will sit down and say, this is what the case is. These are the facts. You don't dispute the facts generally if you're going to do one of these consent agreements. And then you come to terms with the board. Generally, there's a fine associated. There might be a reprimand. There might be a letter of concern. They might recommend community service. They might require you take CME or provide CME. They might say, gosh, we're not sure that you've kept your skills up. You need to go to Florida Cares, or you need to go to CPEP, or you need to go to PACE and get evaluated. And once we hear from them, we'll decide what we want to do. They might say you have substance abuse issues and you need to go to PRN, and it's not an option. They can impose fines. They can be as high as $10,000 per event. A wrong site surgery and their tolerance for none generally gets wrong site surgery to be a $10,000 fine. And if you have multiple counts against you, every count could get you a fine. Because once they get a complaint, they come to your office and try and figure out what's going on. And if it was one thing, it could be other things. And they may look at multiple charts and how you run your office and inspect your office. And then that's another can of worms. You may get assessed costs, whatever they had to do, whatever the expense was, you'll get that. Then you're going to have your attorney costs. and then you're going to have the emotional and personal costs. So we want to keep you out of the hairs of the Board of Medicine. It is draining. These things don't happen quickly. There are cases at the Board of Medicine that have been out there since 2015. This isn't like a 6-month process. It's long. So you want to make sure that this is not something we get you involved in. The Board of Medicine has the statutory requirements for discipline. They can suspend your license. All of these things are allowable for them to do, and they will, depending on what it is. Very often you'll see somebody who has a medical care count against you, and then they find out you have illegible medical records. You get a second count because they can't read your medical records, and then you dispensed medications the way you shouldn't have. Maybe you were over-prescribing, and you'll get a count for that. So it's complicated, and it can turn into be a big ordeal. They've been busy. This is the third quarter MQA report on what they've been doing. They did 1,300, almost 1,400 investigations in the quarter. They issued 77 emergency orders of suspension. Now remember, the MQA is for all the boards. So this isn't just medicine, it's all the board. The acupuncture board, the massage board, they do all of those licenses. Common issues before the board: fraud. Medicare fraud is a big thing. Every time you go to the Board of Medicine, there's at least 2 or 3 people who have pled guilty to federal charges of Medicare fraud. I'll show you the list that I pulled for the meeting today, and I think there's 4 who have pled guilty to Medicare fraud. Sexual misconduct. This is more common than you would think. Substance abuse. There's a fair amount of substance abuse among medical providers, a lot of recidivism, and so you see these cases come up quite frequently. Then there's the whole medical care aspect. Those come up quite a lot, and we see those. We don't see this as much as we used to because a lot of the pill mills are gone, but pain management without appropriate processes or training. The standards for practicing pain management are you need a fellowship. And if you're kind of grandfathered yourself in, you better make sure that your practice works like a pain management practice should. The days of writing a simple chart, if you're not getting contracts with your patients, you are setting yourself up for losing your license. I've had more than one provider at Florida Cares who said, well, I thought I was doing the right thing because nobody else would prescribe for them, for this patient. But the problem was they took these patients on and they never went back and said, is there really something to treat here? They never went back and said, what's the source of the pain? Is there some other way to treat this other than opioids? And that's where they get in trouble. Just continuing to prescribe hundreds and hundreds of pills a month to a patient will get your license suspended. The patients that we see, the clients that we see in Florida Cares very often are office-based practice only. They don't have hospital privileges. They're not board certified. We see a lot of practitioners who've changed their scope of practice. I had a general surgeon that we saw, again, this was in the pill mill days, probably 5 or 6 years ago, and he decided he was going to do pain management. He learned very quickly that was not the practice he wanted to do. The whole issue of aesthetics and cosmetics is now a lot of what we're seeing. Family practice physicians who are doing liposuctions in their office having gone to a weekend course. And when the plastic surgeon interviewed him as a peer reviewer, he didn't get interviewed by a family practitioner, he got interviewed by a plastic surgeon. And he called me up on the phone and he said, Eileen, he doesn't even know the layers of the skin. Was not a good report. GYNs didn't want to deliver babies, decided she was going to do liposuction. This is emergency license suspensions and revocations from the Florida Board of Medicine from January 22 to 8/22. This is stuff you can pull off the internet. It's not super secret or anything. You can see, I could have put licenses and names and I didn't, but you can see entered guilty plea for conspiracy to dispense and distribute controlled substances is the first two. Failure to pay a civil judgment in a malpractice case, license suspended. General practitioner doing GYN procedures with terrible mortality, morbidity cases, emergency suspension, and actually he ended up having his license revoked. Somebody who pled guilty to wire fraud, bank fraud, and healthcare fraud, license revoked, and somebody practicing pain management, license revoked. So that's just in the last 8 months in the state of Florida. So these things do happen. If you belong to a multi-specialty group and your multi-specialty group has a surgery center and your name's on that surgery center, please, 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 please make sure you understand what your name is attached to and that your practice is on the game, that they have a person managing that who knows all the rules and regulations and can keep you safe. As they said in the previous one, you have to have all sorts of stuff stocked in that office. Probably about 10 years ago, I was at the Board of Medicine meeting and I looked down at the agenda and 5 of my favorite cardiologists in my community practice were on the board agenda. And I thought, oh my God, what have these guys done? They had an outpatient cath lab. The inspector came for a routine inspection and their epinephrine and their atropine was out of date. And they all got cited because they were all on the list. So make sure that the process and procedures for the surgery center are being complied to the letter of the law, that you have someone who knows all the rules and regs. It's not that you can't have one, and I'm not trying to scare you, but you guys are very good. I've worked with physicians my entire career. You're very good at signing things, aren't you? Here, doc, sign this. Here, doc, sign that. You're very good at it. Make sure you know what you're signing. Make sure you know, and make sure you have. There's all sorts of things to be in office surgery. You need to make sure that everybody who's supposed to be doing procedures is doing them. What levels of surgery? What does that entail? These are all the documents for a surgery center, and I don't want you to read them. I'm just pointing out it's complicated, and make sure you have an expert. This isn't something for a high school graduate to be your surgery center manager. You want somebody who has the experience and the risk management savvy to keep you protected. Do these documents look familiar? They won't, probably, because you don't work at the UF Health Shands Hospital. These are mine. These are cardiology privilege forms and medical staff bylaws. How many of you have read your medical staff bylaws in the last year? In the last 5 years? Please, if you do nothing in the next month, when you've got 5 minutes of downtime, which you never do, pull out the current staff bylaws and just run through them. You're being held to them every day. And what I hate to see is a provider who has issues with the hospital and then they don't understand what the process is going through and they feel like the hospital's gunning for them. And we're all old enough to know if somebody wants to get you, they can get you, right? None of us are perfect, and anybody can get you for something. We've all made mistakes. Make sure you know what your hospital privileges are. Make sure they're accurate. Make sure you know what your staff bylaws. If you're supposed to be at a meeting once a quarter, you need to make sure, because it's okay as long as you're okay. But when you're not okay, that's when they'll pull out the fact that you never came to a medical staff meeting. Does that make sense? I'm not trying to be Debbie Downer here. I just want to protect you. So make sure, go pull those staff rules and make sure you understand them. Credentialing and appointment, make sure that everything is accurate. This is becoming a little bit more of an issue because we have lots more procedures that people do. If you're recently out of training, and most of you probably look a little bit older than that, but if you're going into your first job at 2 years, this is your first 2-year program you had to go to. Most of you are well seasoned beyond that. They do call our fellowship program and make sure that you've done what you say you did so you could get privileges. And we've had a former trainee in our institution have a lawsuit with a competitor because they said they didn't have the skills to do something they were advertising that they could do. And it got back to they had to pull out the records and see how many of those kinds of cases somebody had done. Make sure you understand what your privileges are. Losing privileges is not as hard as you think it is. And so you just need to make sure you understand what they are. And again, you're okay till you're not okay. When applying for privileges, make sure you over-report rather than under-report. You are held to a different standard than a lot of us. You are physicians. You are the caretaker of humanity. They expect that you have good judgment, that you conduct yourself in a professional manner in your private and your personal life. And as was said previously, when you get that DUI, you have to report it. And then the board says, gosh, doc, do you drink and go to work? Taking care of my mother? Do you get angry and get in fist fights and have public altercations? And do you have anger management at work? You have to report those things. And they hold you to a different standard. You need to maintain your license to be current. Make sure that you are doing the procedure number that you need to keep those privileges. This becomes a bigger issue as the groups get bigger. Do you have enough cases to maintain your competency? There are minimums across subspecialties. And I don't want somebody working on me who the last time they did that case was like a year ago. I want somebody who did 10 last week. So make sure you keep your skills up. If you learn a new skill, you get training, make sure you update your privileges. This is something that you have to do. Do not rely on your office manager for anything related to your credentials, your licensure, anything like that. It is your responsibility, and the board doesn't care. If I heard a provider say, well, my office manager was supposed to do that, and they say, doctor, I'm sorry, that's not their responsibility, it's yours. So please own that. A little bit about professionalism. Physicians often don't report physicians who are incompetent or impaired. A survey, this is an old survey in 2007. I pulled this out to be cardiology because I was giving cardiology grand rounds. About 2/3 did not report these events, which is amazing. So 67% of anesthesiologists reported a personal knowledge of an incompetent physician to a relevant authority, but most of us don't tend to report. When you asked people, did they agree that impaired colleagues should be reported, about 67% thought they should be reported. Okay. And only about 60% felt they were comfortable in reporting incompetent or impaired provider colleagues. A small percentage had the incidence of that they had that experience, and probably about 70% actually reported it. And when asked why, they thought somebody else was going to take care of it, or that nothing was going to happen, or there was retribution going to be associated with it. And I get it. but it's about doing the right thing. And this is why when we manage ourselves and the public gets wind of it, they get upset and they lose faith in us. The ultimate test, I have this conversation with my faculty all the time. There's this feeling that it's hard to get into medical school. Medical school's tough. Training's hard. And once you get in, you're in. You're in the brotherhood and the sisterhood. But there are people who get through medical school and residency and training who maybe shouldn't. And people are very reticent to say, not so much of a good provider. The ultimate test, if you're conflicted, is would I want my mother, my daughter, my granddaughter, my uncle, would I want anyone in my family to be taken care of by that provider? And if the answer is no, why in the world would you think it was okay for my family to be taking care of that person? And that's the ultimate in professionalism. It's not comfortable and it's not easy. I'm not saying it is, but we owe the public, the people that we have said do no harm. That's the ultimate in doing harm, sending people out who shouldn't be there. Peer review is important. If you're in a solo practice, this is in a difficult environment. You're working by yourself. There are some programs around the country that pull together peer review in a way, because it's hard when you're in solo practice and you're competing against other groups. You don't want to show your foibles or your flaws, right? And you don't want to have them have some ammunition to go against you. So I can understand why people in private practice, solo practice, don't do it. There are some programs around the country. We need a healthy workforce. This 2022 survey of physician suicide, there were about 13,000 participants. And obviously it's a little biased, but 10% of those reported thinking about suicide. It's been a very stressful decade for providers. Many do not reach out for help. 24% of the providers surveyed say they had clinical depression. These were the suicidal thoughts broken down by specialty. The highest was pathology, general surgery, oncology, emergency medicine. Again, it's biased because these are the people that answered. And how do they keep healthy? Spending time with family and friends, doing activities. Many of you are so focused on being great providers that you let the profession suck the life out of you. And we have a really increasing suicide rate, and we don't want that to continue. So please take care of yourselves. We're in the home stretch. We're going to finish up here. I forgot to change my slide. I add one every time I give a talk. So top 14 tips. You're good doctors. We want to keep you. We want to keep you out of trouble. First of all, take care of yourself. The institution is going to be there whether you're there or not, and they don't care. Your family cares, your loved ones. We tend to put them off and say, well, they'll be there when I get home. Sometimes they're not there when you get home, and that's why the divorce rate is high. So spend the time with your family and friends. That's what's really important in life. Suicide rate is increasing. Substance abuse among providers is very common. Anesthesiologists have a lot of access to drugs. They're a really at high risk group. Make sure you've got that support of family and friends. Get outside interests so that when you're ready to retire, you have something else that you love and that you want to do, and it's easy to walk away and have another 10 or 20 years of goodness in your life. Take time to recharge and refresh. PRN is available. It's confidential. It does not affect your license as long as you are compliant with the program. They run a hard ship. They make sure you are or try as hard as they can to make you successful. I would suggest that each of you, sometime in the next 6 to 9 months, take a 2-hour block for yourselves. Turn off your phone, take a calendar, and take a look at your life and say, what am I spending my time on? What's important to me? What's sucking the life out of me? and think about saying no to some things and focusing on the things that will bring you joy. And do that every 6 months, and your priorities are going to change. And you might find that you have no time now because you've allowed it to be absorbed by things you don't really care about and you don't need to be concerned about. The things I cared about when I was 25 or 30 are not so important to me now. And so doing this assessment allows you some opportunity to change your life. If it seems too good to be true, it probably is. You guys have the unique ability to be medical directors of everything. Make sure that what you are going to be medical director is not going to get you into trouble. Make sure that if it is a business model, you understand exactly what is being done, because they are very likely to bill under your provider number and do all sorts of stuff. And if you are not intimately involved in the business, this is where you get in trouble. This is where you get sucked into Medicare fraud. This is where you get sucked into some kind of care that's not allowable. Please make sure Medicare fraud is the highest target in the Department of Justice. They are going out after Medicare fraud like nobody's business. Please protect your license and make sure. Again, if you get a letter from the Board of Medicine, get a good healthcare attorney, not your cousin Vinny. Do not represent yourself. I can't say this enough times. Do not represent yourself. If you have an office surgery setting, make sure you know the rules. Make sure they're following the rules. It's your license on the line. You'll get called into the Board of Medicine whether you've been involved or not. If you move, this was mentioned before, make sure that you keep it active so that you get any communication that you need. How many of you have a license in more than one state? Keep every license active. And if you have something happen, let's say for instance, there's a RIPR or an FMA party tonight, and you have a little too much to drink, and you are not staying here, you live in Orlando, you drive home, you get pulled over and you blow and you get a DUI, God forbid. You are required to report that to the Florida Board of Medicine. You are required to report that to every state you have a license in. Because what happens is you report it to the Florida Board of Medicine. The Florida Board of Medicine reports it to North Carolina where you trained and you still have your license active. And they say, why didn't you report it to us? And then you get a fine from North Carolina. That holds it up. And then the other state you have a license is sees the Florida, the North Carolina, and why didn't you report it to us? I call this the license death spiral. You can have multiple state licenses. You just need to make sure you keep them all current and that you report to absolutely everybody. I have seen doctors at the Board of Medicine almost in tears because they say, well, it happened here. Well, but doctor, you didn't report in North Carolina, and now you have a sanction against your North Carolina license. And we can't clear that. Well, but it was a Florida problem. Well, now you have to clear North Carolina. So please make sure you keep your licenses all straight. Pre-approve any advertisement for your services. If you don't think the people across town are reading your ad and their marketing people are reading your ad, you're naive. They are. People put that they're board certified when they're not board certified, and they report you to the Board of Medicine saying, Dr. Jones says he's a board certified vascular surgeon. He is, but by this really weird board that exists in South America, and it's not an approved board, and it's on the billboard on I-75. So make sure that your advertisements are accurate because somebody will notice. Electronic medical records are the thing, right? They date stamp everything. You can't go back in and put something in that didn't happen when it happened, right? You have to do an addendum because every time you enter into the electronic health record, there's a timestamp on that. So the days of going back and fixing something are gone. So just remember that. And it's really a billing record. It's not really a very good patient care record. It's because the hospital wants to get all the money they can for all the things that you do. And so how many of your electronic health records are template driven? Review of systems, physical exam, right? When we review records in Florida Cares, I'm not shocked anymore, but it's always the case where the chief complaint, the review of systems, the physical exam, none of them match because they're all templates. So the patient comes in with a complaint, the review of systems doesn't match because it's all templated, and nobody bothered to edit the review of systems to make it accurate for the visit. And I can't tell you how many times I've taken care of a patient and said, gosh, you're the first person who has listened to my carotids in a year. And I'm thinking, I bet that medical record says they did a full exam. Carotids, no bruit, right? It's on the template. So if you have a physical exam finding that matches a review of systems that matches the chief complaint, you better be editing your record. That kind of stuff will get you in trouble. They're quick and the billers love it because you've done everything you could possibly do with 3 clicks, and they can bill out the door and make lots of money. But what you care about is what that looks like in a court of law, or to pass on to the next provider so that it's accurate. And we know, I hate reading other people's medical records because it's all template. I liked it when we all scribbled. At least I knew what you thought. Now all I get is everything copied, and it's an 8-page note, but it doesn't say anything, right? It's craziness. That's why people are writing on glass doors. You're right. You do have to report office incident reports. Make sure everybody that you hire is licensed the way you think they are. It's not hard to check. You do not want unlicensed providers. They are looking for that. A lot of that in South Florida right now, people practicing as physicians who are not physicians, and other providers. Happens more with massage therapists, go figure, but please don't hire people that are unlicensed. CE broker, they're out there. And so you need to record everything on CE broker. You need to make sure you do your CME requirements. Again, this is not something to leave to the office manager. Never prescribe to yourself. It's a short walk to the Board of Medicine. Do not prescribe to yourself. Every institution can have a different policy about whether you can treat family and friends. Not friends, but family. So just make sure our institution has some specific requirements around that. Yours may or may not. What he said earlier about creating a medical record for family, friends is extremely important. The divorce rate is 50%. I couldn't get 20 years out of 2, okay? I don't know about the rest of you. Couldn't get 20 years out of 2. So my spouse then is not my spouse, and they don't always stay friendly. So if you provide care, you need to write a note and make sure that it can be brief, but please make a record. You should not be treating your neighbors. You should not be treating the office staff unless you're going to make a note of the record. What happens if and it can be simple and well-intentioned. The nurse says, gosh, I'm congested. I think you've got sinusitis. And you say, okay, I'll write you a Z-Pack. What if they have an anaphylactic reaction to the Z-Pack and you didn't ask them what their allergies were? Now, they may not have known it, but it won't make any difference in a court of law. You prescribed something without doing a complete history and physical that pertain to what you were doing, prescribing. So protect yourselves. You got to do the surgery in the right space. That's all there is to it. This happens a lot in neurosurgery, spine surgery, where you said you were going to do, 1 and 2 and you ended up doing the repair in 3 and 4. And then the patient doesn't feel better. They go back and look at the x-rays. They look at the follow-up x-rays, and what you said you were going to do is not what you ended up doing. So this happens more than you would think. No sex with patients. The board has zero tolerance. You have a relationship. It is not a consensual relationship. I was at the Board of Medicine meeting, and the board said to this physician, "Now let me get this straight, sir. You're telling me that you did the office visit in the strip club? These notes you wrote while you were sitting at the bar? Is that what you want to tell me, Dr. Smith?" Yeah. Well, he lost his license. It happens more than you would think. There's not a good way to, there's lots of literature about how to have met someone who you take care of and then to dissolve that relationship and then go on to have a relationship, and different specialties have sort of societal recommendations. So if you're thinking that's what you want to do, you should probably look in your specialty and see if there's some guidance around that, and make sure that you do that, because again, you can be in love now and you can not be in love in a year. And then if somebody was vindictive enough, they could go back and say, well, I was his patient. I was her patient. So I hate to be cynical about that, but you see it more than you know. So this is you at the end. I'm going to leave 6 minutes. Any questions? Sure.
Relating what you were just discussing with no sex with patients, I think that the last part of that is ever, because former patients are patients. You cannot safely, reasonably say, well, no, I discharged this person from my service, then began a relationship. It's going to get you just as hot water as you were in the episode. So just say no.
I agree, but when you're in love and your hormones are talking over your brain, it's hard to do. And I don't disagree with you, but it is much more common. And I would say if you're in the psychiatry field, you'll never have a leg to stand on ever, for sure, because they are so vulnerable. But yes, ma'am. Sure. So the question for those that are streaming, her comment was an observation that because we're tend to be practicing defensive medicine, radiology reports are a little bit nebulous because they want to put the onus on the provider to verify that something may or may not be right. So we're ordering more tests or more referrals. And is that deleterious to patients having to get further workup? I don't think anybody's looked at that. I think until we get better at getting better diagnoses, this is always going to be an issue because we tend to missing is bigger issue than what you're talking about. And so I think it will always sort of be the focus, but I don't know that anybody's ever looked at it. I've never seen any data around that. So I want to thank everybody. I know this was 2 hours of your life you cannot get back. So hopefully you have some tips that are practical that you can take back into your practice on Monday. I applaud you for being providers. I thank you for your service to the public and to the community, and wish you a happy summer and good health. Thank you.
So our final speaker of the day is Dr. David Koo, who's going to discuss controlled substance prescribing. He's done this before. It was quite enjoyable, so I'm sure you're in for a treat. Dr. Koo is currently a hospitalist at Florida Hospital Waterman, and he is on the faculty at the University of Central Florida College of Medicine. He was awarded Teacher of the Year in 2011, 12, and 13, and I think that we'll find out why. Dr. Koo.
Hello, can you all hear me? All righty. Well, welcome to the Florida mandatory opioid CME. Who here prescribes opioids routinely? Most people. I assume everybody here is trying to fulfill their 2-hour mandatory requirement for Florida. Is that true? Yep, most people here. Yes, there's nothing, as a presenter, there's nothing more rewarding than being the last person to present a 2-hour lecture for everybody that is forced to be here. So we will continue. Okay. I have nothing to disclose. Nobody wants to pay me anything, especially since I usually use generic medications. I need to probably switch that. So we're talking about pain management and the landscape of pain management. And for those of us who have been practicing for a while, I've been practicing for almost 25 years now, we've seen that the landscape of pain management has changed very dramatically, right? Back in the 90s, it was the war against pain. In fact, pain was often described as like the 5th vital signs. And doctors, and we were doing crazy things like prescribing oxycodone, 200 milligrams BID, and the pendulum has swung the other direction. And now it seems like we are in a war, not against pain, but against drugs. And honestly, we can see why, right? In one study, it's estimated about 25% of people prescribed opioids misuse them. Since 1999, about 760,000 people have died just in the US alone from drug overdoses. And just in 2021, there have been 92,000 opioid deaths. Now, if we trend this over the last 3 years, what we'll see is that this trend has been rising some. In 2019, there were 51,000 deaths. 2020, 70,000. 2021, 92,000. And if we look at all causes of deaths in just 2021, we'll see that overdose deaths, is nowhere near heart disease, cancer, or even COVID. But the number of overdose deaths is more than all the deaths from pneumonia and motor vehicle accidents combined. So it's still actually quite significant. On average, that means that there are approximately 252 deaths per day from overdoses in just the United States. And it's estimated that over the next 10 years, there's going to be about 500,000 deaths. And what's interesting is that if you actually break down the opioid deaths, and this is covering a 20-year span, so going all the way back from 1999 all the way up to 2020, what we'll see is that the vast majority of opioid deaths is actually from this blue line that goes all the way up. And what that is illicit fentanyl use. This is not prescribed fentanyl. This is illicit fentanyl that is obtained on the streets. This orange line is actually prescription opioids. And as we see, the number of deaths from prescription opioids in general has remained fairly steady from 2011. What's also interesting is if you look at this gray line here, the deaths from this gray line, which is actually stimulants like methamphetamine, have gone up significantly, as well as the deaths from this other blue line, which is from cocaine. Okay, But if you look at just prescription opioids, it's remained relatively steady. If you look at where does all this illicit fentanyl comes from and its precursor, this data is actually from the Drug Enforcement Agency. Most of it comes from China, and it comes into the United States from China. What's interesting is that the precursors used to make fentanyl is not illegal to transport from one country to another. And so maybe better laws are needed. Now, going back to deaths just from prescription opioid use, what we'll see is that the number of deaths, again, since 2011 have remained relatively stable. There was a jump in 2020, probably related to COVID too, but it has remained relatively stable. But we shouldn't be complacent about this. Actually, let's talk about this. So in terms of the number of prescriptions dispensed by U.S. pharmacy, since 2011, the number of opioid prescriptions have steadily declined. Now, we shouldn't be complacent about all this because 4 out of 5 new heroin users started out misusing prescription painkillers. So in a lot of ways, prescription painkillers for many patients is a way they get into the illicit stuff, which tends to be significantly cheaper than prescription medications. Okay, so in this lecture, we're going to go through 3 separate things. First, we're going to review HB 21 and what that means. We're going to review another legislation called HB 451. And finally, we'll review the CDC guidelines for treating chronic pain. All right, HB 21. In 2018, then Governor Rick Scott signed HB 21 into the law, and it was a big piece of legislation. There were 205 pages in it, and it aimed to combat opioid abuse in Florida. It targeted both prescribers and dispensers, and its main purpose is try to reduce the number of inappropriate prescriptions by providers, mainly. And what it definitely did is it did 3 things. It increased the amount of regulation, what we need to do, the amount of training, and that's basically this right now. There's required a 2-hour mandatory opiate training for all opiate prescribers every 2 years, and the amount of documentation that we have to do. This is whenever we prescribe controlled substances or if they're dispensed. Now, HB 21 actually dictates standard of care to various regulatory boards. It tells us how to evaluate the patients, how to create and maintain a treatment plan, how to obtain informed consent, when and how to review our treatment plan, and compliance with controlled substances law. And failure to follow the guidelines can result in disciplinary action. So just as an example, so this is taken from page 13 out of 205. It says the complete medical history and physical examination, including history of drug abuse and dependence, we need to document. We need to document the diagnostic therapeutic laboratory results, evaluations and consultations that the patient has had, what the treatment objectives are, discussion of risk and benefits, treatment, what our current treatment is going to be, and we have to list all the medications, date, type, dosage, quantity, and also instructions and agreements. So it's actually pretty comprehensive. So the question for us is, how do we distill 205 pages of legislation into something practical that we can follow? And so far, and this lecture is going to focus on that. But before we do that, let's talk about some just quick disclaimers. You know, summarizing all 205 pages into 30 slides really is not possible. Part of the laws are very clear, but part of the laws are medieval and vague. And we'll talk about those parts of the law. And so determining how to interpret this and how to apply it will be up to every single board. So these slides are my effort to interpret the law and distill them into something practical. But remember, the board may interpret them a little bit different. So refer to the board for any question. Mainly, the whole point of these 2 slides is just don't kill the messenger. That's it. I should have just skipped everything, just said don't kill the messenger. And that's the main point. All right, so to distill this law into bullet points, this is the main thing, okay? HB 21 basically says that there's a 3-day limit on Schedule 2 opioids for the treatment of acute pain. A 3-day limit. Now we can extend that to a 7-day limit by doing something called an exemption, which I'll talk about. The second thing is that HB 21 dictates that we need to prescribe an opioid antagonist in certain situations, and we'll talk about that too. And finally, and probably most importantly, it tells us that we need to consult the database, the drug database, before prescribing most controlled substances every time, okay? So let's talk about this in a little bit more detail. First, how does HB 21, how does it define acute pain? Acute pain is the normal predicted psychological and time-limited response to an adverse chemical, thermal, mechanical stimulus associated with surgery, trauma, or acute illness. Sounds pretty reasonable. Sounds pretty reasonable to me. Now, this definition does not include cancer. That makes sense. Cancer would not fit into acute pain. It does not include a terminal condition, somebody with less than 1 year of life expectancy, or palliative care to provide relief for symptoms related to an incurable or progressive illness. Unfortunately, HB 21 also includes this as part of the acute pain. It does not include serious traumatic injury with an injury severity score of greater or equal to 9. And we'll talk about why HB 21 does this. Okay, so let's talk about the 3-day limit for the treatment of acute pain with a Schedule 2 opioid, okay? So HB 21 says you have to limit to 3 days, but you can increase it to 7 days if you believe it's medically necessary. Now you have to write the words acute pain exception on the prescription, and in the chart you have to document the acute medical condition and the lack of alternative therapy that justifies a deviation from a 3-day limit. So you have to document medical necessity, acute medical condition, and lack of alternative. You have to write the words acute pain exception on the prescription, and then you can extend your Schedule 2 opioids from 3 to up to 7 days. Okay, so here's what my recommendation is. Take a picture of this slide and make a template for your EMR program, and then you'll meet pretty much most of the documentation requirements. For instance, patient is having significant pain caused by hip fracture, which will last more than 3 days. Trial of Tylenol has not helped. I believe it is medically necessary to treat the patient's pain because it is affecting her ability to sleep or something like that. And that should meet your documentation requirements for HB 21 in the chart. Remember, you still have to write the words acute pain exception on the prescription though, okay? Okay, let's go through some question and answers and see if we can answer some difficult issues that may come up. So there are many causes of acute pain that last more than 7 days. Severe shingles. Who's had severe shingles on a patient and had to treat them for like a month, right? It lasts more than 7 days. What do I do for these patients? And HB 21 basically states that they have to return for a follow-up in 7 days for a new prescription, okay? When this patient with shingles sees me in 7 days, do I have to document everything all over again? Of course, because it's the hard thing to do. So you have to do it all over again. So if you prescribe more than 3 days of a Schedule 2 opioid, yes, unfortunately, you have to redocument everything, write acute pain exception on the prescription, and recheck the PDMP, okay? What about patients with subacute pain? So subacute pain is pain that is defined as more than 4 weeks, but less than 12 weeks. Chronic pain is after 12 weeks. So what about these patients? Well, the good news is that the board believes that subacute pain can be listed as non-acute pain, so you don't have the 7-day limit for that, okay? So you can write for more than 7 days for subacute pain. Now, can I do all my documentation on the prescription? So this is my question, because I'm trying to find the laziest thing I can do to meet all the requirements. So can I write all this just on the prescription, not even have to bother with the chart? Acute pain exception, severe mononucleosis, not relieved by NSAIDs. And unfortunately, I asked the board folks and they said no. So they shot my idea down. It did not work. You still have to do the medical necessity, medical condition, and lack of alternatives on the chart. And on the prescription, you have to write acute pain exception. And this is to extend it up to 7 days. Okay, now what about for treatment of pain other than acute pain? For example, you want to treat chronic pain, or again, we talked about subacute pain. So if you're going to treat non-acute pain, pain other than acute pain, you have to write non-acute pain on the prescription if you want to prescribe a Schedule II opioid. So let's do more question and answers. What happens if I forget to document acute pain exception or non-acute pain on my prescription? The answer is if you're prescribing more than 3 days of an Schedule II opioid, the pharmacy will give you the dreaded phone call, and then they'll follow their policies and protocols, which probably means you have to redo the prescription over again. Okay, so let's talk about this. So what are Schedule II opioids? Just as a quick reminder. So common Schedule II opioids, we all know what they are, right? There's oxycodone, fentanyl, hydromorphone, which is also Dilaudid, and morphine. And since 2014, the DEA reclassified hydrocodone, which I believe used to be a Schedule III opioid, as a Schedule II opioid. So pretty much all the common medications that we use to prescribe for pain, hydrocodone, oxycodone, morphine, Dilaudid, and fentanyl are Scheduled II opioids. The only Schedule III opioid that I know of is Tylenol with codeine, and it still remains a Schedule III opioid, okay? So basically, your Tylenol number 1, your Tylenol number 2, your Tylenol number 3, and your Tylenol number 4, those are the only Schedule III opioids left. Now, Tylenol number 1 has 7.5 milligrams of codeine, number 2 has 15 milligrams, number 3 has 30 milligrams, number 4 has 60 milligrams. Here's my recommendation. Forget all of them except for number 3. And the reason I say that is because if you try to prescribe anything else except Tylenol number 3, you're going to get a call back from the pharmacy because they don't stock it. And you're just going to waste a lot of time, and it's going to cause a lot of frustration. So just mainly prescribe Tylenol number 3. Now, how strong is Tylenol number 3? Is it effective? How does it compare to Percocet? How does it compare to Lortab or hydrocodone products? And if you convert Tylenol number 3 into its morphine equivalents, it's about equivalent to 4.5 milligrams of morphine. That's not bad. Tramadol, believe it or not, is equivalent to 5 milligrams of morphine. Hydrocodone at 5 milligrams, which is basically your Lortab or Norco, has also is equivalent to 5 milligrams of morphine. And oxycodone at 5 milligrams, which is your Percocet at 5 milligrams, is equal to 7.5 milligrams of morphine. So it's pretty comparable. So if you want an alternative and not have to deal with any of that documentation hassle and prescribe pain medications up to 30 days without the hassle, you can just prescribe Tylenol number 3. Now, you still have to do the PDMP. Look in the PDMP, the prescription drug monitoring program for each patient, but you don't have to do the documentation hassles, okay? Since HB 2021 has come out, the number of prescriptions for Tylenol number 3 has probably skyrocketed. I'm pretty sure. I should have bought stock in Tylenol number 3, except that it's generic. Okay. So does that mean that I can't write refills for hydrocodone products? Remember, hydrocodone is Schedule number 2. Can you write refills for Schedule 2 products? No, you can't. Right. So you cannot write refills for Schedule 2 controlled substances, but for Schedule 3 products like Tylenol number 3 or for all your benzos, you can write refills. So for Schedule 2 prescriptions, a new prescription needs to be generated every single time. So again, to clarify, Tylenol number 3 is a Schedule 3 opioid, does that mean I can write for more than 7 days to treat acute pain without having to do all the HB21 documentation? And that's true, correct? But just remember, you still need to check the PDMP. Now, what common benzodiazepines such as alprazolam, clonazepam, diazepam, lorazepam have their schedule classification been changed? And no, they're still considered Schedule 4. I'm sorry, you're Schedule 4, not 3. But remember, you still have to check the PDMP. Now, what about tramadol? What's the schedule for tramadol? Tramadol is still considered Schedule 4, but because it's still a controlled substance, remember, you still have to check the PDMP. But probably more important, just remember that tramadol will lower the seizure threshold for your patient. So anyone who has prescribed enough tramadol will have caused 1 or 2 of their patients in their lifetime to have a seizure. Who's seen seizures with tramadol in their patients? Okay, a few patients, right? So if your patient is taking an SSRI or SNRI, which will lower the seizure threshold, you know, maybe Tylenol number 3 for short term is a better drug than the tramadol. HB21 requires, so here's another rule that we need to talk about. HB21 requires the prescriber to co-prescribe an opioid antagonist, so like naloxone, when prescribing a Schedule 2 controlled substances for pain related to traumatic injury and an injury severity score of greater or equal to 9, okay? And this honestly makes absolutely no sense. Where did this requirement for an opioid antagonist come from? Is it part of some emergency medicine or pain medicine guideline? Not that I know of, okay? Is if a patient meets the criteria for co-prescription of an opioid antagonist, do I still need to adhere to the 7-day limit for acute pain? So if the patient meets the criteria for co-prescription of an opioid antagonist, then most likely you can write for more than 7 days of an opioid, but not more than 14 days. So this is probably why they decided to put this contingency into effect. So if you have somebody with an acute pain, and it's pretty severe where their injury severity score is pretty high, you can technically write for more than 7 days, up to 14 days, if you prescribe an opioid antagonist. So question, my patient has an injury severity score of greater than equal to 9, a traumatic injury, and I'm prescribing a Schedule 2 opioid for 10 days. What do I document on the prescription? So if you remember, HB21 excluded traumatic injuries with an injury severity score of greater or equal to 9 from the definition of acute pain. So you would actually write non-acute pain on the prescriptions for these patients if you're prescribing for more than 7 days. Honestly, if you're prescribing for up to 7 days or less, I don't know that I would go through all this. I think I would just document the medical necessity, the alternatives, and all that stuff, and not have to deal with all this. Okay, so this doesn't make any logical sense. A traumatic injury sounds like acute pain to me. Yep, it doesn't make any sense. I hear you. So what are some possible strategies? So here's what I would do. This is actually a reasonably good chart to explain, to summarize HB21. Listen, if you're only prescribing for up to 3 days of a Schedule 2 opioid, then you don't have to document anything on the prescription, all right? It's the only tricky part is between 3 and 7 days. Between 3 and 7 days, you either have to document acute pain exception, and then you have to do all that documentation stuff, or you document non-acute pain. In other words, the patient has chronic pain, subacute pain, or they have that, acute pain with an injury severity score of greater than equal to 9. Now, after 7 days, your only option is to document non-acute pain. In other words, it's most likely a chronic pain or a subacute pain. So what is an injury severity score? I never heard of it. How do I calculate it? So unless you work in an urgent care, you probably would never have to do it, but there are good calculators that are available online. Just go to www.medcalc.com. There's a lot of different calculators that you can use. Now, what if the patient only fills a prescription for the opioid, but not the antagonist? As a provider, am I somehow in trouble with the board? And the answer is, honestly, what the patient does with their prescription is up to them. These prescriptions for opioid antagonists are extremely expensive and most likely are not covered by insurance. So really, it's not the provider's responsibility. But I don't even know how to teach my patients how to use naloxone auto-injector or the nasal spray. How do I learn? YouTube. You can do anything in YouTube. I replaced my garbage disposal on YouTube. I added a new outlet to my house with YouTube. Who teaches their patients how to use albuterol in the office? Anybody? Okay, a few of you. YouTube. You play the YouTube video, you walk out of the room, see another patient, you come back, and then you document that you taught them how to use the albuterol. All right. I'm an ER doc. A lady fell off the bike and broke her wrist and lacerated her tongue. All I want to do is prescribe a few doses of hydrocodone for 3 days. Do I really need to write an opioid antagonist? According to my calculations, her ISS score is 9. Since she meets all the criteria, yes, you are required, according to HB 21, to prescribe an opioid antagonist. But that's insane. It's just low-dose hydrocodone. It's only for 3 days. When I treat painful tonsillitis, why don't I need to write an opioid antagonist for the same strength hydrocodone? Now, for this slide, I actually looked online for cricket sounds, and it went cheep, 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 cheep. But we do not have the technology to play that for you today, so I apologize. Yes, pregnant silence. All right. So no, there's goofy things about this law that don't make any sense, but politicians. Okay. So the final thing of HB 21 is that a prescriber or dispenser must consult the Prescription Drug Monitoring Program to review a patient's controlled substance dispensing history before prescribing or dispensing a controlled substance for a patient age 16 or older. But HB 375, which was a bill that came out afterwards, does exempt us from having to check the PDMP if the patient is admitted to hospice. So that's nice. All right, so how do you sign up for the Florida PDMP? By now, most of us should already be signed up, but if you're new to Florida, you can sign up by going to this website. Do I really have to check the PDMP before every single prescription for Lortab, 1 tablet, PO, QHS number 30 for Grandma Jones for her rheumatoid arthritis? Her PDMP has been unremarkable for the last 4 years. I check it every 6 months. She even makes brownies for the staff. It really depends on what's in her brownies. But yes, according to HB 21, you need to check it before every single time, regardless of her brownie making status. You should do a drug screen on her brownies, though, just say. Do I really have to access the PDMP even for ADHD stimulants like Adderall? Yes, if it is a controlled substance and the patient is 16 years or older, you have to check it. The only exception is for certain Schedule 5 non-opioid controlled substances such as pregabalin, or as most of us know it as Lyrica. Okay, I'm currently doing telemedicine. Can I prescribe opioids or controlled substances via telemedicine? Short answer is no. But there are certain provisions and very unique circumstances which none of you and I would probably fall into, but I'll let you read that. Okay, how do I document my PDMP compliance? The nice thing is that most of us have EMR programs that automatically document it for us. But HB 21 actually doesn't specify the if you actually go to the eForce website, it will actually automatically document it for you. But to cover yourself, I probably would write something on the chart. Who has an EMR that automatically documents it for them when they check it? Okay, maybe it's only me. Never mind. All right. But I would document it in the chart just to protect yourself. Can I incorporate the PDMP into the EMR, and will it make my life easier and more seamless? Yes, it will. Who will pay for it? Yes, you can. Florida, unfortunately, is not one of the states that will pay for it. So look to your company to see if they could set that up. What if the PDMP is down? What do I do? If you cannot access the PDMP because of the technological or electrical failure, you must document that in the chart, and only 3-day supply of a controlled substance can be given. What? My legitimate chronic pain patient has to come back in 3 days because the government website is down? How is that fair? I didn't make up the rules. Don't kill the messenger who said life is fair. All right. What if I forget to access the PDMP because things just got extremely crazy and stressful in the office? It happens. Answer, the Department of Health may issue a non-disciplinary citation for the initial offense. Each subsequent offense is subject to disciplinary action. Work, does anyone care? And all I can say is I care. I really do. As a provider who has been up and down the burnout spectrum for the last 25 years, I do feel your pain. Let me just give you a few recommendations, and this has nothing to do with pain management, I suppose, but it's fun. So during COVID, one thing I did was I went back to my childhood hobbies. Anybody ever make model rockets from Estes when they were a kid? So I went back to my childhood hobby. I 3D printed this N1 moon rocket. This is a Russian moon rocket, and I shot it off in the air. And most of my launches were historically accurate, which means that they blew up, but it was still fun, and it was a great stress relief. These are some of the other rockets that I made. That last one is actually a squid rocket. I have shot every single one of these rockets off except for the squid rocket, which I am 100% sure is going to crash and burn, but I'm still going to shoot it off. I just have to wait for a non-dry season so that it doesn't burn up a whole field.
So let's talk about HB 451. HB 451 was signed into law by Governor Ron DeSantis in 2019, and basically what this requires is that it requires the Department of Health to make an educational pamphlet on non-opioid alternatives to treating pain. And it requires us to discuss non-opioid alternatives to provide prescribing Schedule 2. And a lot of you probably are already aware of it. If you want to download it, you can go to this website and download it, credit, and consultations, and then you'll be compliant with this piece of legislation. Okay, so
how does this affect us? We have to inform patients of non-opioid alternatives. We need to discuss the advantages and disadvantages of non-opioid therapy, including if the patient is at risk for controlled substance abuse and misuse. And we need to provide them with the Department of Health pamphlet. And finally, we need to document all this in the medical record. So my recommendation for you is make another macro and make it look something like this. You know, the risk of opioid therapy including but not limited to addiction, medication misuse, overdose, tolerance, respiratory depression, falls, permanent disability, and death were discussed with the patient. Alternatives such as Tylenol, NSAIDs, ice, stretching, and home exercises were discussed. The patient agreed to proceed and verbalized understanding. The Department of Health non-opioid alternative pamphlet was provided to the patient. Go ahead and just take a picture of this, make a macro, and then just provide the pamphlet to your patient. Okay. And now, who is exempt from HB 451? So those providing emergency services and care are exempt from this regulation, but unfortunately, hospice and urgent care providers are not typically exempt. Okay, let's go through a few case studies, and then we'll talk about our last bit on chronic management of chronic pain. So, question, all of the following pain medications are classified as Schedule II opioids, except for A, hydrocodone, B, oxycodone, C, codeine, or Tylenol number 3, or D, tramadol, or E, both C and D. What do you think? E, yes, you are correct. Both codeine and tramadol are not Schedule II medications. True or false? When prescribing any Schedule II opioids, for any length of time, HB 21 specifies that providers must document the medical necessity acute medical condition, and lack of alternatives in the chart. Is this true or false? It is false, right? And the reason why it is false is because you only have to do that documentation if you extend a prescription from 3 days to 4 to 7 days. If it's less than 3 days, you don't have to do all this documentation in the chart. 22-year-old female presents with severe exudative tonsillitis. Ibuprofen has not been helping for the pain, and you want to prescribe a 3-day supply of hydrocodone, acetaminophen, 5 milligram, 325, 1 tablet every 6 hours as needed for pain. What does HB 21 now require of the prescriber? Okay, so 3 days. It is a Schedule II opioid. And what are the requirements? A, nothing, since the opioid prescribed is 3 days or less. B, check the PDMP before writing prescription. D, document medical necessity, acute pain condition, and lack of alternatives. Then check the PDMP. Or D, write acute pain exception on the prescription. I heard some B's. So the answer is, in fact, believe it or not, I know a lot of people are saying C, but the answer is B. And the reason is because it's only for 3 days. So you don't have to do all this documentation. All you have to do is check the PDMP. So the answer for this is, thankfully, just B. Okay. Okay, true or false? HB 21 only requires that the prescriber check the PDMP if the Schedule II opioid, if a Schedule II opioid is prescribed. False, right? It's any controlled substance, except for maybe Lyrica. All right. 12-year-old patient with ADHD presents for refills of her Adderall, which is true regarding checking the PDMP. A, the PDMP needs to be checked regardless of the patient's age. B, only if they're 21 years or older. C, 18 years or older. D, 16 years or older. Or E, PDMP does not need to be checked for Adderall. D, excellent. All right. 77-year-old male with end-stage multiple myeloma, I'm thinking, except my ugly face is covering it, is admitted to home hospice. You prescribe probably Percocet PRN. What is the current law regarding checking the PDMP for this patient? A, the PDMP does not need to be checked for hospice patient. B, PDMP only needs to be checked with initial hospice admission. C, PDMP needs to be checked with Schedule II opioid prescriptions only. D, PDMP requirements are the same as non-hospice patients. A, correct. PDMP does not need to be checked for hospice patients. You're a hospitalist who is treating a 75-year-old male for infected stage 3 sacral decubitus ulcer that has been going on for 5 weeks. So that 5 weeks is important. His pain is under control except for severe pain during his dressing changes, which require oxycodone once a day. So not a lot of oxycodone. At discharge, what is likely the best course of action? A, I don't know there's a right answer here, but this is what I would do. A, give a 3-day supply of oxycodone, then check the PDMP. B, give a 7-day supply, document medical necessity, acute medical condition, and lack of alternatives in the chart, then write acute pain exception on the script, then check the PDMP. Or C, give a 14-day supply, document non-acute pain on the prescription, then check the PDMP. C, I hear a lot of C. I would do C. Honestly, you could do any of them. They're all logistically correct, but I think C makes the most sense clinically since this patient has, it's been going on for more than 5 weeks. So this is subacute pain. All right. So C. 44-year-old male takes Ambien, 5 milligrams PO before bed for insomnia. You prescribe a prescription for Ambien number 30 with 2 refills. It's hidden by my ugly face again. Okay, so a number 30 with 2 refills. When must the PDMP be checked? A, before the initial prescription and with every refill. Or B, with initial prescription only. Or C, with every refill, but not the initial prescription. Or D, Ambien is not a Schedule II opioid and therefore the PDMP does not need to be checked. Okay, that's wrong, right? We already established that. E, only when the urine drug screen is being administered. Okay, I hear a lot of B and A's. I love your enthusiasm, and the answer, thankfully, is only B. Because you gave number 30 with 2 refills, you know, you don't really exactly know when the patient's even going to refill those medications. They may fill it a day early, a day late, 2 days late. So there's no actual requirement for us to check the PDMP with their refills. So if you give number 30 and 2 refills and you say, follow up with me in 3 months, yeah, at that 3-month time, you're going to have to. So this question could have been worded better. According to HB 21, how often should you perform the urine drug testing? A, 1 month, 3 months, 6 months, 12 months, or E, HB 21 does not specify, refer to CDC or DEA guidelines? It is E, yeah, it doesn't specify. I would do it at least every 12 months, so at the minimum. According to HB 21, how often should you follow up with your chronic pain patients? Every 30 days, every 2 months, every 4 months? HB 21 does not specify, but not to exceed 3 months. It is, in fact, D. Yes, it is D. It doesn't specify. Okay, what is true regarding the following, regarding tramadol and the risk of seizures? So what is true regarding tramadol and the risk of seizures? A, seizure risk with tramadol appears to be dose dependent. B, the risk of seizure is worse if tramadol is taken with other medications that lower seizure threshold. C, consider alternatives in patients with seizure history. Or D, total daily dose should not exceed 400 milligrams. Or E, all of the above. E, all of the above. Very good. Okay, you guys are good. Okay, so last stretch. Let's talk about the CDC guidelines from treating chronic pain. So we've been focusing mostly on acute pain. So let's talk about the CDC guidelines for the treatment of chronic pain. So when the CDC first came out with their recommendations in 2016, they put out this statement that said, in summary, evidence of long-term opioid therapy for chronic pain out of life care remains limited, with insufficient evidence to determine long-term benefits versus no opioid therapy. Now, after this statement was made, there were a lot of people who misunderstood this statement to mean that compared to placebo, there was no benefit. That's not the case. That's not what the CDC is saying. What the CDC is saying is, based on their criteria, their search criteria for research studies, they couldn't find a single study to meet their inclusion criteria for their paper. That's what they meant. So it doesn't mean that long-term opioids have no effect. It's just that they could find no studies to meet their criteria. Now, are there going to be studies that are going to be done in the future? It's highly unlikely. It's highly unlikely that drug companies are going to sponsor it, because that's not going to help them with their sales. And it's highly unlikely that the government is going to do anything about it either, because the goal right now, in terms of the government and the way the pendulum is spinning and turning, is already towards less opioid use. Now, from this lecture, it may seem like I'm against the use of chronic opioids for chronic pain, but actually my philosophy is a balanced approach. I think there are times where the use of chronic opioid in very specific situations can be helpful for patients, and we just have to approach it clinically. So this is a 2016 guideline for prescribing opioids for chronic pain. And in 2016, the American Academy of Family Practice gave it its affirmation of value, but it didn't completely endorse the documentation, mainly because of this. The CDC basically gave everything a category A recommendation. Basically, they're saying that these 12 recommendations should apply to everybody. And this is despite the fact that most of the evidence that they use for their recommendations had significant limitations, important limitations, or several major limitations with the data. So they were using basically type 3 evidences and type 4 evidences. But you know what? I think that's okay. So here's an example. So the first recommendation by the CDC is try use of non-pharmacological therapy and non-opioid therapy first for chronic pain before you prescribe opioids. And they give it a category A recommendation. In other words, everybody should follow this, even though the evidence for supporting this was only a level 3. And the way the CDC justified this was saying, consistent with the ACIP and grade process, category A recommendations were made even with type 3 and 4 evidences when there was broad agreement that the advantages of clinical action greatly outweighed the disadvantages based on consideration of benefits and harms, values and preferences, and resource allocations. In other words, okay, here's what they mean. Imagine that you had a patient coming to see you because of chronic headaches. And imagine that the reason that they're having chronic headaches is because they are whacking their head against the wall, right? So your recommendation to them is what? Stop whacking your head against the wall. Now, are there placebo-controlled randomized studies to prove that that's a good recommendation? No. Is that a reasonable recommendation to give a guy who's whacking his head against the wall? Yeah, so the CDC is basically saying that. A lot of these recommendations are kind of like, stop whacking your head against the wall. And yeah, we don't have type 1 level evidence, but these are probably self-evident. Another one of these things is ventilator use. I don't know if you know this, but there are no good randomized placebo-controlled studies that showed ventilators are a good thing to use on people in respiratory failure. Who would want to enroll in that study, right? Right. So that's another one of those things that doesn't have placebo-controlled randomized studies. Okay. So the CDC basically gave 12 recommendations, and we're going to go through them pretty quickly. Number 1 is maximize the use of non-opioid therapy. Number 2 is establish realistic treatment goals. And number 3 is discuss the risk of opioids. Okay, so let's talk about this very quickly. Now, the treatment of pain should be multimodal. What do I mean by that? We need to treat any underlying mood disorders. So for those of us who've ever tried to treat chronic pain and the patient was exceedingly depressed or anxious, we know it is nearly impossible to control their pain. So treat any underlying mood disorder. Consider physical therapy, exercise programs, water aerobics for osteoarthritis of the hips and knees. Consider cognitive behavioral therapy. Cognitive behavioral therapy works wonders for many things, and it's proven by great evidences, especially for things like obsessive compulsive disorder, but unfortunately, insurances don't cover it very well. Intra-articular glucocorticoid or trigger point injections, you can consider epidural steroids injection for chronic radicular low back pain. The data for epidural steroids, believe it or not, is not that great. It's not that robust, although it seems to be common practice. But if it helps the patient, it probably won't hurt them. TENS units also have pretty poor data to support them in the use of low back pain. But you know what? I don't care. If a patient rubs their stomach and rubs their head, and for some reason that makes them feel better and it helps with their pain, I'm all for it. Chiropractor has been shown to help with some pain conditions, as does acupuncture. So maximize the use of non-opioid therapies. Now, what about Tylenol versus NSAID? Which is better? Now, for chronic low back pain, both are equally effective. Now, typically we think that NSAIDs are more effective, but the truth is, if you look at the studies, both are pretty equally effective. For non-low back pain, NSAIDs might be slightly more effective than Tylenol, but NSAIDs also have significantly more side effects, mostly GI side effects. COX-2 inhibitors have less side effects, but like NSAIDs, they can have cardiovascular risks, such as strokes and heart attacks. Just especially be careful of using NSAIDs in our older patients. And also limit acetaminophen use to less than 4 grams, maybe even 3 grams per day. Okay, so what about neuropathic pain? In other words, numb pain or sciatic pain. Examples include diabetic neuropathy, postherpetic neuralgia, stroke, lumbar radiculopathy. First line for these would be gabapentin, pregabalin, which is your Lyrica, or tricyclic antidepressants. And then second line would be duloxetine, which is Cymbalta, or venlafaxine. Just remember, the venlafaxine would be considered an off-label use. Note again that gabapentin, although we use it frequently to treat lumbar radiculopathy, supporting data for it is limited. Gabapentin has very, very few FDA-approved indications. Almost everything that you see gabapentin used for is off-label, including diabetic neuropathy. Gabapentin is off-label for diabetic neuropathy. It is its on-label use is as an adjunct for seizure and for post-herpetic neuralgias. And I've been actually trying to limit my gabapentin use because its side effect profile is not that great, including weight gain and significant sedation and fall risk. Nociceptive pain. So basically pain that's not neuropathic is labeled as nociceptive pain. That's everything else. You can treat it also with acetaminophen and NSAIDs. Consider topical NSAIDs. Have a local pharmacy mix it for you. You can use duloxetine or Cymbalta to treat fibromyalgia, chronic low back pain, and chronic musculoskeletal pain. And it is somewhat better than placebo, but its effect was very small. It was less than a 1-point improvement on a scale of 1 to 10 in their pain and functional scale with duloxetine. So am I going to use Cymbalta as first line for treatment of chronic pain? No, but as an adjunct for someone who's depressed or anxious, I think it's quite reasonable. Nortriptyline, you can also use for treating nociceptive pain. Normally, we think of using tricyclic antidepressants for treating neuropathic pain, but it can be used off-label. There's some data to support its use. Just tell the patients it's an off-label use, though. Other adjuvant medications, topical 5% lidocaine patch or gel. And if the 5% lidocaine gel is too expensive, you know what's a cheap alternative you can get over the counter? Anybody? Vagisil. Vagisil is just topical anesthetic. I probably would make my wife get it for me, but it is a topical anesthetic. Capsaicin cream, it is basically hot sauce that you can apply to your skin. The only problem with capsaicin cream is a couple things. Number one, it probably takes up to a month to 6 weeks before you'll see effects. So you just have to be consistent with it. It can cause burning, stinging, and erythema. So obviously you do not want to apply it to sensitive skin. You can get this over the counter too. Now, muscle relaxers. Muscle relaxers are useful for acute pain, but honestly, for the treatment of chronic pain, the data does not seem to show a lot of benefit. But if I had a patient who is on Flexeril 10 milligrams before bed, and they've been on it for years, and they say that it helps them with their pain, they're probably mostly using it to sleep. But if they say that it helps them with their pain, am I going to stop it? No, I'm not going to stop it. Just talk about the risks and benefits and then just go on. Okay, so the next thing is before initiating chronic opioid therapy, what we want to do is we want to maximize the use of opioids, of non-opioids, and we want to establish realistic treatment goals. So let's talk about that. And let's also discuss what we should tell patients about the risk of opioids, okay? So before prescribing chronic opioids, we have to establish candidacy. So not everybody who comes to our office with chronic pain is a good candidate for opioid therapy. In fact, I would suggest that probably most patients are not good candidates. So for instance, have they tried a trial of non-opioid therapy and it's not helped? What is the diagnosis causing their pain? Did we do a thorough history and physical? For instance, irritable bowel syndrome, fibromyalgia, migraine headaches, these conditions are probably not good candidates for chronic opioid therapy. Well, what about low back pain and abnormal MRIs? Let's talk about that. So if you look at many different studies, disc herniations and spinal stenosis is seen in up to 67% and 21% of asymptomatic patients over age 60, right? Okay, in other words, if you get MRIs on perfectly healthy people over age 60, almost 70% of them will have an abnormal MRI. And these are people with no pain, throwing frisbee with their grandchildren and doing perfectly fine, right? In fact, MRIs typically correlate extremely poorly with symptoms. MRIs are one of the most useless tests to get for low back pain. Unless you're looking for something very specific, like a occult fracture that's difficult to see on a radiograph, if you're looking for an abscess, if you're looking for demyelinating process, if you're looking for a cancer or tumor, unless you're looking for some very specific things, MRIs are one of the most useless tests, or if they have significant radiculopathy that's obvious on clinical exam. Outside of those things, it's almost a completely useless test to get because it's going to be abnormal in the majority of the patients that you get it. In fact, in individuals between 40 to 80 years of age, about 60% had facet joint osteoarthritis with absolutely no correlation to low back pain. So the bottom line is many asymptomatic people will have abnormal MRIs. And so the question is, are we going to start chronic opioid therapy on everyone with low back pain and an abnormal MRI? And the answer is obviously no. In fact, abnormal MRIs and low back pain is one of the biggest snake oil scams in modern medicine today. A doctor can make amazing amount of money and can do an amazing amount of unethical things with abnormal MRIs and low back pain. Most doctors do not, but you can, and it's terrible. So here's what I do. I ask myself, is the patient having radicular symptoms? So if they are actually having a pinched nerve on the fourth lumbar spine, right, in the inner space, they should have a pain in a very specific area, tenderness over a very specific area, radiation of pain over the anterior thigh and leg, numbness down the anterior leg to the great toes, hypoalgesia here, decreased patellar tendon reflex, motor weakness and atrophy in the quadricep muscle. This is only if it's very advanced, but they should have very specific radicular symptoms. So here's my recommendation to you if you're a primary care doctor, or if you deal with this frequently, or if you're in an emergency room, get a radiculopathy chart. Get a radiculopathy chart that lists all the symptoms and physical findings that you should have with every lumbar interspace and try to correlate it with your patients. If it doesn't correlate, then they probably do not have radiculopathy. Often what happens is we'll have a patient who's having numbness down the left leg, but the MRI shows the pinched nerve on the right side. What the hell do you make of that? I don't know. Well, for sure, it doesn't correlate. Does that person need neurosurgery? No, that person does not need neurosurgery. Okay, so that's what I would do. So also, what are the patient's goals and expectations, right? If they expect that their pain is going to go from a 10 out of 10 down to a 2 out of 10, that's pretty unrealistic, right? So what are their goals and expectations? Are they realistic? If they say, well, doc, I just want to be able to sit through a movie without having to worry about my pain. All right, I can work with that. I can work with that. Now, do they have a previous history of addiction? Obviously, that's going to affect us if they are candidacy for us to prescribe opioids. What about compliance? Are they going to be able to take their medications as directed, not take it too often? What about home safety? Are there small children laying around? What about their age? You know, prescribing chronic opioids for patients elderly can significantly increase their risk of fall, and they will poop diamonds. It will make them constipated. So there are a lot of downsides to chronic opioids. Do they have comorbidities? If they have Alzheimer's or Parkinson's or something like that, it can sometimes make it significantly worse. Also, what are the results of the urine drug screen and the PDMP? Do they show any concerns? So before I even prescribe the very first prescription for any opioids, this is the list of stuff that I have to go through with every single patient. And also, Again, we have no solid evidence that long-term use of opioids improves pain or function, and complete pain relief is unlikely. And there's a potential for serious lifelong opioid use disorder. They can have withdrawal, physical dependence, intolerance. They can have fatal respiratory depression. It can cause severe constipation. It can affect their ability to drive their vehicle safely, and it can be a source of danger to other people in the home. Again, this is a lot of stuff to go over. And so here's what I do. To make my life simple, to go through all this stuff, I use a controlled medication agreement. Who uses one of these in their practice? Okay, so quite a few hands. So how often do you use controlled medication agreements? I would use it always with all your chronic controlled medication patients, because it protects you. Without it, it's just your word against the patient's words. Now, here's a sample controlled medication agreement that I've made, that we made for the residency. And let's just go through it very quickly. What does it say? It talks about that this medication will cause physical dependence. Now, does that mean that they're addicted to the medication? No, they're not addicted per se, but it will cause physical dependence at a high enough dose. Withdrawals will occur if it's at a high enough dose. Again, that doesn't mean that they're addicted, but withdrawals will occur if the medication is ceased abruptly. And they have to understand that we are under no obligation to taper the dose of controlled medications, especially if there's suspicion of diversion or illegal activity. Again, having this wording seriously protects you as a provider. Although rare, some patient may develop a psychological dependence. It talks about it may cause depressed breathing. It may impair their judgment and responsiveness, and can cause problems with driving. Although typically, if you titrate up very slowly, they should be okay. It tells the patient that they need to inform me of any traffic violations, that it may increase the risk of dizziness and falls, and that they need to discuss any new medications prescribed by other providers to ensure safety. It also talks about that I may and will measure their blood and breath alcohol if there's suspicions or concerns, that they cannot increase their medications on their own. So frequently, sometimes you'll have patients come in and say, oh, my pain was not under control, so I increased it. No, they're not allowed to increase it on their own. If the pain worsens or is not under good control, they need to make an appointment to discuss it with you. They understand that long-acting opioid medications should not be broken, cut, crushed, or chewed, because that's very dangerous. That changes the pharmacologics of the medications. They also talks about that when they're admitted to the hospital, what needs to be done. And it is a felony offense to receive controlled medications from multiple prescribers without the doctor's prior knowledge. And it's important for them to know that silence can be considered deception and therefore a felony offense also. And that they are not to take controlled medications from their Aunt Bessie. And regarding marijuana use, as if they're not to use illicit substances. And marijuana is, is in its own category. If they are using it medically, I think that's probably okay. I don't have a problem with that. They understand that refill of controlled medications can only occur at regular office hours. It can't be done just because they ran out early. It can't be done only as an emergency on Friday afternoons before the office is closed. And it will not be prescribed just simply to avoid withdrawal symptoms. Okay, they have to use the same pharmacy. They have to write their pharmacy here. And we may do a pill count from each visit. And in certain situations, we may ask them to come in for a random pill count and a urine drug screen. And we are under no obligation to compensate them financially for any adverse effects that may cause. That we are required and will do random urine drug screens, and they will not use prescribed or illicit drugs from somebody else. And if there's any concerns of diversion, the medication may be immediately terminated, and they will not be weaned with abnormal drug screened, and may not be given any further prescriptions. Okay, so it basically protects the prescriber significantly, and I would seriously try to do it with every single patient. Okay, So don't only use it, but read it. So this is the checklist I go through before prescribing chronic opioids. Did they do a trial of non-opioid therapy? Is the diagnosis appropriate? I have to review the records and imaging from other providers. I have to review their goals and expectations, their risk for addiction, compliance, home safety, check the urine drug screen, and review and sign a controlled medication agreement. So on that first visit, typically I make it a 30-minute visit because it's a long visit. And even in that visit, I do not prescribe a single controlled medication. I have to wait for the result of the urine drug screen, and I typically have them come back in a week. Okay. All right, so let's talk about the other recommendations quickly. When starting to prescribe chronic opioids for chronic pain, prescribe immediate release opioids instead of long-acting opioids. So and then also use the lowest effective dose. For the treatment of acute pain, use the lowest effective dose. We won't go over the treatment for acute pain much because we already talked about it. And then follow up in 1 to 4 weeks for after initiation or escalation of therapy. Okay, so let's talk about the medications we use for acute treatment of acute pain. So for treatment of acute pain, these are the immediate release medications. These are the extended release medications. So hydrocodone comes in 5, 7.5, and 10 milligrams of hydrocodone. Oxycodone comes in 5, 7.5, and 10 milligrams. This is your Percocet. Now, you can get also oxycodone alone without the Tylenol, and that comes in 5, 10, 15, 20, and 30 milligram strength. And the morphine comes in immediate acting strength orally at 15 and 30 milligrams. And the Dilaudid also comes in oral form at 2 and 4 and 8 milligrams. Again, the most common immediate acting opioids, Schedule II opioids, are these three. If you're prescribing an extended release medication, there's extended release oxycodone, which is the brand name is OxyContin, and comes in multiple strength. Morphine ER is MS-Contin, and hydromorphone does come, Dilaudid does come in an extended release formulation, but rarely anyone uses it. Fentanyl patches comes in multiple formulations, and I listed it there. So here's a reasonable starting strategy for your for immediate acting opioids, and this is a reasonable opioid progression for your opioid naive patients. So basically patients who have never been on any opioids. I would start with hydrocodone with acetaminophen at 5 milligrams and start it at twice a day or 3 times a day. Now, why not 4 times a day? I don't do 4 times a day because I'm trying to limit the number of pills kind of on the street or at home. Okay, so I typically stick with BID and 3 times a day dosing. And then I see them back in about a week to a month, usually a week. And then I increase the hydrocodone if it's still not, the pain is still not controlled, to 7.5 milligrams, and then see how that works. And then if I see them back in another week, and then if that's still not strong enough, then we go to 10 milligrams if needed. Now, once we've maxed out the hydrocodone at 10 milligrams 3 times a day, then I switch to Percocet, oxycodone at 5 milligram strength. And this makes sense because the oxycodone, if you look at the morphine milligram equivalence, is 50% stronger than hydrocodone, okay? And if you actually did the conversion, it makes sense. Then I see them back in a week to 4 weeks. And if it's still not in control, I increase it to 7.5 milligrams 3 times a day as needed. Then and then with every adjustment, I see them back in 1 to 4 weeks. The reason this is a good strategy is because the titration is actually quite slow. And it's actually quite reasonable thing that we can do even in a primary care setting, okay? So what about long-acting opioids? So I would start a long-acting opioids. Okay, so why do we start immediate acting opioids instead of long-acting opioids initially? Why do we do that? The reason is because long-acting opioids are 2 times more likely than immediate release opioids at unintentional overdoses. Okay, so that's why I never start a long-acting opioid for an opioid naive patient. In fact, methadone accounts for only a few percent of opioid prescriptions, but about 1/3 of all opioid deaths. And the greatest risk of overdose is usually within the first 2 weeks of starting therapy. And in 2014, the FDA changed the labeling for extended release or long-acting opioids to the following: reserve long-acting opioids for severe pain requiring around-the-clock treatment, and it should not be used on an as-needed basis for pain, and to be used when alternative treatment options such as immediate release opioids are ineffective. Okay. And FDA also recommends starting long-acting opioids only with those who are already tolerant to opioids, which is defined as having more than 7 days of the following. So do not use a long-acting opioid unless they've had 7 days of these medications and can tolerate it first. So either morphine 60 milligrams a day or more, 30 milligrams a day or more of oxycodone, 45 milligrams a day or more of hydrocodone, and 8 milligrams a day or more of hydromorphone, or greater or equal to 25 micrograms of transdermal fentanyl. Okay. Now, what about using short-acting opioids for breakthrough pain while also on long-acting opioids? Because this is something that we do a lot for the treatment of patients that are in hospice or are in palliative care. We use around-the-clock long-acting opioids, kind of like steroid inhalers for the treatment of asthma, right? You have your controller medication and your rescue medication. So long-acting opioids and short-acting opioids can be used in this manner, but typically we only use them for our cancer patients. But what about using them for non-cancer patients? Let me take a quick step back. So if you do have a cancer patient that you want to do this for, typically what you would do is you would dose you would typically use 5 to 15% of the total long-acting opioid dose every 4 hours for breakthrough pain using the same opioid, okay? So for example, if you are prescribing oxycodone 40 milligrams twice a day, so that's 80 milligrams of oxycodone per day, then you would dose the oxycodone immediate acting about 5 to 10 milligrams every 4 hours as needed for pain, because that's approximately 10% of the total daily dose. Does that make sense? Okay, I see head nodding, that's good. And then we would increase the long-acting opioid when the patient is typically using more than twice a day or 3 times a day of the immediate acting opioid for rescue. Then we would increase the long-acting opioid. So again, now what about outside of cancer pain? What about for non-cancer, non-palliative care pain? And again, there's no good safety data on the use of opioids in this manner. But the only problem is that using so much opioids does increase the risk of overdose as well as escalation of medication significantly. So what do? I do not do them together. So unless they have cancer or they're palliative care patients, I don't use long-acting and short-acting together for chronic pain patients. And I try to limit immediate reacting to 3 times a day at the most, and long-acting extended release to 2 times a day dosing. Again, these are not hard and fast rule, and research is lacking to support any particular dosing regimen. Okay. Now, what is the maximum dose of opioids that we should be using? Now, for palliative end-of-life care, there really is no definite maximum. The thing that limits us really is side effects. So mental clouding, constipation are the limiting factors. There's also risk of respiratory depression. Now, what about our non-palliative care patients? According to the CDC, we should try to keep our opioid use to less than 50 morphine milligram equivalents per day. And we need to justify our use if we're prescribing more than 90 morphine milligram equivalents per day, okay? So why is this? The reason is because opioid overdose risk increased in a very dose-dependent manner, which is obvious, right? So opioid doses from 50 to 100 morphine milligram equivalents per day had almost 5 times the risk of overdose. So that's why they want us to limit it to less than 50 morphine milligram equivalents per day. And opioid doses greater than 100 morphine milligram equivalents per day had up to 10 times the risk of overdose. And in the VA study, the mean overdose was, the mean opioid dose was almost 100 morphine milligram equivalents for overdoses causing death, compared to 48 morphine milligram equivalents for overdoses not causing death. So that's how the CDC justifies these numbers. So we've been talking a lot about morphine milligram equivalency. What does that mean? Basically, for all your opioids, you can convert them into the equivalent morphine equivalent so that you can compare them in terms of their efficacy and their strength. And all you have to do is use this conversion factor. So what you would do is you would multiply the opioid to convert it to morphine, and you would divide to convert morphine to the opioid. So let me give you some examples. So if you want to convert 2 milligrams of hydromorphone, so 2 milligrams of hydromorphone, if you want to convert that to morphine, you would multiply it by 4, so 2 times 4 is 8. So 2 milligrams of hydromorphone is equal to 8 milligrams of morphine. Or if you wanted to go the other way, convert it from morphine to something else. So let's say morphine to oxycodone. So here's oxycodone. Then you would divide the morphine. So 30 milligrams of morphine divided by 1.5 is equivalent to 20 milligrams of oxycodone. So again, 30 milligrams of morphine is equivalent to 20 milligrams of oxycodone. Does that make sense to everybody? Yes? Okay. All right. Now this is important because you need to get an estimate of what 50 morphine milligram equivalents looks like. So I actually calculated what that looks like for many common immediate reacting opioids. This is immediate reacting opioids. And 50 morphine milligram equivalents of hydrocodone is equal to 7.5 milligrams of Lortab, 2 tablets 3 times a day. Or your Percocet 10 milligram tablets, 1 tablet 3 times a day. Or your morphine immediate reactant 15 milligrams 3 times a day. Or your Dilaudid 4 milligrams 3 times a day. So just for your convenience, I converted it for you. They're all about 45 morphine milligram equivalents per day. Well, what does 50 morphine milligram equivalents per day of long-acting opioids looks like? And for oxycodone, your long-acting oxycodone or OxyContin, that would be 20 milligrams BID. For morphine ER, that'd be 30 milligrams twice a day. For fentanyl, that would be a 25 microgram patch every 72 hours. For those doing chronic pain management, this is not that high, right? I mean, for folks doing chronic pain management, it's not uncommon to see some folks on oxycodone 40 or even 80 milligrams twice a day if they've been titrated over years to those higher doses. So what does the 90 morphine milligram equivalents look like for extended release medication? So remember, the CDC says stay at less than 50, and if you're more than 90, you should justify its use. So for the long-acting, that's equal to 30 BID of oxycodone. For the long-acting morphine, that's 45 milligrams twice a day. For fentanyl, it's 37 microgram patch every 72 hours. So what are the pros and cons of these CDC limitations? Number one, the pro is that these guidelines help us limit endless escalation. You know, I think as primary care doctors or people who don't deal with pain management doctors, you know, they can have a line that's kind of way out there, right? They can have a line that's way out there in the sand. But for us, especially the primary care providers, we kind of have to draw a line in the sand that says, you know, after this dose, I don't feel comfortable in continuing to manage your chronic pain if it's not under control. And the nice thing about the CDC guidelines is it helps us draw those lines in the sand. So it gives us a line around 50 morphine milligram equivalents. And that's nice for us because there's somebody that helps backs us up. Another pro is these limits may reduce overdose risks and deaths. Another pro is, again, like we discussed, there's very little data to support doses greater than 50 morphine milligram equivalents in reducing pain in non-cancer palliative care end-of-life patients. What are the cons, though? The main cons is these recommendations may not provide adequate pain control for select patients who need higher dose, are reliable, and have real pathology. Okay, let's go through a sample case. 35-year-old male with a spinal cord injury from a paralysis, and he has a chronic sacral wound, presents for his refill of his oxycodone, of his OxyContin, which he takes 60 milligrams POBID. So he basically takes 120 morphine milligram equivalents. He is reliable, and attempts at weaning him over the last 3 years have been unsuccessful. Okay, and his dose has not been changed in the last 3 years. What would you advise? A, advise that there's little evidence that doses greater than 50 morphine milligram equivalents per day are effective. B, immediately decrease to 90 morphine milligram equivalents per day. C, slowly decrease to 50 morphine milligram equivalents per day over 3 months. D, warn of the risks of greater than 50 and keep at the same dose. Let's see, who would do A? Anybody? Who would do B? Who would do C? Who would do D? Yeah, okay. I probably would do D, honestly, in this situation. Or honestly, if you're not comfortable at this point, there's a line in the sand that's been drawn by the CDC. And if you're not comfortable, we could always refer to a pain management specialist. I don't know that any of these questions our answers are wrong per se, but I think for me, I think D seems to make the most sense. Okay, let's talk about opioid rotations. Basically, when and how do we switch from one opioid to another opioid? So try switching opioid when the side effect of the current dose, consider switching if there's side effects or if their current dose of opioid is not working and you are not comfortable with titrating up. Okay, so how do we do this? First of all, why does it work? The reason it works is because different patients metabolize opioids differently, and so one opioid may be more effective than another. To do this, we have to use our opioid equivalency table, which you just saw several slides ago. And then you have to decrease the dose by 25 to 50% because of unpredictable cross tolerance and metabolism. So you decrease the dose of 25 to 50%. And just know that the conversion of methadone and fentanyl has been beyond the scope of this lecture. And let's do a quick example. So let's say that you want to convert Dilaudid hydromorphone 8 milligrams 3 times a day to oxycodone, okay, with a 25% reduction because of incomplete cross tolerance and different metabolism in different people. So how do we do that? First, what is the total amount of hydromorphone this patient is taking in one day? So they're taking 8 milligrams 3 times a day. So they're taking 8 times 3, which is 24 milligrams a day total in one day of Dilaudid, right? So we want to convert Dilaudid to the morphine equivalents. So we find hydromorphone. So that's 24 total milligrams, multiply it by the conversion factor, and that means that it's equal to 96 milligrams of morphine. So this 24 milligrams of hydrocodone is equivalent to 96 milligrams of morphine. Now, we need to convert the morphine milligram equivalents to oxycodone, so we have to divide. So where's oxycodone? It's over here, and we have to use a 1.5 conversion factor. So because we're converting to morphine, I mean, the other way around, we have to divide. So we take 96 divided by 1.5, and that gives us 64 milligrams of oxycodone. Now remember, we have to reduce it by 25%. So that's 64 minus 16, which equals to 48 milligrams of oxycodone per day, or about 24 milligrams twice a day. So about 20 milligrams of oxycodone twice a day. Now, there are applications that can simplify this calculation for you very, very easily, but just make sure you double check them because messing up this calculation is very bad. Okay, so that's how you would do the conversion from one opioid to another if you wanted to try to switch. Okay, so final stretch. Let's talk about always evaluating for risk factors for opioids. Let's talk about reviewing the prescription drug monitoring program at least every 3 months. Actually, we won't talk about that much. We talked about it. The urine drug screen should be checked at least annually. Avoid giving opioids with benzos, and we'll talk briefly about opioid use disorder. So on every visit, here's what I do for an assessment of their pain, and it's called the PEG assessment scale, and it's very commonly used. It's just a simple handout that you give to the patient, and it asks, what number best describes your pain on average on a typical day? And it's either no pain or 10 is as bad as they can imagine. What number best describes during the past week how your pain interfered with your enjoyment of life? Again, either no pain or as bad as they can imagine. What number best describes how during the past week pain has affected your general activity? And then they fill it out. Now, obviously, if they're following up with you consistently, and this scale is not changing, and they're staying at 10 out of 10, at some point you got to talk to them about, this isn't really helping you. It's not improving your quality of life. It's not improving your activity level. It's not improving your pain. Should we even be continuing chronic opioids for you, right? Also, at every follow-up visit, we should assess risks. We should assess the following problems: nausea, dizziness, constipation, mental fogginess, traffic citations, fall, ER visits, use of alcohol, illicit substances, for a screen for opioid use disorders. Do they have any uncontrolled behavior? Are they running out of meds early? Any comorbid problems, anxiety, depression. And the easiest thing to do is probably just to use a pre-populated form and have the patient fill it out before every visit. Opioid-induced constipation can be very serious and require the need for manual disimpaction. I would make sure that you screen for it every visit. I treat every single patient on chronic opioids with prophylactic laxative therapy. I typically just use Senna 1 tablet before bed and then titrate it up to 2 tablets twice a day, and so that the patient is getting at least 1 good bowel movement every day. Obviously, you can use lactulose, you can use Miralax, and you can use bulking agents also. Now, you can also use subcutaneous methyl naltrexone and for very resistant cases, but this is an expensive medication, unfortunately, but it works well. Okay, tips on urine drug screen. Check the urine drug screen before initiating opioid therapy and at least annually. And what we're looking for is illicit substances. I don't prescribe that cocaine. And we're also looking for diversion. And make sure you document the exact date and time of when the last opioid was taken and what you expect on the urine drug screen. So for example, if the patient is late to their appointment and they're on immediate acting hydrocodone, and the last time they took it was 2 days ago, and they're a little shaky, document on your notes that you don't expect a urine drug screen to be positive for hydrocodone, so that you're not dealing with any surprises, right? Again, interpreting urine drug screens can be very complicated. Opioid screens can turn positive for morphine, codeine, and heroin, but not turn positive for synthetic agents such as fentanyl, methadone, and oxycodone. Many labs have specific screens specifically for oxycodone. Just know also that hydrocodone breaks down into hydromorphone. So if hydromorphone lights up, that may not be abnormal. Also, oxycodone breaks down into oxymorphone. So if you have results from your urine drug screen, my recommendation is talk with your toxicologist with any difficulties. Also, I would not dismiss any patients solely on the results of the urine drug screen. This would give us an opportunity, if this happens, this would give us an opportunity to talk about changing your strategy, weaning off opioids, increase visits, follow-up visits, refer for treatment of opioid use disorder, and in some situations, confirmatory testing for urine drug screens may be needed. If patient has repeatedly negative urine drug screens for opioid, then the opioid can be stopped without tapering. Again, discuss this with your toxicologist. Prescribing opioids with benzos is a big no-no, although unfortunately we often inherit a lot of those patients that are already on it, and it's very, very difficult to get these patients off, and I understand the challenges that you guys face. In a 2015 study, about half of the overdose deaths occurred when veterans took both benzos and opioids together, and there was a 4-time increased risk of death if they were both taken together. So what do we do about opiate overdoses? For patients that have had unintentional overdoses, reevaluate therapy, discuss risk and harms again, consider tapering down or off the opioids, consider giving them a naloxone auto-injector or the family member. In an observational study, it was shown that that was beneficial and decreased ER visits significantly. An opioid use disorder, this is the definition. And I'm not going to go through all of it here, but I supply it here for your reference to go into what the DSM-4 criteria for opioid use disorder is. And for treatment of opioid use disorder, the main thing I want to leave you is that methadone or buprenorphine has actually quite decent supporting evidence of their use for preventing relapse. Unfortunately, there's not enough treatment centers around. The main thing holding it back is lack of resources, costs, and poor insurance coverage. And you can do a search here to look for the nearest treatment center for you. And these are the final recommendations, and then we will stop. So number one, opioid therapy will test the clinical abilities of every clinician. It's not easy. Prescribing opioids, especially chronic opioids, is not easy. And for those clinicians that say, you know, I just don't want to do it, I totally understand. I get that. I get that. Just remember, read what's in your controlled medication agreement and use it every single time. Do not start opioid naive patients with long-acting opioids. Try to limit the dose of opioids for chronic pain patients to less than 50 morphine milligram equivalents per day. Justify the use for greater than 90 morphine milligram equivalents per day. Make sure you check your PDMP and the urine drug screen consistently for your patients, and understand the treatment resources for opioid use disorder. And that's about it. I'm going to go through a few case studies and then we'll be done. Patient presents with new onset severe, I think it's shingles. What is that game show where, do you remember back in the 90s, that game show where there were tiles and pictures that were like covering words and you had to get, never mind. All right, concentration, is that what it was? Okay, good. This is concentration. Okay, severe shingles that's causing 8 out of 10 around the clock pain, in addition to Lyrica, which is likely the best opioid to manage her pain. Now this is an opioid naive patient. A, methadone, B, morphine ER, C, oxycodone ER, D, oxycodone IR, or E, fentanyl patch. D, right, it's a short-acting opioid, right? We don't want to start long-acting opioid. Which of the following is considered an off-label use for gabapentin? A, chronic back pain and radiculopathy. C, adjunct pain for chronic pain. D, diabetic neuropathy. D, post-herpetic neuralgia, or E, A, B, and C. It is E, right? It is A, B, and C. The only indications is adjunct for seizure and post-herpetic neuralgia. Lyrica is FDA approved for which of the following? A, diabetic peripheral neuropathy. B, neuropathic pain with spinal cord injury. C, fibromyalgia. D, partial onset seizures, or E, all of the above. E. I hear more E's. The answer is, in fact, E. But if you guess the other ones, you're right too, because it's E. All right. Cymbalta is FDA approved for all the following except A, diabetic peripheral neuropathy, B, fibromyalgia, C, chronic musculoskeletal pain, D, depression and anxiety, or E, lumbar radiculopathy. The answer is, in fact, E, right. It is approved for diabetic neuropathy, fibromyalgia, chronic skeletal pain, and depression and anxiety. Okay, which of the following is false regarding Tylenol and NSAIDs? A, for chronic low back pain, both are equally effective. B, for non-low back pain, NSAIDs are slightly more effective. C, NSAIDs have significantly more side effects. So we're looking for false, remember. D, COX-2 have much less GI side effect and CV risk than NSAIDs. Or E, try to keep acetaminophen dose less than 4 grams per day. D, yes. And the reason D is because, yes, they do have less GI side effects, but they also have cardiovascular side effects. D. Which of the following is especially dangerous in overdose situations? A, Lyrica, B, Neurontin, C, Cymbalta, D, Prozac, or E, amitriptyline? E, who's ever seen a really bad case of a TCA overdose? They're really horrible. Yeah, answer is E. And which is probably another reason why I always prescribe the lowest dose of a tricyclic antidepressant whenever I prescribe it. So if you prescribe 10 milligrams of Nortab, if they take all 30, that's 300 milligrams. Some people are on 300 milligrams a day. They're probably not going to die, right? They'll sleep for 2 days, but they won't die probably. Of the following opioids, which likely has the highest risk of death in an overdose situation? A, oxycodone, B, hydromorphone, C, methadone, D, hydrocodone, or E, tramadol? C. Methadone has the highest risk for death. Thankfully, most PCPs are not comfortable with prescribing methadone, including myself. And another reason is because there's a lot of drug interactions with methadone, tremendous amount of drug interactions. Patient taking Percocet 5/325 milligrams PO 3 times a day for chronic pain. Which medication in conjunction significantly increases morbidity and mortality? A, Scalaxin, B, Ativan, C, Lyrica, D, Neurontin, or E, Zoloft? B, right. Try not to prescribe opioids and benzos together. So the answer is B. Patient takes oxycodone ER 20 milligrams BID as needed for pain. Her urine drug screen comes back. Okay, we're playing that game again. Her drug screen comes back probably with no opiates. Negative. It's negative. Comes back negative for opioids. She claims to have taken oxycodone about 4 hours before the urine drug screen. What is the best next step? Okay. A, dismiss patient from practice because of diversion. B, attempt to wean down oxycodone. C, call laboratory toxicologists to discuss findings. D, repeat urine drug screen in 1 week or repeat it in 4 weeks. C, I think the answer is C. The main reason is because oxycodone is a synthetic opioid, and so it may not come back positive for a simple opiate screen. You have to actually look for oxycodone specifically. I would discuss it with your toxicologist. C. And that's it. This is my son, and we went to a zoo in Georgia, and they have one of those drive-through zoos, but we should have known that something was really wrong when we got a towel that said I got slobbered on at the zoo. But it was incredibly fun, and I've never seen so much giggling from my son ever in my entire life. I would tell you the name of the zoo, but I forgot it. If you come afterwards, I'll try to look it up. I really appreciate the time. I know you guys are exhausted, but thank you for giving me the time to lecture. I hope that was helpful, and I hope I wasn't too goofy. I'll take a few questions.
first presentation this morning is going to cover the state mandated topic of domestic violence. There are actually individual topics that are required to be covered, and those will be covered by our two presenters. We have Suzanne Harrison. Dr. Harrison is currently retired from Florida State University College of Medicine. I'm sure she's very pleased about that. She's been very much involved in family medicine and rural health programs during her clinical career, and she's a frequent lecturer for the FMA on these topics. We also have Robin Thompson here, who is an attorney. Obviously, the interplay between attorneys and physicians is really important in this particular area. She's the executive director of the Survive and Thrive Advocacy Center, a nonprofit agency founded in 2015 to assist survivors of human trafficking. She's also an active member and co-chair of the Social Services Committee of the Big Bend Coalition Against Human Trafficking. So rather than take up any more of their time, I will leave the program to them, and I'll be back to help with the question and answer when we reach that point. Thank you.
Good morning, everyone. It's great to be with you again, and really wonderful to be presenting once more with my friend and colleague, Dr. Harrison. I'm Robin Thompson, and we are here today to talk about domestic violence. One of the things I do want to add to what Dr. Edwards said, and thank you very much, Doctor, for the introductions, is that I've also worked in this field of domestic violence for almost 30 years now in terms of public policy and advocacy. And that's who we are. That's more of who we are. You can see that we don't have any disclosures to report here, and that, as Dr. Edwards said, we do meet the requirements for the state of Florida licensure credits in this area. So, and Dr. Harrison, we're going to be doing what we call a tag team. We complete each other's sentences. We've done this a few times, so we'll be popping up and down. We look forward to your questions, by the way, at the end of the program.
Thank you, Robin. I'm so happy to be with you, all of you here today. I'm Suzanne Harrison, recently retired and very happy about that. And I just want to talk a little bit about why this is such an important topic. I know that it's state mandated by the state of Florida, but I think that as healthcare professionals, we are really the first to perhaps identify a victim who's been impacted by abuse in their lifetime. And really, in the context of a clinical encounter, we have a unique opportunity to develop a trusting relationship where they might actually disclose the details of their life and what's going on. So we need to trust that and realize that it's the gift that it is if a patient decides that they want to trust us enough to disclose what's going on. We also know from looking at the research and really combing over what happens when people do choose to disclose that we can have improved health outcomes if we know more about what's going on in a patient's life, and really better adherence to treatment plans, because then they become shared decision-making plans. And so that's really part of the reason that we think this is so important. So you want to do this?
Our learning objectives today, as mentioned, is exactly what the law requires us to do. So you get the credits. We're going to talk about what domestic violence is, or intimate partner violence is what we're going to refer to it more today. We'll talk about prevalence. We'll talk about the screening, what's expected of you in the healthcare setting, indicators, of course, the numerous impacts on a victim or survivor's health. We'll also talk about the laws, your responsibilities under the laws in terms of reporting and the like, other laws that are available and programs to help survivors. And we'll also talk about the resources. So what is domestic violence? One of the most important things to remember about domestic violence is that it is a pattern of assaultive and coercive activity. And as a lawyer, as a good lawyer, right, standing up here talking to you, I will talk to you a lot about some of the kind of drawbacks under the law. So the law looks